Good morning. It's really a great pleasure to see this room filled. And at the risk of being too informal, it's lovely to see many of you for the first time with your clothes on. So welcome. This is a joke that really only a GI doctor can tell. But my name is Swati Patel, and it's really special to welcome you all to this educational event on Lynch syndrome, particularly today, which is the cap off of Hereditary Cancer Awareness Week. And so it's a true honor on behalf of my course co-directors, Jessica Berman, Michelle Springer, Lisa Naxel, and Lisa Koo, to welcome you all. You will be hearing from all of us throughout the day. I will say that we are a bit disappointed that Jessica was unfortunately unable to join us today. She came down with a cold last night, but she's tuning in and is here with us in spirit. This conference, and many of you have already come and given us feedback on how wonderful the space is, how well it's organized. All of those things would not be possible without this outstanding University of Colorado Cancer Center team. Please give them a great thank you when you see them. Every small detail that's been attended to is because of the hard work of these individuals who really aren't necessarily paid to work on a Saturday, but are here because they support the mission of the University of Colorado Cancer Center and share our passion for cancer prevention and treatment. So if you see them, find them, congratulate them, maybe hand them a cup of coffee, they might need it. A very special thank you. This event would not be possible without the generous support of the Karen K. Wachtel Memorial Fund. This fund was established in honor of Karen K. Wangerud, and with the goal of really supporting educational events like this in genetics. We're really, really lucky to have Ken and Kira, Karen's family here. Ken and Kira, please stand up. We can't thank you enough for generating all of the support for this fund to really support this important event today. We also must thank all the experts that we have today, particularly those who have traveled from afar to be with us, including Dr. Patrick Lynch, who will be our keynote speaker. We have a series of speakers throughout the day on many topics related to Lynch syndrome. Again, we are very, very grateful and thankful for them to spend their Saturday with us. A really important theme throughout today is that this is about you. This is about patients, our community members. And because of this, we really emphasize the importance of the strong patient voice at the forefront. And hopefully you'll see that throughout the day today and feel comfortable and confident enough to be engaged in conversations throughout the day. We have multiple important patient advocacy organizations in this space who are here, including the Jacqueline Rush Foundation, Catch It in Time, Fight Colorectal Cancer, Connect My Variant, and the Colorectal Cancer Alliance, who, as nonprofit organizations, were able to still be here and provide us support to be able to have this event. And at lunchtime, we'll be hosting a very nice patient advocacy panel where we can all learn about what their organizations do and how to get involved if interested. We also have several corporate sponsors to thank. These are the really entities that we as clinicians partner with to deliver the highest quality care to our patients. For those who had coffee and breakfast, we have Grail to thank. This evening, this early afternoon, once we wrap up, we will have a nice cocktail reception on the rooftop, and hopefully the weather will clear up for us for some beautiful views of the mountains in downtown Denver, thanks to Ferring Pharmaceuticals. Also would like to thank our bronze level sponsors, Janssen Oncology, Medtronic, Myriad Genetics, and our pearl level sponsors, Cook Medical and Invitae. Please take the time to learn about these our organizations during the breaks, during lunchtime. If you have had polyps removed, go find out what tools are used to remove those polyps. If you're curious about how artificial intelligence works in colonoscopy, you can learn about all of that. Just a few housekeeping items. If there's any questions, issues that arise throughout the day, please find any one of us course directors, the Cancer Center team, and of course, their fearless leader, Ashley Boshovan, if you need any assistance with anything. If you do have a laptop or a device that you'd like to connect to Wi-Fi, there's an open guest Wi-Fi network, CU Anschutz guest. You just have to agree to the campus network policy and connect. Hopefully everyone used the parking code to park in the Vail, Snowmass, or Monte Vista lots. If you have any questions or issues around that, Ashley or someone from the team can help. Make sure, if you haven't already, to pick up your attendee bag. There's some helpful information in that bag, some paper if you would like to take notes, as well as QR codes that can lead you to our feedback survey, because we will want to hear from you on what you liked about the conference, what you'd like to see next time, if you'd like to see it next time. And then, of course, we're really, really pleased to share that all of the presentations today will be video recorded, and we plan to make these openly available to not only everyone who's registered for the conference, but our wider patient community. And so please stay tuned for more information on that. Once we have those videos organized and a place where they can be accessed, we will communicate that to the registrants, and you're free to share that with anyone in your friends or family or community that you would like to. So the symposium today is structured as such. We'll start with our keynote presentation, and then we have 3 sessions dedicated to kind of different domains. The first on our best practices in decreasing cancer risk in Lynch syndrome. The second, really focusing on how we can engage with our family, our community. And then the third session, really kind of looking at the most cutting edge treatments in Lynch syndrome cancers. For each session, the speakers will give their presentations in succession, and then we'll have ample time for a nice panel discussion where we really will encourage a lot of participation from you all. And to really spark that, what we'd like to do is use this audience response system. So I'd like to just take a pause here. Please take your smart device out. This is the time where it's not rude to take your cell phone out at the table. So take your cell phone out and go to your text messages. For the recipient number, put in the number 22333. So that's the number you're texting, 22333. And then in the body of the text, you'll learn how to spell Ashley's last name. So it's Ashley Boshovan 513. That's the body of the text. Dr. Lynch, I'd like you to do this too. Okay. So throughout the day, we'll have reminders on, what this code is, what the text message is, but once you do it once for the day, you don't need to do it again. And it'll just allow you to participate through the panel discussions and the sessions. So to start off, we'd just like to learn a little bit about each other, about who all is in this room. So we'll test this system out a little bit. Let's see if we can get this to project. Perfect. So let's, sure why it does that. So we're working out some of the projection issues, but it should still be able to capture your responses here in this mode. We just want to learn about what brings you to the symposium. You have Lynch syndrome, you can enter A. If it's a family member who has Lynch syndrome, enter B. Take care of individuals or do research, do advocacy work, part of industry, or some other draw to this symposium. So we can all see that the vast majority of individuals in this room are individuals affected by Lynch syndrome. So I thank you all for being here. And hopefully we all take away something that can advance your life, your care, and your family. So a follow-up question for those of you who do have Lynch syndrome, 65% or so in the audience, if you do have Lynch syndrome, do you know which genetic change you have? Is it MLH1, MSH2, MSH6, PMS2? Not sure, something different? There's some whispering, probably some conferencing going on among family members. That's perfectly acceptable. This is an open book test. So this is really insightful to know. Of course, these are de-identified and we don't know who's entering these responses, but just as we contextualize what we learned today about Lynch syndrome, and although it's been caused sort of, or called a collective entity for a very long time, we'll learn that perhaps the issues that these genotypes deal with are just a little bit different, and our approach to taking care of individuals with these different genetic changes is customizing and personalizing over time. So we can go ahead and go back to the presentation format. So the format of the presentations are such, and again, I'll remind you that during the lunch, we invite everyone to grab their lunch and return if they'd like to for a really outstanding set of panelists that will talk about their patient advocacy organizations and how to get involved if interested. As I mentioned, we crave your feedback. This is the first time we're hosting this event. We'd like to learn from you as to whether it's worthwhile, whether you would like us to organize such events in the future, what topics you would like to see covered. This QR code will be displayed throughout the day. It's also on the printed agenda in your bag and the notes pages in your bag, and will be emailed to you. So, you know, please be honest and open with us because we organize this for you. So with that, it is my true honor to introduce our keynote lecturer for today. We're very, very grateful that Dr. Patrick Lynch has traveled. In fact, he travels all over the world, so we're a stop on one of his worldwide tour. But he's traveled here from Houston, Texas, to be with us. He's a professor of medicine. He tells us that he's a citizen now because he's recently retired, but he's a professor of medicine at the University of Texas, MD Anderson, where he essentially started the hereditary cancer program there from inception to the powerhouse internationally recognized program that it is today. He's a world-renowned expert in hereditary GI cancer syndromes, polyposis, as well as Lynch syndrome. And we're really, really honored to have him give us a grand overview of the past, the present, and the future of Lynch syndrome. Dr. Lynch, thank you so much for being here.
All right, well, thanks. It's wonderful to be here. I actually have a few preliminary comments. Let's see, where's this one forward to it? Oh, here we are. Okay, so yeah. So I just retired about a year ago after being at MD Anderson for 34 years. You know, I love patient conferences. I think this is about the third or fourth one I've been to. We hosted one at MD Anderson some years ago. And as I was sitting here having breakfast, I was kind of reflecting a little bit on what it all means. You know, you all have a problem based on the comments about having a mutation in the MLH1 or MSH2 gene. And this has been, is, and will be an issue in your family for many, many generations. And that's just a fact of life for you. But at institutions, doctors come and go, researchers come and go. And so I think one of the important things at an institutional level is to develop a sense of continuity as well. So this conference is part of a series that are sort of built around a memorial to Dennis Annan, who was a dear friend of mine, a GI many of you I'm sure knew very well, took care of you. But we were old friends, and Dennis very much recognized many years ago, long before he fell ill, the importance of continuity in a program that deals with patient problems that require long-term management. And it was for that reason that he mentored Swati and others to eventually take his place. And I've been visiting with her and her colleagues over the last few days. I've been it's been very heartwarming to me to see how Swati is already mentoring a new generation of colleagues who will be here in years to come to take care of you and members of your family and others like it. And so I have strived very hard. In fact, I was just talking to a colleague of mine from Italy that we're in the process of recruiting to MD Anderson, because I was not really satisfied with my so-called succession plan at MD Anderson. So I'm pretty happy about that. So although I come from MD Anderson in Texas, I actually have unusually deep Colorado roots. My mom was born here. She was a nursing cadet at the university during the war. She met and married my father here in Denver. We were up here earlier in the week to bury her ashes. She died 11 years ago, but we're just now getting around to burying her ashes up in Longmont, where my grandparents and great-grandparents are buried. So, that my great-grandfather homesteaded on what was a sugar beet farm, which is now, unfortunately, underneath part of the freeway that goes out to the airport. So we don't have that farm in the family anymore. I'll be taking kind of a historical perspective today on what I call HNPCC. I don't use the term Lynch syndrome. That's a very long story. But as many of you know, my dad, Henry Lynch, really did a lot of pioneering work in this field, and I can't give a talk without alluding a little bit to some of his work. And we worked together off and on for a number of years. And one of my most vivid memories, and so this is kind of a warning, one of my most vivid memories was he often would be, because he was who he was, the keynote speaker at a conference, and he would cover everything. He would cover everything. And so the most common comment from a speaker later on in the conference was, as Dr. Lynch was saying, or to follow up on what Dr. Lynch said. And it used to drive me crazy because he would like scoop everybody else's presentation and sometimes leave them with not a whole lot to say. So my apologies in advance to anyone if I do that. So I'll be going through a lot of things very, very quickly. And we will be trying to stick to a schedule, but sometimes I go off on tangents, and the only way you can really keep me on schedule is to just cut me off, but be assured if there was anything that I was going to say that might have been of some utility to you, but I got cut off before getting to it, we'll have ample opportunity to circle back. Somebody else will be covering that in some way anyway, or you can feel free to ask me about it. And lastly, one of the concerns that I always have coming to a patient conference is, and I've been talking to Swati and others about that, is as an academic, I think I know what's important in this area, and I tend to speak to what I consider important, but I cannot know if the issues that I consider important to you really are the issues important to you. And so please, 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 I'm very approachable. And as the day goes on, if there are things that, gee, Dr. Lynch, you commented on this, but I didn't understand it, or could we amplify that? Can we talk about it more? I love nothing more than these buttonhole conversations where we have an opportunity to expand on these things. So without any further ado, I'm going to blow through a lot of information. Just make a note if there's just something like you didn't understand, you want to talk to me about later, and by all means, cut me off when it's time. Let's see. Okay. Well, so the good news is sometimes I have to give very, very short talks. And believe it or not, it takes a lot more time to prepare a very, very short talk. But because I've been given kind of carte blanche to take as much time as I want, I'm ready now. So I'll be talking a bit about the historical perspective. Now, a lot of this, For some of you, this will all be old information. For some of you, it may be sort of an interesting walk through the history of things. So one of the things that, and I cannot emphasize this too much, one of the things that's very important to you as patients is to, and I'm sure some of you have stories, maybe horror stories like that you can tell about going to a doctor. Obviously, nobody here at the Colorado Medical Center, because obviously they're experts, but possibly your providers back home, and you said, gee, I have an MLH1 mutation. And they were like, does in the deer in the headlights. Like, I don't know what you're talking about. So to this day, many providers, even medical oncologists and surgeons and gastroenterologists, are really unfamiliar with not only the nuances, but sometimes even the kind of more important features of these conditions. So, don't blame them. They have a million other things to have to be thinking about, and not everybody can be an expert on everything. So I think this is part of where advocacy comes in. Of, part of your job is to kind of work with your providers to, not embarrass them, but really kind of coax them in the direction of getting up to speed. So we'll be talking a little bit about how we've gotten to our current standards for managing risk. I'll talk a little bit, but not a lot, about the guidelines for HNPCC management, because others will be talking about that. And I'll be talking a lot about things that I think are kind of on the horizon. So I'm assuming that because you're here, you've already addressed a lot of this issue, so I won't talk a whole lot about that. I will certainly be talking a bit about, and so since you already have family mutations known, some of this may not be as relevant to you as it will be to some patients that may be coming to you for guidance as somebody who's been down this path before. So I will be talking a little bit about where we currently are going with genetic testing and the broader and broader brush we're using in doing the genetic testing. So for example, you can simply Google genetic testing or genetic testing for cancer susceptibility or direct-to-consumer testing, and you'll find a wealth of information. Some of it very proprietary, being put out there by laboratories that are marketing genetic testing. Some of them are here, and they're all over the place in terms of the quality of the information they provide and how helpful it is to you. And these are just kind of random examples of the kind of things you would come across if you just Google, genetic testing for cancer and so forth. So let's back up to the beginning. So this all goes back well over 100 years that the first family with what we now know is HNPCC was identified. But keep in mind, back then, before 1993, we only kind of suspected that there even was such a thing as Lynch syndrome or HNPCC. We had patterns in families that were certainly consistent with what we call autosomal dominant transmission. But in a given family, it could be very difficult to have any degree of certainty that this condition was present at all. And there were epidemiologists right up to the time that the first gene for this was identified, who basically said there is no such thing as a hereditary disposition to colon cancer outside of the very rare condition of familial polyposis. So discovery of genes was just a huge game changer here. And this was the family originally described by this pathologist, Worthen, back in 1913. So here's a picture of my dad, Henry Lynch. If there's any family resemblance, well, that's how it is. But notice this was back in the 1970s, and data gathering at that point was we had Fortran cards. These were pieces of paper you would punch holes in and feed into a computer to give you. And so this is how data were collected then. So a lot has changed. Back then, that was as good as it could get. So during all of that time, from Worthen's original work to other case reports of families, because that's really all it was case reports, and what we came to know by the late 80s or early 90s was simply that there are so many case reports that there are patterns and similarities that seem to be running through these families, certain tumors that seem to be more prevalent than others in these families. And so the things that I was able to contribute were things like, well, small bowel cancer looks like it's part of this picture. Some of these skin tumors, these funny skin tumors, these sebaceous adenomas and keratoacanthomas were part of this. But all of this was purely descriptive, really nothing more than gathering together a lot of case reports. So things started to change, not so much with HNPCC, but actually a few years before that, in this other condition that I gave a talk about the night before last, familial polyposis, which is a very different, but shares a lot of similarities. But that condition involves so many polyps of the colon at a very early age that it really can't be confused with anything else. So it was very, very clear that it was genetic and inherited and associated with cancer and so forth. So it was actually very easy to be sure that a given family had this condition and to study it. So investigators in 1987, that's not that long ago, in 1987, established that there was linkage between various markers on chromosome 5 and the occurrence of polyps and cancer in these families. But it took 4 years, given the fairly primitive genetic sequencing techniques that were available at that time. It took 4 years to actually identify the sequence of that gene and be able to identify mutations in the gene. So at about that time, an international collaborative group called the International Collaborative Group, creatively, on HNPCC was formed. And this is a picture from 1990. I didn't wear jackets back then. That's me in the white shirt. Formed to study HNPCC, to try to have more uniform criteria for saying what family actually had this and what families didn't, so that we could hopefully offer screening. But again, keep in mind, without a gene, if you have HNPCC, a mutation, or not a mutation, let's say this is before the mutation, or let's say you have this condition and you are pretty sure it's a real thing in your family, and you've got 4 or 5 kids, and the doctor tells you it's autosomal dominant, and you say, well, explain that to me. Well, it means the risk to each of your kids is 50-50. Well, we can offer screening of the type that we do now, but we do that with the knowledge that half of the time we're going to be screening somebody that doesn't even have this condition because we don't have any kind of a genetic marker for it. So we wanted to be at least as sure as we could be that a given family had this condition, but we also wanted the best families, so that investigators looking for a gene would have the most fertile soil to be looking in. So I'm going to guess that in this audience, we have a spectrum of families that, if we were to look at your pedigree, probably would have been included in those early gene finding studies. But some of you, probably a lot of you, are from families where back then, many of us would not have guessed with any certainty at all that you had this condition at all. So it's really only been with the discovery of these genes we've been able to be certain in a given family, especially one that didn't have a lot of people affected, that you actually had this condition at all. So let's see. Okay. So again, back then, all we had were very clinical criteria. We had things that now are just of historical interest. You may have heard people talk about the Amsterdam rule for HNPCC, that to conclude that a family had this condition, they had to have 3 or more people with colon cancer extending over at least 2 generations, and one of them had to be young. So think about your own family. Are there at least 3 people in my family that have had colon cancer, or later it was changed to, a related cancer like endometrial or ovarian cancer? Are there at least 3 people in my family? Is it really over 2 generations? And has there been at least 1 person under age 50? So I love audience participation too. I don't have a clicker-based thing, but so how many of you are from families where there's at least 3 people with one of these cancers over at least 2 generations and somebody under 50 at diagnosis? Okay. How many of you can't say that your family meets these criteria? Yeah, so there's some. Okay. So this actually will become kind of important as we go through this. Well, so the game changer was in 1993. Albert Della Chapelle at the University of Helsinki in Finland, working with Päivi Peltomäki, and looking at families like yours, like some of yours at least, using some of the improved genetic mapping techniques that were rapidly emerging, was able to identify a locus on chromosome 2 that seemed to track with the development of cancer. And it took only 6 months, less than 6 months, from the recognition of linkage of these various markers to actual sequencing of the gene that would then enable genetic testing. So this did a couple of important things. One, it confirmed finally once and for all that there is such a thing as HNPCC Lynch syndrome. It's an actual thing because we've actually mapped the gene for it. But really, in a way, so that's really important. But beyond that, we now have the opportunity to do genetic testing and to say who among this group of otherwise at-risk sons, daughters, sisters, brothers, cousins, of these people who are at risk, who is actually a carrier of susceptibility, so that now those of us that do colonoscopy for a living can at least say, okay, the person that I'm screening definitely has this condition, and we can put aside those who do not. At the same time, at the exact same time, Laurie Aaltonen from the same group, the same issue of science, reported that tumors from families, tumors from patients and families with this condition that they just at the same time were able to confirm was a thing, have an unusual molecular feature in their tumors we call microsatellite instability. And what that involves, and I have a little picture of that, is when the genes associated with HNPCC, MSH2 amylation, when they don't work right, they don't detect errors in DNA reproduction properly. And there are certain genes that involve a lot of repeat sequences that are probably regulatory in function, that have a lot of repeat sequences, CA, 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 can vary in length. And when there's a tumor present, there's often an increase or a decrease in the length of these sequences that can be detected. And what he found was, based on work from other labs, that virtually everybody with a tumor in HNPCC, even if it wasn't colon, actually had evidence of this unusual, fairly unusual genetic alteration. So this then could become a clue that if a given cancer patient came across my exam table and I could take a biopsy of that, we could do an assay that would show if there was microsatellite instability. Aha, I'll bet this patient has HNPCC. So in the early days, and by that I mean the mid to late 90s, we had to decide if a given colon cancer had HNPCC on the grounds of age at diagnosis and family history before even doing MSI testing, because it was very expensive and cumbersome. So this is what the typical blot looks like. At the top, we have a single peak. This is the normal number of repeat sequences. But then at the bottom, in a tumor, we see that we have the normal native number of repeat sequences, but because of a mutation, we have a different band now that can be detected this way. But that was kind of a laborious, tedious undertaking. And so we needed more straightforward methods. And so nowadays, much more likely, a slightly different approach, kind of a surrogate, something that gives you the same information but less tedious, is based on immunohistochemistry. So unless you're a laboratory wonk, this isn't going to mean anything to you. But even I, as a humble clinician, can make sense out of this, because we have a GI Path conference, and I can say, okay, on the left, we have completely normal colon epithelium, and that brown staining shows that the mismatch repair gene in this patient is working fine. On the right, we have tumor, and it's pink because we've lost the brown staining, and this tells us that this patient has microsatellite instability because the protein is no longer being expressed. And this has come to become the more standard way of doing this testing, even in institutions that could easily do the other method. But even with immunohistochemistry, there are a lot of problems that actually led investigators to look at other important things. So if I biopsied your tumor and you had microsatellite instability, then the next thing we would do would be germline testing. We would draw some blood and sequence your gene. But what was found was, more often than not, we would not find a mutation. And the older you were, the less of a family history you had, the more likely it was that genetic testing based on an abnormal tumor finding, the more likely it would be that was non-diagnostic. But unfortunately, for a period of time, again, this is only of historical interest now, for a period of time, we would have to continue to treat you as if you had HNPCC because of this microsatellite instability, because we could not prove that you didn't. And the only way that we could prove you didn't would be if we had a genetic test that could reliably exclude. So we didn't really have that. So this was kind of problematic. So we now know that as much as 80% of all colon cancer patients with microsatellite instability, in fact, don't have HNPCC. The challenge is to detect which proportion that is. So, although, and this may seem a little bit confusing, although there are a lot of fits and starts with use of tumor testing, and as I'll be talking about here with the advent of panel testing, this is in many ways kind of replacing the reliance on tumor testing. We nevertheless tend to be doing tumor testing kind of universally in everybody with colon cancer, because even those people that don't have HNPCC, that 80% of people that do have microsatellite instability but don't have HNPCC, we now know that those microsatellite tumors, at least in the advanced stage when they need to be treated with chemotherapy, respond altogether differently than microsatellite stable tumors. The usual kind of chemotherapy doesn't work in HNPCC, but some new drugs, pembrolizumab and others, work phenomenally well. But it doesn't really seem to matter whether you have HNPCC or not. So for those reasons, we test everybody's colon tumor for evidence of microsatellite instability. But because of all of the problems with interpretation, we have other methods that are evolving that can kind of take the place of that. So sorry for when I sent this, all my margins were fine, but sometimes, you know, in the software things get all messed up. So just ignore that. So what are multi-gene panels? Now, I don't know how many of you were diagnosed on the basis of your doctor just going straight to multi-gene panel testing, as opposed to starting with the tumor that had microsatellite instability. I'm going to guess that most of you, if you're in this room, have had this, been known to have this condition for a while. But I'm guessing most of you started off either with you or your family member who had a colon cancer that was investigated by immunohistochemistry, was found to show microsatellite instability, and then genetic testing was done. And you may not even remember that, but I'm going to take a chance. So who thinks that's kind of the pattern that led to us, starting with a tumor, doing some testing, and then doing genetic testing? Yeah, quite a few of you, but I'm going to guess you maybe don't even remember exactly how that testing was done. So oftentimes the problem is in a given family, we're dealing with a newer generation of worried well. We think that our family has HNPCC, but mom or dad that had colon cancer died and there's no tumor available to do this work on. So as an alternative, we can just go straight to genetic testing, but we have to decide who's going to benefit from that and who's not. So most of the work in this area really started off with breast cancer, where there's a big familial hereditary component. A lot of women with breast cancer have BRCA1 or 2 mutations, and they really didn't have the same abnormal tumor findings to drive the evaluation like we have in colon cancer. So because it was common and because we didn't have a tumor-based thing to start with, the development of panel testing really emerged from the breast cancer area. And what it is it's a host of gene sequencing and testing for deletions and other kinds of abnormalities that's done not just on one gene. So, gee, you've got breast cancer, so we're going to test you for BRCA1. Oh gosh, that test came back negative. Okay, now let's test you for BRCA2. Oh, that came back negative too. Well, let's test you. So rather than kind of nickel and diming it, the laboratories that do these said, well, let's just have, now that it's gotten very cheap and easy to do this testing, let's just have every gene that possibly could contribute to breast cancer and test for all of them at the same time. And the yield was actually very high. And we talked about this over the last few days at our place, and I'm sure at yours also. You know, we all pushed back and said, oh, that's such a shotgun. Here's shotgun. That's such a shotgun approach. That's so inelegant. But the laboratories really pushed this, and frankly, it's come to carry the day. So because of the early successes and evidence of utility in breast cancer, it came to be a very convenient, easy, inexpensive way to look for colon cancer susceptibility even when there was no tumor available, or we couldn't evaluate it, or for whatever reason it couldn't be done. So I think in newer situations, somebody diagnosed nowadays, we wouldn't really worry as, again, advanced cancer where the treatment, with pembrolizumab or something like that. Yeah, we might evaluate the tumor for those reasons. But if the main concern is, gee, is there a genetic susceptibility, we would tend more and more to be going straight to this panel testing. So this is kind of the algorithm, if you will, the sequence of things that are the way we think about evaluating a tumor. It's kind of maybe hard to follow, but this is actually kind of old data. So basically, it says if you start with a colon cancer, you do tumor testing with either the so-called PCR, look for the new band on the gel, or the immunohistochemistry. If it's normal, probably not HNPCC. If it's abnormal, there are other tests we can do to kind of sort out, is this likely HNPCC, or is it likely a non-HNPCC sporadic? And then once we've sorted all that out through this mind-numbing process, we then can go to genetic testing in the hopes of finding a mutation. But now, as I show on the right, there's emerged kind of this alternate pathway where if for whatever reason we can't or don't want to do a tumor-based approach, we can just go straight to genetic testing. Models have been developed where a worried well person can walk into their doctor's office and say, gee, I think I have a cancer problem in my family. And the doctor can go online and pull down a breast model or a colon model. And based on information like who in your family's had cancer and how old were they, they can punch it in and come up with a likelihood that you have a gene alteration of some sort. And depending on that probability, which actually is a fairly low probability, maybe in the range of 2.5% to 5%, which is pretty low, they'll say, okay, you would benefit from a gene test. So there are some problems with this approach. I'm not going to go into to all of the details of that. But the current landscape, I'm here to tell you, is that panel testing, for better or worse, has become quite routine, with a very low threshold for undertaking that testing. A lot of this is changing how we think about genetic counseling. And because, again, without saying anything against any of our laboratories out there, because of aggressive marketing of these panels by these labs to just mainstream doctors, the doctors are having to become more and more familiar with the implications of what these tests do and what a finding would actually mean. So if your doctor is more up to speed this year than he was he or she was 2 or 3 years ago, part of it may be that the laboratories are kind of pushing a lot of this information on them, which is a good thing. So if you don't have any cancer available for testing, immunohistochemistry and so forth, or for whatever reason, you or a family like yours wants to undertake genetic testing, this is the huge number of genes that can be included on a panel. And the breast panel and the colon panel are really not that much different, because frankly, the colon panels looking for a colon gene include a lot of breast cancer genes, and the breast cancer panels include a lot of colon cancer genes. And so the ones in the heavier boxes are the host of genes that are associated with colon cancer susceptibility. And of course, yours, MSH2, MLH1, and so forth, are up there, but so are a whole bunch of others. So again, the importance of genetic counseling, these laboratories do tend to encourage people, because there is now direct-to-consumer testing, which I'll talk a little bit more about. Because of direct-to-consumer testing, you don't even have to go through a provider. So, if your next door neighbor is concerned about the risks of cancer in their family, but they don't like to see doctors for whatever reason, they can go online and, again, Google direct-to-consumer genetic testing, and they can actually have a kit sent to them within a couple of days, so that they can be tested for all of the same stuff without ever seeing a doctor, without ever seeing a genetic counselor. And if we're lucky, the information that they get from the website will tell them what they need to know. Will recommend or help them get to a genetic counselor, hopefully before the testing, more hopefully after the testing, but there's no guarantee. So again, from an advocacy standpoint, those of you in the audience with this condition can, I think, be very, very helpful to kind of a whole new generation of people that are stumbling across information about their genetic susceptibility. And these are just examples of the kinds of things that you run across when when you do a web search for genetic testing. They're getting very, very inexpensive. A lot of patients express concerns about the cost of genetic testing. And at one time that was a concern. The testing was $3,000 or more. Now, in many cases, the comprehensive test for everything is actually less than the copay for a colonoscopy in some instances. So I'm not going to go through all of this, but just to kind of show what the power of these panels is and the things that they can come up with. So this is a not unusual situation. A young woman comes to see her doctor, maybe a gynecologist, and says, gee, I'm healthy and fine, but I'm worried about the cancer in my family. Notice there's no colon cancer, some fairly early breast cancers. What happens if we test this young 24-year-old? This is not an unusual setting. Well, even though she had a breast panel done, it includes the colon cancer genes, and she's found to have a PMS2 mutation. There's not even any colon cancer in the family, but she's got a colon cancer gene. So that's the situation we have. This one hits closer to home, which I'll show you in a second. So very similar family, healthy woman, little bit of a family history of breast cancer, has a genetic testing panel, again, shows a PMS2 mutation, except it's on the other side of the family. And there's not even any immediate cancer on that side of the family. Well, why do I care? Well, she's got a son who's at risk. Well, obviously that makes sense. She's got a son that, will eventually want to be tested to find out if he's a carrier. Well, again, why do I care? Well, it's because it's my grandson. My daughter's gay, and through an in vitro fertilization process, my daughter-in-law has a son, my grandson, who's got a 50-50 chance of carrying this PMS2 mutation, which by itself is not a big deal. But here's one of the specters that's kind of out there, kind of lurking. We don't know anything about the sperm donor for my grandson. And it's unlikely that he had a genetic susceptibility. But we know that PMS2 may actually be the most commonly mutated of the mismatch repair genes. And so on the off chance that the sperm donor has an PMS2 mutation, if my grandson were to inherit the known mutation from my daughter-in-law, and on the off chance that he inherited a mutation from the sperm donor, when you have two copies of this, not just one, but if you have two copies, you actually have a devastatingly early, severe form of this we call constitutional mismatch repair, that cancers by the time you're 8 or 10 years old. Horrible thing. So, I would kind of want to know. And so we're seeing more and more of these kind of situations. People are adopted, uncertain parentage, false paternity, in vitro fertilization. So we're seeing a lot more of this. Okay, well, enough about all of that, because I'm starting to burn through my time. So what about screening? Well, obviously this is the paradigm, colonoscopy. And oftentimes, I'm retired now, but oftentimes, many of the patients on my endoscopy list and Dr. Patel's list are people coming in for colon surveillance. A lot of the guidelines that we now have for surveillance are based on these data from the so-called prospective Lynch syndrome database in Europe. Paul Muller, who's been the driver of this, kind of a character, but dear friend of mine from Norway, has this huge registry of data from European centers. So the data here are actually kind of disconcerting. And if you don't take really any other message about surveillance from this, then this is important. So these are patients that actually have been under surveillance. These are people who have been getting regular colonoscopy by and large. But you'll notice that despite that surveillance, upwards of 40% of MLH1 patients will eventually have a colon cancer, and MSH2 not far behind. So, well, wait a minute, I'm under surveillance to try and identify polyps and remove those polyps before they become cancer. How can this many people be developing cancer despite surveillance? Well, we know that surveillance is not perfect, that things can be missed, and we have very much reason to believe in HMPCC that these tumors tend to evolve very, very quickly and emerge between exams. But this even more distressing data nested within that larger body of data that I just mentioned, data from Germany, where they do colonoscopy every year, Holland, where just by accident they tend to do it more like every 2 years, and in Finland, where it's more like every 3 years. So you actually have kind of a historical ability to compare the yield of different screening frequencies. Virtually no difference in the rates of colon cancer or the stages of colon cancer. Very distressing to me. This is not the kind of data that I like to see, but I have to admit that when we went back and looked at, we have a lot of information from our own institution, most of our data were very, very similar to this. It didn't really seem to make that much difference. So now the guidelines have kind of changed a little bit. The guidelines actually recognize the differences in risk between MLH1, MSH2, MSH6, and PMS2, which is a fact that's not known to a lot of your providers, but is a very important one and is being currently reflected in the guidelines. So these are the European guidelines. So again, I want to emphasize these are the European, not American guidelines. In MLH1, MSH2, and MSH6 carriers, the recommended frequency of surveillance is 2 to 3 years. And in PMS2, more liberal 5-year intervals. The age of initiation, about 20 years old, 25 for MLH1, MSH2, and later from MSH6 and PMS2. These are the NCCN guidelines that I tend to quote because I've been on this committee for many, many years. And there's a lot of text that's associated with it. You can pull this up pretty easily yourself and look at them. So in the US, at least the NCCN guidelines now provide for more aggressive surveillance in MSH2 and MLH1, starting at 20, that's supposed to be 20 to 25, and then at 1 to 2 year intervals. We emphasize the importance of colonoscopy quality, and Dr. Pell will talk about that. Important to remove adenomas. Again, this is important to all of you. There are screening guidelines for endometrial cancer that'll be talked about by others later. But in the case of MSH6 and PMS2, a somewhat more relaxed approach based on the now recognized lower risk of cancer, of colon cancer. So the guidelines are recommending starting at 30 to 35 and at 1 to 3 year intervals to include an upper GI endoscopy, to at least consider an upper endoscopy with colonoscopy. In MSH2 and MLH1, it's actually a recommendation, proactive recommendation to do upper endoscopy. And I know Dr. Patel has been basically following these guidelines pretty well. So again, because of the increased risk of stomach cancer, we're starting to see we are doing screening in those individuals. My personal view on GYN tumors, again, I'll defer to others talking about it later. We have no concrete guidance to actually support any particular approach to screening. One of the things we do at MD Anderson, before I retired, is women at risk of endometrial cancer. When they came in for a colonoscopy, we would arrange to have one of the gynecologists come in and do an endometrial biopsy while they were asleep for the colonoscopy. It takes a little bit of logistic work to get everybody together, but our patients love it. So I'll kind of start wrapping up with some comments on lifestyle and chemoprevention, again, which others will be talking about a lot. Very important data from John Byrne and a predominantly European collaborative study, the so-called CAP1 study. And the conclusion from their baseline study was that aspirin combined with resistant starch for as long as 4 years had no impact on the risk of adenomas, of precancerous polyps in HNPCC. You see really no difference. This was his conclusion when he announced these data, opened the envelope at an international meeting, because he was hoping to see a real benefit in treating polyps. He said, damn, this isn't what we wanted to see from the study. The good news is they continued following these patients for a long time, even after the study closed. And they actually found that over a longer period of time of observation, even though there was not a short-term reduction in polyp risk, there was a long-term lowering of the risk for colon and other HNPCC related tumors. So what this has driven, and again, this is even longer-term data showing that up to 20 years, we still have an improvement in cancer risk. But what this has led to is the so-called CAP3 study, where they're looking at lower doses of aspirin because there are some concerns. And again, these are recommendations from various groups around the world in terms of the role of aspirin. Again, I think all this is available online. There are certain caveats or reservations possibly about the use of aspirin. Patients that are older, patients that are allergic, patients that really have no cardiovascular risk, may not benefit as much from aspirin, people that have a bleeding tendency. So your doctor may have second thoughts. And that's part of the reason for the CAP3 study looking at lower doses, because a lower dose of aspirin may be safer. And again, this is kind of the outline of that. Resistant starch will be talked about more. No real impact of resistant starch alone on colon cancer, but some benefit in treating seemingly some benefit in other cancers. So are there other lifestyle things? Well, yes, being overweight in HNPCC seems to be, and this is true in general, but in HNPCC, it's also true that if you're overweight, you're at higher risk of having polyps and cancer. It makes sense. This may be another game changer, the possibility of vaccines. Okay, this is really exciting stuff. I'm only very peripherally involved in any of this, but the abnormal proteins that are a very early event in the development of an HNPCC tumor, the abnormal proteins are what we call highly antigenic. That is, the immune system can react to them. And so we want the immune system to really react to them and kill these abnormal proteins in the cells that make them. And so Matthias Klur, a pathologist in Germany, has really pioneered a lot of this work. So let's see if we can raise up a vaccine to target the cells that are producing these proteins. And so there are several studies that are being done in the US to evaluate both the safety and as shown on the right, to look at whether these vaccines can possibly reduce the risk of polyps and cancer. And this is another similar study being done by Eduardo Villar-Sanchez. So patient advocacy, there's going to be a whole conversation about this. So I'm not going to really say much about that because I'm starting to run out of time. I think we're going to be seeing almost universal testing for MSI, again, not only because of concerns about HNPCC being present, but again, differences in therapy in people that have advanced cancer. I think we're getting to where routine testing of all cancers is the case. We're getting less rigorous, and I think in some ways that's good, some ways that's bad, less rigorous about how we think about genetic counseling. We want the information, but there are other more media-based models. Look at this video to give you all the information you need rather than a face-to-face with a counselor. I think increasingly with our electronic medical records, there will be ways that we can get your family history into our electronic medical record and see to it that that information is well curated and tended, and that some of the inaccuracies that are present are gotten rid of. The things that I think are coming are universal testing for cancer. And I talked about this a bit in a lecture the other night. It's getting so cheap. There are so many settings where we can't anticipate the possible benefit of this. I think a day may come where, even though it's already kind of available on the basis of direct consumer testing, if you're worried well and want this, you can get it. But I think a day may not be that far off where we just consider it routine to test everybody for cancer susceptibility, cardiovascular disease susceptibility, just like we test newborns for certain inborn errors of metabolism. The thing is, there are certainly downsides to that, but one of the things that a group like is that being afraid of a genetic diagnosis doesn't really help anybody. We have to embrace that. And what better way to embrace that than by mainstreaming the entire process and basically saying, hey, let's get over our hangups. We'll let the genetic counselors deal with the fallout of the tons of information that's going to come when we test everybody. But, if we can get over our hangups, I think it may turn out that the benefits outweigh the risk. And I know I'm about out of time, but one of the things that's kind of exciting, and it's over my head, and now I'm retired and I won't be in the game much, but there may be ways of detecting some of these, like really, I mentioned the frameshift peptides, some of these funny proteins and proteins associated with tumors. So it may be possible with simple blood tests to detect these, possibly as a screening test for very early cancer and maybe even the polyps that precede them. And so there are studies already doing that in high-risk people, looking to see if some of these blood markers can be helpful. And so these are the things that I think are going on. But I think the things that I'm most excited about are the things that we can only imagine. And I think one of the things that would benefit all of us is a very fertile imagination. And on that note, I can say one of the things I loved about Dennis Anand was his very fertile imagination. And Swati had kind of alluded to this in a conversation the other day, is that probing question. Can't remember exactly how she put it, but if here's where we are and here's where we want to be, what's it going to take to get us there? And if we aren't thinking about that question of what's it going to take to get us there, we're never really going to be able to design studies to get to that. And so, fortunately, in Dr. Patel and her colleagues, we have people that are ready to stretch their imagination, say, okay, here's where we are, here's what can we do to get there? So I think it's an exciting time to be involved in this field. I'm very excited, looking forward to the other speakers and the chance to visit with you all informally. One of the things I loved about my dad was he had a lot of energy when he would get up and talk, but he loved to mingle with folks, and big hulk of a guy, 6'6", and he'd kind of hover over people, but it was because he had such a passion for all this stuff and loved to talk to patients. And so I'm going to take my jacket off and maybe even loosen my tie so I can be as approachable as possible during the day. Thanks a lot.
Wonderful. Dr. Lynch, I know you probably want to take a sip of water, but we'd love to open the floor to questions for Dr. Lynch. We have some time. Please feel free to approach the two microphones, or we can come to you if you raise your hand. I'll start off with a question, Dr. Lynch.
Just come up to me later.
Yes,
Yeah.
of course. Certainly throughout the day, we can continue these conversations, but some of the last few slides really generate excitement and anticipation. From a historical perspective, can you kind of, if you were to forecast, because you were in this field from its inception, really, if you could forecast some of the biggest ways that you see the lives of patients changing from the prevention side of things, what do you think is going to be the biggest difference in what our patients are currently doing?
Well, hopefully I touch on a few. I think one of the most important things from the standpoint of prevention is, again, I hopefully don't have to tell this, but I'm going to guess that even in your own families, there are brothers, sisters, sons, daughters, cousins that don't want to get tested, don't want to hear about this, are afraid to come see Dr. Patel for a colonoscopy. I think the most important thing that I see is that as all of this stuff becomes more mainstream, as your doctors get more comfortable with these diagnoses, as you get more comfortable with having a condition like this in your family, and we become more matter of fact about this. These are chronic diseases. It's not like diabetes where you take your insulin and but these are chronic. These are things that are a lifelong issue for you and members of your family. We have to get over our unwillingness to basically say, yeah, it's an issue, just like diabetes. It's just something we have to deal with. So I think that is something that is going to be happening increasingly, no matter what kind of imagination anybody has, because this is just, it's like a wave that's just kind of coming over us, and it's kind of a nice warm wave that I personally welcome. The thing that I think will be hopefully a game changer will be some of these vaccines. If they're successful, they potentially can be used in conjunction with some of these other really exciting new chemotherapy medications. I've had patients with HNPCC colon cancers treated with drugs like pembrolizumab that didn't even get operated on for their colon cancer because the tumor melted away with chemotherapy. Still, colon looks a little bit funny, but you biopsy the bejesus out of it and there's no cancer there. So I think that's going to be kind of a game changer. And the vaccines, if successful, may be an important supplement to those kinds of chemotherapies, but may be even more important in preventing those colon cancers in the first place by identifying the very earliest cells that are going to become the adenoma, that are going to become the cancer, and actually kill off those cells before they emerge. And I think maybe what Swati was getting at is some of these lifestyle things. You know, I will admit, I was kind of a naysayer. You know, I felt that, you know, if you had one of these gene mutations, your risk of cancer was such that it really didn't matter what you ate or how well you took care of yourself or any of that. But I think the data that we've seen from, you know, the aspirin studies and some of the other interventions have shown that, and this is a note of hopefulness, certainly, but even if you have a susceptibility, even if it's one of the worst ones, you know, badder ones like MSH2 or MLH1, even if you have a susceptibility, we can really impact that risk by use of agents like aspirin. We just don't know the right dose yet, and there may be able to combine it with other medications that help too. So, you know, there are things in addition to your surveillance that I think will help. And then lastly, you know, it really bothers me that colonoscopy has not been more thoroughly effective in identifying the adenomas that lead to cancer. And so I think some of the newer techniques that are emerging, the possibility as we are thinking about longer intervals between exams. Again, European data seem to suggest that doing it every year doesn't really make that much difference. So maybe we ought to just do it every 2 or 3 years. But we're nervous about the idea of thinking about those longer intervals. But there are some non-invasive tests we've been talking a bit about the last few days, testing for blood and mutated DNA in the stool, that if we missed something on the colonoscopy yesterday, and we're planning to bring you back in 2 or 3 years, but we do this stool test next year and it's abnormal, it's like, oh, maybe we missed something. Maybe we ought to bring him back sooner, and then pick it up then. So I think having adjuncts, having alternative supplemental approaches in the screening arena are important. And honestly, you know, I spent all day, every day doing colonoscopy, but I welcome the introduction of you know, additional complementary approaches to surveillance, whether it's looking for circulating tumor cells or fragments in the blood or in the stool. But clearly colonoscopy by itself, I cannot guarantee you that if I or Dr. Patel does a colonoscopy on you every year, I cannot guarantee you that you won't develop a cancer despite that. And we need to do better than that.
Other questions? Yes, looks like we got a bunch of hands up. For others who want to approach the podium, you may as well.
So I like history, and you were there at the conception. I don't know if you went back to why you don't call it Lynch syndrome, and I wondered if you had any quick stories about the Amsterdam criteria. I'm a 3-2-1 person that was diagnosed with colon cancer at age 16, so I fall under the Amsterdam criteria.
I think in a lot of ways, for me, the Amsterdam criteria are of historic interest. So, you know, if you're, and this is unlikely, but if you go to your doctor and your doctor went to medical school in the 1990s and they got a lecture on HNPCC at that time, gene was known, but you know, what they remember was the Amsterdam criteria. I was actually there at the Prinsengracht Hotel. I was the one that took that picture of them, old slide carousel. Remember slide carousel? And where those criteria came. But yeah, so some of your kind of old timer doctors may still have in mind the Amsterdam criteria, but a host of studies have confirmed that many families don't meet those criteria. So if your doctor says, well, gee, you know, there aren't 3 cases and nobody's especially young, you know, that doesn't really carry any water anymore. I think where the 3-2-1 rule, you know, if it has any importance at all, you know, if your family does meet those criteria, you know, 3 colon cancers, you know, over multiple generations, somebody very young, probably a little bit more likely that you have an MSH2 or an MLH1 mutation. If your family doesn't meet those criteria, more likely that it's an MSH6 or a PMS2. But, you know, we see families that have MSH2 and MLH1 mutations, more bad ones, where the cancer ages don't seem all that young. They're kind of the exception, but So it's kind of all over the place. And so that's why I'm saying is, yeah, the 3-2-1, the Amsterdam thing is it's kind of a handy frame of reference, but I don't use it anymore at all. I'm guessing Dr. Patel doesn't either. It was important at the time. There was these so-called Bethesda guidelines for when you should do tumor testing. When tumor testing was hard to do, not many labs did it. It was expensive. How strong did your family history have to be? How young did you have to be before we would say it was worth doing the tumor testing? Well, because of the circumstances at the time, that was the best we could do. Those guidelines were helpful. Now, largely of historic interest only. So don't get, history is great. I'm kind of a history buff at heart, but don't get too hung up on things that were valid then, but really aren't important now.
Ken.
I'm just an old geologist, but I'm thinking about the world of data that we've seen.
So I'm very
In
hard
our
of hearing.
life.
So
Pardon me? I said, I'm just an old geologist thinking about the world of data that we've seen emerge.
Mm-hmm.
Three things are coming to my mind. You touched on them here. The testing that is now becoming available, you said, and it's relatively cheap. But somebody has to pay for it.
Mm-hmm.
This might be a cohort of people who have encountered insurance companies who say, well, we don't think so yet. Well, what does that do to our world of data? Maybe we have to wait another 50 years to get the kind of data sets that are scientifically aha. I'm thinking about your slide where the guy said, damn, that happens too much.
Mm-hmm. Mm-hmm.
I love this slide. And I'm thinking about the world of all the data that's going to be coming available to
Mm-hmm.
us, especially if we can get somebody to say it's important to pay for that.
Mm-hmm.
And we have this wealth of data coming to us as we're approaching the finite limits of digital computers to analyze that data in a timely manner. I'm wondering if you have encountered thoughts yet about the world of this science and the emergence of quantum computers,
Right.
and AI.
Well,
Can we get answers to the science questions
right.
that we want
Well,
to
so
ask?
actually we had a conversation about AI. We're actually using AI to help us find polyps better in the colon. But that's really not the context. So, insurance issues, I glossed over them, and hopefully they'll crop up again. And I'm going to guess this is true here too, our genetic counselors spend way more time than I think makes any sense trying to determine if an insurance company is going to pay for tumor testing or genetic testing in a particular context. Okay, is that safe to say? We spend more time on that than we'd like to. But so that's the bad news. The good news is I think that's rapidly changing. The barriers are falling as it gets cheaper. Well, if it's cheap enough, an insurance company will be willing to do it versus if it's expensive. The amount of data that's coming in support of this is like water out of a fireman's hose. So I think correct me if I'm wrong, genetic counselors, but I think many of the insurance barriers that had been there in the past are rapidly falling and becoming less and less of an issue. Some of it aided by legislation, but some of it just driven by the data. But again, the cost has gotten so cheap that, in the range of like $200, or is that about right? About $200 for a panel test. So, if the family gets together, I mean, if you have a really poor family, and I think some of the testing labs, have kind of a compassionate situation where even truly indigent people can get testing. But even if you don't have $200, this is a family issue. So, can we get all the siblings together to pool, $50 each so that the person most likely to have a positive test can be tested? Sure. So I think that the cost need no longer be a barrier. So when I had to tell a patient, insurance may not cover it, it's going to be $3,000 out of pocket. Whoa. But now I say, chances are the insurance company will pay for it. But even if they don't, $200, that's like I said, often less than the copay for a procedure.
So multiple questions. We'll take one more question and then please, we encourage you to hound Dr. Lynch all day.
Anybody- Yeah.
That's why he's here.
So I'll be here all day. Come and grab me anytime. Chase me down in the bathroom. You know, I have an old prostate, so I'm in the bathroom a lot.
But let's take this one last question from my dear friends here.
Really quick, regarding the insurance thing, I don't care how much the testing costs. What I'm concerned about is the long-term effects of that test. Meaning, I'm thinking of a dystopian future where my grandson is labeled as having this, and all of a sudden we're labeled as invalid or not able to get insurance, and the long-term cost
Right.
significantly outweighs the upfront cost of the
Right.
test.
So I don't know if this is going to be covered elsewhere during the day, and if not, it probably should have been. This would be something for next time. I think this is a real concern. This has led in some situations to people, and we still see this, some people saying, you know, I want genetic testing, but I'm so afraid of discrimination in the workplace or insurance. I want to do this testing under an assumed name. You know, I'm going to be John Doe. And I don't know how many, you know, the labs that do this stuff, I assume that they're willing to do this testing under an alias. They're not happy about it, but there are certain situations where, you know, where patients they're so terrified of the implications of it that they'll actually be tested under an assumed name. So that's how anxious people can be. The good news is most of these concerns about discrimination are more imaginary than real. Yes, it can happen, but again, I think the key is as all of this gets more mainstream, as all of your doctors and all of the people in your family and all of your neighbors and all of the people on TV and all of the people doing the podcasts, as all of them get more matter of fact about this whole thing. It was just another brick in the wall, just another thing to deal with, especially now that we have interventions that can really make a difference. You know, this is, you know, just because you have an alteration of one of these genes doesn't mean you're going to die or die young. We have things too. So it's just something to manage, you know, so I'm very optimistic that, but it's definitely something within a family. You really have to process this within your family, because this is something that's very near and dear to me. It's very important to me because I know every family's got its weirdos in it. That my family in particular, but every family's got a whole range of concerns and worries. So there's not a family out there that doesn't have somebody who's afraid to be tested because they just don't want to know, and so forth. So, you know, it's a process. It's an ongoing thing, but I think everything is moving in the right direction toward these concerns, which are entirely valid, becoming less and less of a concern as time. And so, the more matter of fact we all can be about it, then I think the fewer of those concerns on the part of the kind of, you know, doctor averse members of our family will be.
Thank you, Dr. Lynch. And Mr. Patzer, thank you for that question. I'm really excited that you brought that up because it is an incredibly important issue. And we have an entire session this afternoon dedicated to talking through some of these things where we want to hear your voice and your perspective on these barriers to communicating results to family and thinking about the next generations, because it's a rapidly changing time. And you know, us millennials, what we grew up with is so different than what we can imagine our kids growing into. So I'm glad you brought that up. So that concludes our session this morning with our keynote speaker, Dr. Patrick Lynch. We really greatly appreciate you coming and giving us a grand overview and topics that, despite your request, we will continue to refer to your presentation about throughout the day. We'll have a break now for about 10 minutes. Please get some coffee, get some refreshments, and we'll reconvene at 10 o'clock. Thank you very much, everyone.
Let me do that for you.
Okay, I think it's okay.
It's good.
Yeah, right.
It's just the mouse. The other way around. You got it?
Yeah.
He's doing it back there. Yeah. It's a lot more. Yeah. And I think, welcome back, everyone. I know it was a short break, but we're hoping to get started again to just stay on schedule. My name is Lisa Axel. I'm a genetic counselor. I may have met with some of you over the years. So session one is going to be about cancer risk reduction. So we are going to have Dr. Swati Patel come back up. We're going to have Dr. Aldridge, and then also our dietitian, Patty, is going to come share some information with you. So to start us off, I am happy to welcome back Dr. Patel. As you all know, or most of you know, she's a gastroenterologist here at the University of Colorado, and she will be talking today about the importance of colonoscopy quality.
Thank you, Lisa. I know that was a short break. I was asked to make one announcement. It sounds like the front doors are intermittently locking themselves. So if you go outside or take a break, just make sure you either get the cell phone number of somebody up front who can let you back in, or a family member to let you back in case they lock. So it has nothing to do with colonoscopy quality, but perhaps event planning. But nonetheless, what we'll spend the next 20 minutes or so talking about is really a procedure that most people in the room have not only had once, but many, many, many times over. Honestly, I wish we had more time. When we designed this session, I thought I could give a broad talk about everything cool we do in GI to decrease cancer risk. The advances in what we can do to decrease upper intestinal cancer risk, like Dr. Lynch mentioned, these upper endoscopies that we do with your colonoscopies, what we're looking for, how we can visualize much deeper into the small bowel with a variety of different really incredible technologies, and really a lot of recent promising data on a cancer that in the past has really been something that has been a bit of a frustration, pancreatic cancer surveillance. We now have emerging data that among those with high risk, we actually are seeing really promising outcomes in screening and surveillance. So if any of these topics are of interest to you, please let us know. Perhaps we can include them in future symposia. But for today, we'll try to address three, I think, fundamentally important questions when we think about colonoscopy. What are we actually trying to achieve when we do colonoscopy in our Lynch syndrome patients? Why is quality important? Is it not like any other test where whether you get a scan here or a scan in a different city, shouldn't it be the same? And based on what we talk about, how can we ensure that you, your family, are getting a top-notch colonoscopy? As Dr. Lynch really elegantly explained, those with Lynch syndrome essentially have this inability to fix mistakes. So every time a cell divides in every single organ of our body, which happens millions and millions of times, it has to duplicate that genetic code. So mistakes are kind of bound to happen, and these mismatch repair genes are designed to find and correct those mistakes so that then that cell has normal DNA code. In those that have absence of this mismatch repair function, if it's not working, well, then the mistake can't be fixed. And in that cell, whether it's in the colon, whether it's in the uterus or the skin, that mistake gets incorporated into the genetic code of that cell. You can imagine that if the thing that's supposed to fix mistakes, the spell checker, is not working, if that happens and mistakes start to build up in important genes, the genes that we know are responsible for how cells move, how they divide, how they grow, how they migrate, well, then you can imagine that cells start to grow abnormally, and their next generation of cells grow abnormally and predispose to tumor and cancer formation. And if these mistakes can't be fixed, essentially, this can cause a snowball effect where things can rapidly, very, very rapidly develop. And as Dr. Lynch mentioned, cancers in Lynch syndrome can develop much more rapidly than in the general population. So when we're thinking about colon cancer, for the most part in the general population, we think about this progression from normal tissue that can sometimes grow into a small precancer polyp that over time can progress and grow into a cancer. For those without Lynch syndrome, this question was just asked to me as I was coming up to the podium. How long does that take in the general population? Well, usually around 8 to 15 years, if it's going to happen at all. So that's why your neighbor, if their colonoscopy is normal, doesn't have to come back for 10 years. In Lynch syndrome, however, this is an accelerated process wherein sometimes we can see cancers develop as quickly as a year after a colonoscopy. So Dr. Lynch reviewed our guidelines, what the National Comprehensive Cancer recommends for our Lynch syndrome patients, and based on the different risks that we observe on the gene that's effective, we know that those with MLH1, MSH2, EpCAM, which is a gene that sits right in front of MSH2 and kind of causes MSH2 Lynch, those patients develop cancer at earlier ages and have a higher lifetime risk of cancer. So the National Comprehensive Cancer Network recommends starting colonoscopy between the ages of 20 and 25 and repeating it every 1 to 2 years. But based on the data that Dr. Lynch showed us, we have observed that it appears that MSH6 and PMS2 patients have a lower risk and may develop cancer actually at later ages. And so more recently, the NCCN has suggested that we could potentially start colonoscopy later, between 30 and 35. Now that asterisk is or 2 to 5 years earlier than the earliest cancer diagnosis in the family. So that family history is important to know whether we should start earlier. And that maybe we can relax that interval to 1 to 3 years. So really one of the most satisfying parts of my job, outside of seeing you all in the clinic and talking with you all, is what I do in the endoscopy lab. And that is hunt and find these polyps and take them out before they have a chance to grow and turn into cancer. So what do we do when we do colonoscopy? Many of you have had this procedure. We essentially insert a long flexible scope that has a light source and a camera at the tip of it, a channel where we can irrigate fluid into the colon, suction fluid out of the colon, and we advance this scope through the anus, through what we call the sigmoid, descending transverse, ascending colon, all the way to the cecum, which is essentially the anatomic term for the beginning of the colon. We also often recommend inserting the scope into the last part of the small intestine, the terminal ileum as well. So when we do colonoscopy, what is it that we're actually looking for? Well, we're looking for polyps, right? But like most things in life, and certainly in medicine, it's not as simple. Not all polyps are the same. The most commonly found polyps are adenomatous polyps. And many of you, if you look at your pathology reports, see these terms. But there's even subtypes of those adenomatous polyps. There's tubular adenomas, tubulovillous adenomas, villous adenomas. And then the other commonly encountered polyps that we see during colonoscopy are serrated polyps. Of those, there's hyperplastic polyps, sessile serrated polyps or adenomas, and traditional serrated adenomas. These are really just subtypes based on what they look like under the microscope and sort of how they progress from normal tissue to precancer or possible polyp. But the reality is not all polyps are precancerous. So how do we wade through all of this? Well, typically hyperplastic polyps are these small polyps that really are now quite well established to not confer increased risk of growing or turning into cancer over time. On the other hand, tubular adenomas, sessile serrated polyps or adenomas, they do have that potential to advance and grow and are considered intermediate risk polyps. Whereas tubulovillous adenomas, and traditional serrated adenomas are the types of polyps that we actually consider higher risk. The ones that there's changes under the microscope that suggest that they really are on their way to potentially progressing and turning into cancer. Now, if you have a tubular adenoma or sessile serrated lesion with either high-grade dysplasia in a tubular adenoma or any dysplasia in a sessile serrated lesion, dysplasia is just a term we use for precancer, so high-grade precancer changes in tubular adenomas or any precancer changes in a sessile serrated polyp actually put those types of polyps in a high-risk category as well. So we find these polyps all over the colon. The hyperplastic polyps tend to occur mostly in what we call the distal colon or the sigmoid colon, descending colon, in the rectum. Tubular adenomas can essentially occur anywhere. And the sessile serrated lesions typically occur in the proximal colon or the ascending colon, the cecum, sometimes the transverse colon. And then these traditional serrated adenomas tend to occur in the rectum. So the answer to this question is pretty easy. What do we do when we find polyps? Well, obviously we want to take them out, right? So whether it's a small polyp like the one here on the left, or this monstrous polyp that's really extending all the way through, taking up more than 3/4 of the circumference of the colon here on the right, our goal is to take these polyps out safely and completely. And particularly in Lynch syndrome, no polyp is too small to be worried about. We need to make sure that every polyp we remove is removed completely, because any residual tissue we do not want to leave in place and allow for the possibility of it to grow, progress, and advance to cancer under our noses. So it's critically important that we completely remove these polyps, and there's a specific skill set. I see some jaws dropped in the back there, and I hope everyone's breakfast has settled a little bit. But it's critically important. And, there's, I'm sure, lots of questions, and we can talk about polypectomy technique. But whether it's the tiny polyp on the left, which takes 10 to 15 seconds for us to remove, or this more advanced endoscopic mucosal resection, it's really, really important that you're in the hands of a colonoscopist who knows how to remove these safely and completely. So how well does colonoscopy work? Well, Dr. Lynch presented some provocative data from the Europeans that is really observational data. What that means is that in all these countries that he referred to, Germany, Netherlands, in Finland, essentially they looked at the patients that they had with confirmed Lynch syndrome and whether they were getting cancer or not getting cancer and at what rates. And it's a powerful study because it has thousands of patients in it, long-term follow-up. But what's missing is that we don't know how many of those patients actually got colonoscopy, exactly what interval they were getting it at. We kind of know what interval the countries recommend just based on guidelines, but guess what? Not all of us follow the guidelines. Not all of us can get colonoscopies at those frequencies, and really not much detail on the procedures. And we'll talk about why that's really, really important. But the early data on colonoscopy and Lynch syndrome suggested that actually it helps. Finding these polyps, removing them, early studies suggest that it could decrease your chance of getting colon cancer by 87% and dying from colon cancer by 94%. That's pretty good. Maybe a little bit skeptical with more recent data from the Europeans, though we have question marks about kind of the details of adherence to colonoscopy and quality of colonoscopy. But for those of you getting colonoscopy every year, why isn't this number 100%? If you're putting yourself through the bowel prep, taking a day off of life, family, work to get to your procedure, you'd think that that would be protective to go through all of that every year of removing these polyps. So generally speaking, right, if a cancer happens after we do a colonoscopy, it's probably one of three things. As Dr. Lynch mentioned, it's certainly possible, and probably the vast majority of the times, something was not seen on the first colonoscopy, whether it's a precancer polyp like I showed you, or even a cancer. It's also possible that we found the polyp and we did our best to take it out, but didn't get all of it. And then this really kind of area of kind of fascinating research and understanding of the biology of Lynch, and probably how things just grow faster in Lynch syndrome than the general population, so this rapid growth. So let's talk through these a little bit. As an endoscopist, when we are driving our scope through the colon, for us to really try to decrease the chance of missing things, I tried to really frame everything that we do in sort of two fundamental concepts. One is looking at things. So opening the hood, really trying to expand the colon, clean and wash away things, and make sure we're seeing and exposing as much of the colon tissue as possible. The colon is this dynamic organ with dips, dives, folds, and if we don't fully expand that and visualize it, we could certainly not even open the area that could have a problem. The other piece is actually recognizing the problem. So the hood's open, but what's actually causing the issue? And I think a lot of the things that we do in colonoscopy to try to optimize quality really are aimed at sort of improving these two things, exposing the tissue, and then once the tissue is exposed, really recognizing those even subtle things that could be abnormal versus normal tissue. So we'll talk about the things that we do right now to really optimize these things and what we understand about how they're related to cancer risk and Lynch syndrome. And then some of the new kids on the block that maybe your doctors are using or maybe around the corner. So this seems pretty intuitive, right? The whole point of the colonoscopy is to advance the scope all the way to the cecum. Obviously, if you don't get to the cecum and don't see parts of the colon, you have a really high risk of missing things if you don't even get there. So you'd think that that's really the lowest kind of bar or hanging fruit. There was a study published out of Spain from multiple centers across the country that were Lynch syndrome centers taking care of Lynch syndrome patients. And they collected data on about 800 plus Lynch syndrome patients who got colonoscopies. And in their study, they actually found that in real practice, that over 10% of the procedures done as part of this study were not complete to cecum. So that's pretty humbling, you know. I think it's not really the standard that we want to adhere to. And then when they looked at how a completeness of an exam was associated with things that we're interested in, whether patients get polyps on follow-up, whether they get cancer on follow-up, in fact, protection is on the right there, but those who had a complete exam were much more likely to be protected from having a risk of colon cancer in the future than those who did not have a complete exam. This is intuitive, but this study really demonstrated this. Okay, now I hope your stomachs are really settled. The bowel prep is really one of the most challenging parts of completing the procedure. It is really hard to tolerate that purgative, but it is so critically important. And you don't have to be a trained endoscopist to know that if you come in with a bowel prep on the left, there is a really strong chance that we're going to miss something very, very important if it's there. But honestly, even the picture in the middle there, there's a lot of debris, there's a lot of adherent material, and as much as time as we can spend with irrigating and washing, it's absolutely accepted, you know, no matter how much we do that, it's going to be a much more challenging exam than, for instance, the bowel preparation on the right, where the bowel prep is pristine and we just focus our efforts on examining. A lot of questions that I get asked and our GI nurses get asked, well, there's a million bowel preps out there, and each year it seems like you guys change my prescription. What's the best one? Which one should I be doing? And just tell me which one to do and I'll do it. Well, it's overwhelming because the bowel preps kind of change over time. And, you know, I think the way to kind of understand how to sort of decide depends on a few things, but we kind of divide them into what we call high volume preps. So these are those old school kind of 4 liter plus kind of large volume salty preps. And then these newer, lower volume preps that many of you use, some of them over the counter, many of them prescription. that are 2 liters, sometimes less, sometimes those with just pills. What's key is that no matter what prep you do what's called a split dose prep. And that is take half of it the night before and then wake up as early as you possibly can or set an alarm to complete the second half the morning of the procedure. Why? You haven't been eating anything, you're not making anything. Well, the body continues to sort of make waste product. And so that final second flush is what gives us this beautiful, pristine prep, especially in the cecum and the ascending colon, that's really now the standard of care. So that piece of torture, waking up to do the second half, is because of this. So what's the best prep if we just kind of compare them side by side? The reality is between the high volume and low volume preps, they both achieve about the same quality of bowel preparation. As you would expect, the lower volume preps, there's a little bit better adherence in our patients. The polyp detection rates are about the same. But what's really important to note is that, and as we would expect, the low volume preps are just so much easier to tolerate. And our patients, this last piece is super important for us, right? Because you've got to be willing to repeat, because your recommendation will be come back in 1 to 2 years. It's not, okay, I'm going to kick this can down the road for future Patel in 10 years. Like, this is going to be a 1-year issue. So that willingness to repeat is incredibly important. So I think the bottom line is, putting all those, commercial products aside, the best prep is the one that you can tolerate. And by tolerate, if you have side effects or symptoms, or the volume is something of issue to you, the taste, please talk with your provider. There's lots of ways we can work around that. And many of you can actually coach a newbie who's getting their colonoscopy for the first time, because you've already found all the tips and tricks. And the key is that we want to achieve any prep, no matter what it is, with the right results. And so what do we know what that looks like? Well, as gruesome as this is, if you see this or this, you got to keep going. And maybe that keep going is additional Miralax that you have at home, or milk of magnesia. And what we're really looking for is this, where you can see the bottom of the toilet bowl, kind of diluted Mountain Dew. This is really, really important, because not only is it associated with a easier to tolerate procedure, but it's also protective of developing colon cancer in the future. Inspection technique, this is something that we talk to our trainees about all the time. And so your doc really, if they do a good job of flattening down the folds, opening up the colon, cleansing and washing away debris, those docs have a higher chance of finding polyps than docs who have low scores on some of those metrics. What about actually recognizing polyps? So we've talked about what you can do to really kind of visualize as much of the mucosa as possible, but what about actually finding the abnormality when it's right in front of you? You'd think it'd be easy, right? You Google a polyp and it looks like a big mushroom in the colon, but the reality is actually a lot more subtle. Sometimes these polyps can be really flat. Maybe the only kind of clue is that they're a slightly different color, a different contour. And they can be really large and still quite subtle. And so, as you can see, for the untrained eye, they can be very difficult to detect. Do you see the polyp here? We can use lights to filter through the colonoscope to help delineate it a little bit better. And sure enough, that's a huge polyp in one of our Lynch syndrome patients. What about here? Do you see the polyp here? What about now? Right, there's the polyp. You can see how this would be incredibly challenging to detect without training. And the reality is, training does improve polyp detection. So really training our budding endoscopists to learn how to recognize these lesions is really important. High definition equipment. So what does this even mean? Well, if you look at the picture on the left, you see kind of the resolution of that image versus the one on the right. And the kind of most important analogy I can give you is just think about the technology in your cell phone and how it's evolved over the last 15 years. I'm an Android person, so I don't know if I chose the correct image here, but old school generation iPhone versus the photos that you can take with your iPhone now. And that's really exactly kind of the advances that we've seen in our magnification, our resolution. And so high definition equipment is critically important if we're talking about these super, super subtle polyps. And this same Spanish study showed that, again, in a somewhat contemporary practice, only 12% of these procedures were done with high definition equipment in Spain, and that high definition equipment, again, was protective of potentially developing colon cancer down the line. So chromoendoscopy, we'll just spend a moment on this because many of you have been subjected to this blue dye that you poop out for a couple days after your procedure. So chromoendoscopy is this chemical substance that we can spray into the colon. Then the concept was that it helps provide contrast to kind of help make it easier to see normal versus abnormal tissue. And there were a lot of early studies that were promising. And so we would do this all the time and, spray this dye throughout the colon. But more recent studies, especially studies done with this high definition equipment, really have not shown much benefit. And so I think, this was really then summarized where they took data from all of these studies, and in procedures that were done with high definition equipment, we now sort of practice by using this electronic chromoendoscopy, or with a touch of the button. If we need to, we can filter light to provide that contrast, but the spray dye we don't routinely use anymore. So now we'll just spend the last minute or so talking about some of the new kids on the block. You might see other tools that are used in the endoscopy lab to help improve exposure of the mucosa. There's all sorts of attachment devices that we sometimes use to kind of flatten out the folds or open up the lumen of the colon, balloons and things like that, even cameras that have, ports on the side to get more of a 180-degree view of the colon. And then, of course, artificial intelligence. We've known for a long time that the more eyes you have trained on that monitor in the endoscopy lab, the better you're going to be at finding polyps. And there have been study after study showing that if you have a GI fellow working with you, improved polyp detection and adenoma detection. If you have a nurse that has their eyes trained on the screen, improved polyp detection. So it definitely is of no surprise that if you are able to have a set of eyes that is not distracted by the music that's playing in the endoscopy room, or grabbing the tool that you need for your next procedure, or asking you a question, that if you have some way for artificial intelligence to essentially be that eye for you, these are now technologies that are on the market and that many practices are using, including us here at the University of Colorado and at the VA, that put these bounding boxes in real time while we do colonoscopy to help us find these polyps. And perhaps these are polyps that we would have found anyways, but anything we can do to push the quality of our procedure, we will do for our Lynch syndrome patients. It has to be in hands that can interpret it, okay? That looks scary. That's a lot of polyps. Well, at least that's what AI thinks. But in fact, that's just normal small intestine tissue. So sometimes you got to turn the box off depending on where you are. So just the last moment on incomplete resection. Like I showed you in those videos, polyp removal technique can be quite involved, and you really want to be in hands of somebody who does this at a high volume and knows the limits of their practice and when they maybe ought to refer to a colleague who has expertise in complex polyp removal. This was a pretty humbling study that was published where the doctors essentially took the polyp out as far as they thought was complete, and then they just biopsied the periphery of what they thought was normal tissue. In those biopsies of what they thought was normal tissue, 10% of polyps had precancer polyp under the microscope. So 10% incomplete resection rate. When they looked at kind of the medium-sized polyps 15 to 20 millimeters, 23% had residual precancer tissue in the peripheral biopsies. And then when we think about those sessile serrated polyps, the really subtle ones, the flat ones, that incomplete resection rate was almost over 30%. So this is a real issue. So I think when we think about these guidelines that our bodies sort of recommend and that we want to disseminate in the community, the key is not just the letter of what's written here, but to ensure that we're offering the highest quality procedure. And I think the bare minimum is that the procedure is complete to the cecum and terminal ileum, that there's an adequate but ideally pristine bowel preparation, that we're all using the latest high definition equipment. And certainly there are lots of cool bells and whistles, but that you really need to have a meticulous endoscopist. And sometimes that's hard to figure out. You can ask whether you use high definition equipment, or you can see on your report whether it was complete to cecum. But how do you know if your doc is in tune to what Lynch syndrome patients can develop and what to look out for? Well, I think these are some practical questions that you can ask your doctor, and there's no right or wrong answer to these questions, but their response will likely clue you in to their kind of familiarity with and openness to discussing colonoscopy quality. So adenoma detection rate is sort of a quality metric that we all measure among endoscopists. It's not specific to Lynch syndrome, but it's just a marker of quality. And if you have an endoscopist who says, wow, what a keen question. Sit down, let's talk about this. And I'll tell you my ADR compared to my practice and my patient population. I'm so glad that you're bringing this up. That can be a completely different response than if you get some resistance. And similarly, it's helpful to understand, well, doc, if you find a really, really big polyp in my 30-minute procedure that I have scheduled, what's our plan? You know, and just helping you understand, okay, well, I actually like the idea of you marking it, and then we talk about it, and maybe you connect me with one of your colleagues who specializes in complex polyp resection. So we've talked about sort of these quality issues in colonoscopy, but we all know that Lynch syndrome biology is unique, and Dr. Lynch reviewed this. We'll hear about it sort of referred to throughout the day, but a large part of what we understand about Lynch syndrome biology is that things can go rapidly and sometimes things can progress possibly through non-polyp pathways. And so it's really, really exciting that in addition to colonoscopy, we've got lots of other things to help mitigate risk. Aspirin, Dr. Lynch spoke about. Resistant starch, we'll hear about a little bit later this morning. And then really incredibly innovative research that's being done, including this vaccine trial, which we are participating in. So high quality colonoscopy is the cornerstone for risk reduction in colon cancer among Lynch syndrome patients. And although the bells and whistles really up our game, I don't think they'll replace a meticulous endoscopist, at least not yet, and hopefully not anytime soon, but I would be humbled to be replaced. Thank you very much.
This is Dr. Jill Aldridge. She is an assistant professor of gynecologic oncology here at the University of Colorado, and she is going to talk to us about cancer risk reduction in the setting of gynecologic cancers.
Thank you. Hi, thank you so much for having me. Here we go. All right. So outside of advising AstraZeneca on sort of what might be the future directions in ovarian cancer, I have no disclosures. So some of our goals for today, we're going to talk about just basics of endometrial cancer, who's at risk, what are the things that we can possibly change about our risk, and then the incidence of uterine cancer overall. We'll also talk about some differences in uterine cancer and ovarian cancer risks based on Lynch variant. And then we'll also talk about cancer screening options, some risk reduction strategies. I will briefly talk about hormone replacement, only because that's a very common question that I address for patients. And then I'll introduce pre-implantation genetic testing, which Dr. Rueka will go over later this afternoon in more detail. So just to get started, endometrial cancer is an enormous part of my practice, unfortunately. What we know is that the incidence of I don't know how to use the, oh, there we go. What we know is that the incidence of uterine cancer is one of the few that's rising in the country over time. We would really like to see the new cases of uterine cancer going down, not up. And we do know that within that also, we have racial and ethnic disparities, that this is disproportionately affecting women of color. All of this is unacceptable. And so we do have to look into what are the risk factors that put people at risk of these cancers and how can we modify those risks. So we tend to think of uterine cancer, just to do a little review here, in two different boats. There are low risk uterine cancers, ones that move slowly. This takes many, many years, if not decades, for these to develop through a pre-cancer mechanism and all the way to cancer. This can be an obesity-driven mechanism, which is probably why we have this increased rise right here. But these can also be driven by hormone replacement. So women who have their uterus in place and only take estrogen replacement for hormones and aren't protecting the uterus with progesterone, not having pregnancies, using tamoxifen, all of those things can increase the risk of these low-grade uterine cancers. We also know that there are high-grade uterine cancers. So these are going to move a lot more quickly, be a lot more aggressive. We do know that race is a part of this. Tobacco use can impact this, and then tamoxifen as well. Most Lynch syndrome cancers are going to be in this low risk group. So if we take a look, the population risk of endometrial cancer, so if we just look at the entire population of the US, the risk of developing uterine cancer within their lifetime is 3%, and the risk of developing ovarian cancer is about 1%. So low risks overall, and certainly that is different in our Lynch syndrome patients. that depending on the different variant of mutation, those risks are quite different. You can see that for women who have MLH1 or MSH2 cancers, that risk can be quite high, in the 20 to 60% range. And for those who have a PMS2 mutation, for example, can be as low as 15%. So those are going to be different risks based on different variants. And within the ovarian cancer risk group, MSH6 and PMS2 mutations look pretty similar to that baseline ovarian cancer risk, whereas MLH1 and MSH2 are going to have quite a bit higher risk, up to 10 to 40%. So when we're talking about our risk reduction options, we do have to think of it on a variant specific basis. And what we know, and I won't make you guys memorize all these things because we'll go over these lots and lots of times here on the right side. But just again, we have different risks within each of these different subtypes. The NCCN, which is our body that gives us these recommendations on a national basis, does recommend that for uterine cancer, this is going to be pretty standard across the board for each of these different variants. Symptom awareness is key. Consider hysterectomy, and we'll talk about what that means. And then considering endometrial sampling every 1 to 2 years, beginning at age 30 to 35 or 10 years before the earliest uterine cancer diagnosis in the family. So again, considering family history in our decision-making. For ovarian cancer, this gets even more complex. That really symptom awareness is key. And then we can talk about some potential hormone manipulation or surgery. In the context of MLH1, we can consider removing the tubes and ovaries. And we'll dive into that again here in a moment. MSH2 and EpCAM are going to be very similar guideline recommendations. For MSH6, I do want to point out that the only difference here is that risk of ovarian cancer is quite a bit lower in this cohort. And so there's insufficient evidence for the NCCN to support removing tubes and ovaries. PMS2 is in that same boat. So let's dive into that just a little bit more. So symptom awareness is tricky because unfortunately the symptoms of ovarian cancer particularly, but also of uterine cancer can be really vague. They can oftentimes mimic irritable bowel syndrome or menopause and so get ignored for quite some time. So for uterine cancer, I think it's really important to know that before menopause, bleeding that is not your normal should be a red flag. That can be bleeding that's heavier than your usual, bleeding that's happening in between periods, bleeding with intercourse. After menopause, no bleeding is acceptable, right? Even a drop of blood after menopause, we should be ruling out uterine cancer. So we just need to have very different thresholds for those two different populations about what qualifies as abnormal bleeding. But I've cared for women who are in their 20s who have uterine cancer. And so certainly it's not that you have to only have bleeding after menopause to fall into this criteria. It can happen with just periods are different. If any kind of discomfort or pain with intercourse starts to raise some red flags, or changes in vaginal discharge can also raise those red flags. For ovarian cancer, we often use this mnemonic BEAT to help us remember these symptoms because again, they're really vague. And we're looking for things like bloating, eating issues like getting full really quickly, having abdominal discomfort or troubles with bowels, particularly bladder issues, a little bit less specific. Now, all of these things we're all going to have, right? These are just normal parts of life. But if any of these symptoms were sticking around for more than 2 weeks, then we need to start worrying about those. So please bring those to your doctor's attention if you're having any of the symptoms on this list. As far as ways that we can approach screening in endometrial cancer, I think that it's important to zoom out just a little bit, that 85% of uterine cancers that we diagnose are early stage. So trying to do an intervention that proves that we save lives or that we let women live longer by doing that screening test are going to be really difficult because those uterine cancers are usually low risk, early stage, curable with our interventions much of the time. Proving that something really moves the needle on survival is difficult to do. And so I think we have to first and foremost recognize that we don't have a screening test that changes mortality, right? We don't move the needle on how women survive, but nonetheless, our governing body of OBGYNs and the NCCN support that we do screening nonetheless, because these are really low risk interventions, low risk screenings that have high bang for their buck, right? These are really high yield. Those 3 different things that we can do to screen for endometrial cancer outside of symptom awareness can be using ultrasound. This really needs to be a transvaginal ultrasound, not an abdominal ultrasound. And you can imagine that in women who are before menopause, where the lining of the uterus is changing day by day, this can be really difficult to interpret, right? When the lining of the uterus is thick and we're before menopause, what does that mean? So it's not a good test in women who are before the age of menopause. After menopause, it can be a more sensitive test. We can use it, but superior to that is endometrial biopsy. And I don't know that this picture gives you a good visual of this. I should have taken a page out of Dr. Patel's book and really shown you some anatomy pictures here. But endometrial biopsy is where we actually introduce this tiny suction tube. I would say it's 0.5 centimeter in width. And we introduce that into the uterus in clinic. So this is just something you do during a pelvic exam in the clinic space, not under anesthesia. And we basically just suction cells out of the lining of the uterus. That can be a very sensitive and very specific test. We have tissue under the microscope to tell us about normal, precancer, or cancer in the uterus. And that is far superior to ultrasound. Sort of the most definitive test is called hysteroscopy and dilation and curettage. Now, this requires putting a camera inside of the uterus and then scraping out the uterus with a sharp instrument. So you can imagine that's going to be significantly more uncomfortable for patients. We have higher risks of that procedure. Often we have to do this in a procedure center or in an operating room. And so that difference of sensitivity between endometrial biopsy and hysteroscopy DNC is not enough to put all women through this procedure. So really endometrial biopsy is the standard of care in this space. There are several screening tests that are under investigation at this time because we think we can do better than what we're currently doing. It's important to know that Pap smears are not intended to pick up uterine cancer or ovarian cancer. Pap smears are there to pick up cervical precancer or cancer. And so we are developing a gene panel that can pick up the same secretions that a Pap smear might pick up to look for uterine cancer signatures. So that's intriguing. That's not currently the intention of the Pap smear. This is a new development called Pap-seq. That's a gene test. They can also use a tampon test to pick up secretions in the vagina and do genetic testing on that as well, or using estrogen metabolites in the urine. So lots of things under investigation to either replace or augment biopsy of the uterus. When we're thinking about different ways to reduce the risk of uterine cancer, we'll start with hormone manipulation. The other name for this is chemoprophylaxis. So you may see those used interchangeably. And basically what we're doing here is we're telling the inside of the uterus to quiet down. And that can be done through the use of birth control pills or OCPs, injected hormones or implants with progestin hormones. When we're using those, we can reduce the risk of uterine cancer by 50 to 70%, or of ovarian cancer by 30 to 50%. So we're sort of killing 2 birds with 1 stone with some of this chemoprophylaxis. Progestin IUDs are actually one of the treatments for uterine cancer for women who can't have a surgery. And so we've mostly studied these in the general population. Again, there are smaller studies of Lynch syndrome specific risk reduction, but that we can reduce the risk of uterine cancer by about 80% using an intrauterine device. So if a woman's fertility goals are not yet completed, this is a fantastic option that can reduce the risk until those goals are achieved. We also know, mechanistically, how does this work is a little tricky, but we also know that intrauterine devices can reduce the risk of ovarian cancer as well. So again, really wonderful tools in the toolbox. Intrauterine devices aren't releasing enough systemic hormone to have any additional increased risk, like breast cancer risk or blood clot risk, the way that birth control pills may. So this is worth discussing with your doctor. We also know that the benefit of these continues to last even after that intervention is done. So even after the IUD is out or the birth control pills are stopped, that benefit keeps on going. For the most definitive risk reduction for uterine cancer, we talk about hysterectomy. And there was a big study published in the New England Journal of Medicine in 2006. And this is really the cornerstone for our evidence in this space. What they did is they took 300 women with Lynch syndrome and matched them with 300 women without. And they did surgery with hysterectomy, plus or minus removing the tubes and ovaries. And they saw that in women who didn't have surgery, 33% got uterine cancer and 5% got ovarian cancer. And in the women who did get surgery, 0% got cancer. I mean, that's pretty lovely evidence, right? And we followed those patients for a long duration because initially you have to think, well, did we just look really early and we caught these benefits? But this duration was actually followed out for almost 10 to 11 years. So we see that even over time that we can prevent cancers by removing these things. I do want to point out a really common point of confusion. What does a total hysterectomy mean? I can't tell you how many folks I meet who don't really know what was done, right? What does a total hysterectomy mean to a patient versus a doctor? So I just want to clarify that total hysterectomy means removing the uterus and the cervix. Anything past that, the tubes and ovaries, that's not part of the terminology for total hysterectomy. So it's worth clarifying with your provider, what hysterectomy did I have or will I have? What exactly does that mean? Certainly we can remove the uterus and the cervix along with the tubes, which we'll talk about in a second, or with the tubes and the ovaries. I do just want to point out a small caveat here. We haven't talked about risk-reducing surgery for colon cancer yet this morning in a lot of detail, but removing the colon or colectomy is something that we can consider for reduction of risk for colon cancer. And we're in the same space to remove the uterus, right? Removing the colon, removing the uterus, we're in the same zone within the belly space. And so certainly we can team up to do these things together to try to minimize trips to the operating room and minimize risk for folks. We don't have data on this. No one has done a study to look at, are patients happier? Do we have more complications? Any of those things, no one's ever done that study. I wish I had a fellow here and I could tell them to get on that right now. But we don't have this data yet. Certainly we do this in clinical practice and we have not seen any concerns about safety or feasibility. So I strongly encourage you to talk to your surgical team about this. Why not get this all done at once? Whether that's with a bigger belly incision or a minimally invasive procedure like a robotic surgery or laparoscopic surgery, we can do it. All right, we're going to shift gears a little bit over to ovarian cancer. So what we know for ovarian cancer is that no matter what we have tried so far, we have yet to show that any screening test helps people get diagnoses of ovarian cancer sooner or to live longer when they are diagnosed. So whether it's in the general population or even in like the BRCA1 or 2 mutation where they have a very high risk of ovarian cancer, we don't have a screening test. Pap smears do not detect this. We are just not very good at screening for this cancer yet. And so I just want to point out that things like ultrasound, looking at the ovaries, blood tests that are out there like CA125 blood tests, those may be things that you hear about. We do not have good enough data to say that we can screen patients with these things and actually do them any benefit. So we don't have a screening test for ovarian cancer. Some of this, additionally within the Lynch syndrome population, is that the cancers that do tend to happen in the ovary are different than the cancers that happen in the general population or in BRCA carriers. They tend to be more of a flavor of ovarian cancer called endometrioid cancer. Those behave completely differently. And so a lot of these recommendations about ovarian cancer, we're extrapolating from those other populations. We're saying those things probably apply to Lynch syndrome. But the reality is we don't have that data in Lynch specifically, and we don't have a good screening test for ovarian cancer. We can talk a little bit about the birth control pills that we talked about in that last slide, or intrauterine devices, that those are things that we can reduce uterine cancer risk and ovarian cancer risk at the same time. So those certainly have added benefits. But what do we do with the tubes and ovaries for women who do have Lynch syndrome? And I think that I'll just give you the caveat that what we call ovarian cancer is probably not ovarian cancer most of the time. It's probably fallopian tube cancer, the vast majority of cases, and rarely does it actually start at the ovary. So when we talk about opportunities to reduce the risk of ovarian cancer, what we can actually do is remove the tubes. And removing the tubes alone can reduce the risk of ovarian cancer 65% of the time. So even just taking out the tubes along with the uterus goes a long way towards reducing this risk of ovarian cancer. That can either be done at the time of hysterectomy or at the time of permanent sterilization. It doesn't actually change how that surgery goes. Removing the ovaries themselves, we can consider in women who have MLH1 or MSH2 mutations, like we saw, perhaps there's a lower risk of ovarian cancer if we do remove them. We have to weigh that against potential benefits of hormone replacement therapy versus risks of not being able to get hormone replacement therapy and having increased heart disease or bone thinning and fractures. There are consequences to taking out ovaries early, and we have to weigh that against the benefits. So these are conversations worth discussing with your surgeon. There are a lot of different risk reduction strategies on the horizon, as Dr. Patel alluded to, vaccines that are really exciting, anti-inflammatory medicines, whether it's aspirin or naproxen, immunotherapies, and all of these should also translate into the uterine cancer space. So we have our eyes on those for the future. And for those who just want a kind of consensus summary of our risk reduction and screening options, I have our NCCN guidelines summarized here for you. So for both endometrial cancer and ovarian cancer, your screening and risk reduction guidelines are all summarized here. Just briefly, I want to touch on hormone replacement therapy. This can be a really confusing topic for folks. So as a general rule, if the uterus is in, you have to protect it from estrogen. We can cause uterine cancer by giving people estrogen alone. So we have to be on both estrogen and progesterone to prevent uterine cancer if we're going to use hormone replacement when the uterus is in the body. If the uterus is out, fantastic. We can just use estrogen all by itself. And we do have data that says that use of hormone replacement therapy with estrogen in it can decrease the risk of colon cancer as well. So lots of food for thought. Dr. Roca later is going to talk about pre-implantation genetic testing. So I will not steal her thunder, but as an OBGYN, it's hard for me to not talk about some potential ways to impact future fertility. In the interest of time, I will not dive into this. Here are all the things we talked about today. I have to shuttle my children around this afternoon, so I'm so sorry to not be available later on in the day, but if you do have questions, please do let me know. I'm happy to see you in our GYN oncology clinic to talk about these things in more detail or to be available for questions. Thanks.
And next we have Patty. She's a registered dietitian here with us at the University of Colorado. I just wanted to take 2 minutes just to talk briefly about resistant starch. So Dr. Lynch mentioned it briefly, Dr. Patel mentioned it briefly, but along with the big study that looked at aspirin, they also looked at resistant starch. And so we saw in the aspirin group this potential risk reduction in colon cancer. But in the resistant starch group, though we didn't see that same reduction in colon cancer risk, we saw a reduction in risk for upper GI cancers. So reduced risk for pancreatic cancer, biliary tract cancers, the duodenum, and the stomach as well. So that was really why we invited Patty to share her expertise about how do we get resistant starch into our diet? What could that look like? And, you know, these are cancers that can be harder to screen for. So a 50% reduction, we think is really exciting potential new things to offer in the setting of risk reduction.
Hi, thank you everybody for having me. I'm Patty. I am a clinical dietitian at the Cancer Center, and I am available to see patients. Anybody who is a patient of UC Health at the Cancer Center is eligible to see a dietitian, in case none of you knew that. Okay, so diet and lifestyle measures to reduce cancer risk. Obviously, we're going to talk a lot about resistant starch, but I think I would be remiss if I didn't mention other diet and lifestyle measures you could take for cancer prevention. The American Institute for Cancer Research has done a lot of good research around these topics. These are their top 10 takeaways in terms of things you can control to help reduce your cancer risk. And this is just overall general cancer risk. And so consumption of red and processed meats, being a healthy weight, physically active, limiting alcohol consumption, all of the things you would expect. None of that is a surprise, I would imagine. The limit consumption of sugar sweetened beverage recommendation, I will say that's more in regard to the fact that the sugar is just empty calories and that it adds to a weight gain issue rather than a direct link between sugar and cancer. I always like to clarify that point. And so what we're going to focus on from here on out for the rest of my talk is the one on the end: eat a diet rich in whole grains, vegetables, fruits, and beans. That recommendation is up there for two reasons. The first is that plant foods have phytonutrients. Phytonutrients are these wonderful little things that we're not 100% sure how they're doing what they're doing, but they are helping to boost our immune systems. And so each plant has its own phytonutrient. And therefore, the more variety of plants in your diet, the more phytonutrients you get. And that's a good thing because the phytonutrients really like to work as a team. They really like to team up. And so the bigger variety of phytonutrients you get, the better job they do at boosting your immune system. And so that's one of the reasons that recommendation is up there. The second is because those foods are fiber containing. Whole grains, veggies, fruits, beans, legumes, lentils. That's where we get the fiber in our diet. I tell everybody fiber is like exercise. The benefits are endless. You can get, many, many different benefits from exercising. Fiber offers a lot of benefits for our health as well. To just go through a couple quickly, it would lower the risk of colon cancer, cardiometabolic diseases, type 2 diabetes, normalizing bowel movements, maintaining bowel health, lowering cholesterol, helping it achieve a healthy weight. So there's a lot of good reasons why I'm often telling people to get more fiber in their diets. So what is fiber? Fiber is a part of the plant that your body can't digest or absorb. The two main types are soluble versus insoluble. Although most of those foods listed up there contain some of both. It's hard to find a food that's just soluble or insoluble fiber. Most foods have a combination of the two. But the reason fiber is good for us is because your body can't digest it or absorb it. So resistant starch is a type of dietary fiber. To put it very plainly, very simply, that's what resistant starch is. It's a kind of fiber. Resistant starch digestion, this slide is to just show very simply, obviously, why it's helpful or why we think specifically for this study it's helpful. So the resistant starch in your food passes through your small intestine intact. And that's notable because the small intestine is where the bulk of your digestion and absorption takes place. That's where most of your food is being broken down. The resistant starch is just bypassing that and making its way into your large intestine. In your large intestine, the starch undergoes bacterial fermentation, which is good for its prebiotic effect and because it produces short-chain fatty acids. Very specifically, one of the short-chain fatty acids, butyrate, is specifically of note in terms of its benefits for cancer prevention. So this is a very quick, basic, here's why this is good. And then here's the study that you've all heard about already, where they did a 10-year follow-up. It was a randomized double-blind study. The participants in the study were given 30 grams of resistant starch a day versus a placebo group who didn't get any. They took the starch for a long time, up to 4 years in some cases. And the assignment to the starch group was independent of their assignment to whether or not they were getting the aspirin. And so the wording on that graphic is small, but if you can see the 10-year follow-up boxes, you can see what Lisa had mentioned, that there was a really significant reduction in the Lynch syndrome associated upper GI cancers. Not colorectal. There was no significant difference for colorectal cancer. However, gastric, small bowel, biliary, pancreatic, all had significant reductions in the group that was taking the resistant starch. Okay, so how do I get more resistant starch in my diet? This is not an easy thing to do. Not going to sugarcoat it. 30 grams a day of resistant starch is a lot of fiber. You have to think about the fact that resistant starch is a type of fiber. So most people, the average person, isn't even getting 30 grams of fiber total in their diet. Now, not only do you need more than 30 grams total, you need 30 grams of a very specific kind of fiber. So your total fiber intake is going to be well over that 30 grams to get you the 30 grams of resistant starch. So to be perfectly honest with you, this takes some work. This is not something that you can just, oh, I'll make my way through the day and I'll figure it out and I'll eat some fiber here and some fiber there. This is something that takes planning and coordination. And of course, my first thought when they asked me to present on, tell these people what they can do to get this starch in their diet, I was like, well, what did the people in the study do? Because they did this for years. And the answer is they took a supplement. They had it easy. The supplement that they took is not available to us here in this country. So it is unfortunately not an option for you in this room. And so I tried to find the easy way out for you guys and it wasn't there. So now you are stuck doing a lot of planning with your diets if this is something you want to choose to pursue. So, and before I go any farther, I will say if you haven't visited the research booth out there, they have a fantastic handout they've put together that contains all of the information I'm about to show you, which foods, how to do it, how many grams. It's a super helpful handout. So if this is something you're interested in, don't panic and try to write down everything on these slides. Just go get that handout. Okay, so the foods that are rich in resistant starch: legumes, peas, whole grains, wheat, barley, oats, plantains, and green bananas, specifically green bananas. Rice and potatoes are all really good sources of resistant starch in our diet. But resistant starch is tricky. The amount of resistant starch in a food can change based on cooking, preparation, and storage methods. So this is why I say don't panic and try to write all this down, because here is some things that change the resistant starch content of these foods. In some foods, heating and cooking them reduces the amount of resistant starch, so you don't want to cook or heat them up. Other foods, the process of cooking and cooling increases the amount of resistant starch. So that would be the russet potatoes, legumes, peas, and pasta. Rice, and specifically red and yellow potatoes, are best to consume after you've cooked them, cooled them, and then reheated them. Chilling cooked pasta for 3 to 5 days further increases the resistant starch in it. And specifically keeping corn tortillas at room temperature for 3 to 5 days increases the resistant starch. So you remember how I said I looked for the easy way out for you? I'm sorry. This takes planning. This is, like I said, this is not something you can just cruise your way through the day and get your 30 grams of resistant starch. This is something where you have to be preparing and planning and thinking about this. So we've got some tips for you that take these into account very specifically. So if you'll notice, canned beans are not something you need to heat and store and cook and cool and reheat. So they can be a nice go-to in terms of adding canned beans to basically whatever you could add canned beans to. So salad, soup, chili, salsa, substituting beans for ground meats in some of your foods. You're going to get a lot of resistant starch with beans. And again, they have less planning than some of these other foods. If you want to make a pasta or potato salad, specifically with russet potatoes, that works with these recommendations because you've cooked and cooled the pasta and potatoes. And so that will maximize the resistant starch. Snacking on roasted lima beans, roasted garbanzo beans, snacking on hummus, making overnight oats, because again, cooking oats reduces the amount of resistant starch. And if you're not familiar with overnight oats, you don't actually cook them. You prepare them the night before, put the oats in a container with milk of whatever kind, if you don't want dairy milk. And then you throw in other good things to make it tasty: fruits, cinnamon, vanilla flavorings, whatever you like. There's 1 million recipes online to help you plan your overnight oats. And so that's a way to get your oats in without cooking them, again, to maximize the starch. You could also include raw oats in energy balls or smoothies, adding green bananas to a yogurt or a smoothie, substituting rye bread in your sandwiches, because when you look at the different types of bread, rye is higher on the list of resistant starch content. Using long grain white rice, again, specifically that type is high in resistant starch. And trying plantains. Most plantains are cooked, which I recognize I said reduces the amount of resistant starch, but having plantains that aren't cooked is not necessarily for everybody. Cook and cool your yellow potatoes and then reheat them to make your mashed potatoes. Again, takes planning, but you've really maximized the resistant starch by cooking them, cooling them, and reheating them before you make your meal. A couple of things I found to help you guys supplement your resistant starch intake, because again, this is to get 30 grams through diet alone is not easy. Banana flour is very high in resistant starch. And so if you are able to kind of use this as a supplement to some foods in your diet, you're going to be able to get a few grams every time you can put a spoonful of this into something. So the somethings I thought of were putting it into yogurt, oatmeal, smoothies, using it as a thickener. You can stir it into stews or sauces, and you can, again, use it in protein balls. I took the liberty of finding a recipe for you. That website is in the corner, a website called From the Larder, and specifically green banana flour in these protein balls. So these are going to be a nice snack for you that's got a good amount of resistant starch in them. So if you start Googling, what can I do with green banana flour, you will find some ways to use it. And then, of course, like I said, you could be stirring it into yogurts, oatmeals, applesauce, whatever you don't mind stirring flour into. Obviously, moist foods will work best. The other little, I guess you would call it cheat I found is potato starch is also very high in resistant starch. The trick here is you can't cook it because then you'll break down the resistant starch. So that does limit how often you could use it. But if you use it as a thickener for custards, pudding, adding it against smoothies, applesauce, it works like the green banana flour does, and will just boost the resistant starch content throughout the day. And I, again, found another little recipe for you on a website called Meal Garden. There is a wild rice pudding recipe, and it uses long grain. You can substitute the long grain white rice and the potato starch, and then you've got a lovely rice pudding dessert that's going to be nice and high in resistant starch for you. So this is doable. I don't mean to make this sound like this isn't something that's achievable for you. That's something you shouldn't bother with because it's never going to happen. But like I said, it will take planning. It will take effort. You really do have to do meal planning, meal prep, and be mindful and pay attention. But certainly you can get the resistant starch into your diet if that is something you've put your mind to. I will finish up with a word of caution. I was worried I would take too long, and so I moved very quickly, but I will finish up with a word of caution. Increasing your fiber can often come with some bloating, some discomfort. And so I would like to just warn you, if you are going to work on doing this, you want to increase your intake slowly. You want to just do a couple more grams every day, every few days. You don't want to just suddenly go from where you are now to 30 grams of resistant starch in one day. You're not going to be happy with me if you do that. And also, I do recognize that the bloating and the discomfort and probably feelings of fullness are exactly what Dr. Aldrich told you were signs for ovarian cancer. So just keep in mind that if you're in the process of increasing your fiber intake, that may be the reason for these issues you're having. Hydration, also really key when you're increasing your fiber intake. You really don't want to increase your fiber and not increase your fluid because that's going to constipate you. And again, you're not going to be happy with me for telling you to do this. So make sure when you're doing this that you are also increasing your fluid intakes. Okay, and that's it. That's the end of my presentation. And again, the handout that they've put together is really excellent. It lists the different levels of resistant starch in different foods, which is not something I put on a slide because it would have just been a tiny little chart for you that you would have not even been able to read. So they've done a great job with the handout. So please go grab it.
So we have some time for questions. I'm going to invite the three panelists to come up, and you can either go to the microphones that are in the back there, or we can also walk around with microphones. So
is it okay to go? Okay. I think this question is for you, Dr. Patel. Some of us, myself included, have embarked upon a journey with Wegovy that slows down digestion. And when you think about bowel prep, what are the impacts and are there any recommendations?
Really good question. Really important medications that are increasingly be used for treatment of diabetes and other conditions that we now recognize slow down the GI system. And so the anesthesia societies as well as the GI societies are in the process rapidly of putting together specific guidelines for our patients to not only ensure that we achieve an adequate bowel preparation in the setting of these, but also safety of the procedure. Because what we're finding, for instance, when I do upper endoscopies and colonoscopies, is that normally not eating anything after midnight is perfectly safe, because then when I drop the scope down at 7 a.m., the stomach is empty. But for patients that are on these types of medicines, we're finding an increasing rate of stomach that still has undigested food in it from the meal prior. And that's the effect of the medication, in some ways intended. But obviously, we don't want that food to regurgitate up, go down the wrong pipes and cause aspiration. So Maureen, more to come on that, but we're in the process of putting together specific guidelines such that when we do our review with patients before the procedure, that's one of the high-risk medications that we look for, and we give specific instructions on how long to stay without food, whether there need to be any other dietary adjustments, and we're working with our anesthesia colleagues as to whether that medicine needs to be paused for a couple days before the procedure for safety purposes. So more to come. Thanks for bringing that up.
Thank you for coming and helping us work through this. I had a question about saturated fats and what role, if you are not a dairy eater or drinker, and you love coconut options, how does that impact, just as for saturated fat purposes? How does that impact somebody with MSH6, for instance, asking for a friend?
I don't know that I've ever seen anything that specifically talks about saturated fat with MSH6 or any specific, genetic variation, or I think that's more specific than our research has taken us. So I don't believe there are any specific guidelines around that currently. I would say that in general, saturated fat is not an issue unless you're running into, overweight, other things that would become risk factors to increase your risk for cancer. But saturated fat in and of itself, we don't have specific recommendations around the consumption. Tell your friend.
Hi, Dirk.
For those of us who've had our entire colon removed, is a starch-resistant diet still beneficial?
I don't believe it would be, because that digestion in the colon is really where the short chain fatty acids. Do you have a different comment?
Well, yeah, this was a really thought-provoking study, because the hypothesis was, because of everything that Patty said, was that it should decrease colon cancer risk, right? So that's why they designed the study that way. And John Byrne and his colleague, John Mathers, probably had a similar reaction as they did initially with the aspirin data, which was, damn. But what was surprising is that the upper GI cancer risk was low. Why? We don't understand how that would work based on what she said. The goal was to have this delivered to the colon and be a prebiotic and to create this butyrate compound. So the reality is it was a well-designed study. We believe the aspirin results, and I think we trust the design enough to believe the starch results, but the finding of why upper GI cancers was lower and not colon cancers, we don't have the mechanism or understanding for how that works. And that's really provoked a lot of work and interesting research in other kind of possibilities. So for instance, is it that the resistant starch kind of modulates or binds bile acid, which we know can sometimes promote carcinogenesis in the upper GI tract? Those are question marks. So Dirk, I'd actually say that if you can tolerate it post-colectomy, it'd be worth trying to increase your resistant starch content. And, over time, as we understand how and why it works, we can let you know if alternate anatomy would change that. Thanks for sharing your personal story.
Hi, thank you for all this awesome info. 2 quick questions. Is psyllium husk considered a resistant starch?
No,
Okay. Secondly,
sorry.
no, it's okay. Intermittent fasting, I've heard good things about that for, cancer prevention in general. Is that something to think about for Lynch patients or no?
I don't, again, they haven't looked at it specifically in regard to Lynch patients. The intermittent fasting, they don't exactly know, again, the mechanism of why that's helping, how that's helping, whether that surrounds, regulating blood sugar levels, whether that surrounds different hormones and things that are released. They're not 100% sure how that's helping. And so, that's a question mark as well. And so they haven't specifically looked at it in Lynch syndrome that I'm aware of.
This is probably for Dr. Patel. I don't remember the exact figures that you quoted, but the noticing of polyps during a colonoscopy was about 40%.
Well, in terms of the proportion of patients who have polyps,
yes,
it really depends on which patient population you're talking about. For average risk individuals, so your friends or neighbors who don't have a family history of cancer, don't have a hereditary syndrome like Lynch syndrome, when they come for their routine screening colonoscopy at age 45 or 50, for men, we tend to find at least one possible precancer polyp in 45 to up to 60% of patients. And for women, maybe just a little bit lower than that. For Lynch syndrome, we actually don't have really good high quality data to know how many polyps we should expect. Just based on what we understand, as intuitive, right? Probably the younger patients will have fewer polyps. Probably the patients with MSH6 and PMS2 might have a lower chance of having polyps than MLH1 or MSH2. So in Lynch syndrome, we don't have those percentage sort of expectations like we do in the general population. And that is a kind of a big arm of some of the research that I'm working on with colleagues across the country to try to establish with larger numbers what benchmarks we should be aiming for. We have those in the general population, not yet for Lynch, just because each subset of Lynch sort of, probably affects the risk of polyps.
Okay. I think maybe I asked the wrong question. This would be of polyps that are there, how many are noticed during the colonoscopy?
Yes, so the miss rate.
Yes.
So these are studies that have been done both in Lynch syndrome and the general population. So imagine consenting to do a study like this, but where patients undergo 2 consecutive colonoscopies. So a doc does a procedure, they know they're in a study, they take out as many polyps as they see, walk out of the room, and then another doctor walks in and does another colonoscopy. The miss rate for polyps can be as high as 30% in those studies. And those are really the most kind of pristine conditions, right? You're being watched. Now, the good news is that the vast majority of polyps that are missed, this is data from the general population, are usually small polyps, that for folks that might take 8 to 15 years to grow, probably not that big of a deal if a 2 millimeter polyp is missed. But in our patients, we can't afford to miss polyps if we can at all avoid it. And so those are why we do a lot of the things that we do to try to decrease that miss rate.
And then real quickly, of those polyps that are found, about 40% regrow.
Well,
that are resected.
Yeah, so about 10% overall could be incompletely resected. That's based on one study. There have been subsequent studies that probably estimate it around there. But that's on the data that we have based on the studies that have been done. Probably one last question,
and yeah.
Oh, and the last person up here, so that's good. I'm not sure exactly who to address this question to. I thought of Dr. Lynch, and so I thought I'd just throw this out here to you guys in case you have any perspective on it. There's a lot of discussion online about whether or not breast cancer is ever going to be added to a Lynch cancer diagnosis. And we were talking about this at our table earlier today, and I am just looking for more information on that. I'm not a typical colon cancer, endometrial cancer family. We have a lot of breast cancer, and it's just a looming question out there that I think a lot of us have.
I think I'm gonna end up perhaps being the best person for that. So I think that getting to the root of that is challenging. So when we are defining a hereditary cancer syndrome, we're doing that by looking at large populations and figuring out that, for example, Lynch syndrome is at risk of X, Y, and Z cancers. BRCA mutations are at risk of X, Y, and Z cancers, right? We're doing that by looking at large populations and what's happening more commonly within those groups of patients who have mutations. So those population studies haven't borne out that we should be including breast cancer as a at-risk cancer for this population. And I would say yet, right? That's an evolving process. And that, as you saw today, when we have multiple genotypes that we're looking at, lots of different variants, those cancer risks can be very different. And so when you take a larger group of women who have, or patients, who have Lynch syndrome mutations, and then you break it down into 4 different smaller subsets, I think it's just going to be harder to get you that answer. So for right now, I would say it's not included in our kind of typical risk approach. That being said, breast cancers are one of the most common cancers in the United States. And can women with Lynch syndrome still just get one of the most common cancers in the United States? Absolutely. Right? That we still have all of the risk factors for breast cancer that can make that happen in addition to Lynch syndrome mutations. So I still think that mammography and discussing it with your primary doctor about whether you are at increased risk, regardless of Lynch syndrome, is really important.
I totally agree with that. It's this pendulum, that initially we're like, no, it's definitely not a Lynch associated cancer. And I think, certainly with the emergence of multi-gene panel testing, I've had to sort of deal with a lot of these kind of surprising families, along with my GYN colleagues, my breast oncology colleagues, because they do multi-gene panel testing because there's breast cancer history. And there's a PMS2 variant or an MSH6 variant. And many of you that I work with, that's how we came to know one another. So then, there was some data that suggested, oh gosh, there is an increased risk of breast cancer in these 2 variants. But then once you really look at some of these other really strong risk factors for breast cancer and control for family history, kind of evaluate that, then it's unclear whether Lynch syndrome alone really drives breast cancer risk. But the importance is that family history, which might qualify you for more intensive surveillance on that basis. So I'm always humbled with what we'll learn in Lynch syndrome. So we might tell you an updated tale in the future, but that's where it stands now. So I think for the sake of giving everyone enough time during the break, we'll close here.
Yeah. So thank you to all our panelists. And lunch is outside in the lobby area. And then also during lunch, the patient advocate groups are going to be here and presenting. So if you want to grab your lunch, come back in, and more information to come. Thank you. Oh, yeah. I mean, I would rather about
Is it on? Check, check. Yeah.
Can I, oh, sorry, that was super loud. For our lunch panel session, for those of you who are our patient advocate speakers, we have your lunches pulled aside. They are over here to the left. So you can just come on up. Everybody else, grab a lunch and come back on in about 10 minutes.
Better loud. That is exactly it. I know, you either.
We're gonna put you right here. Yeah. Yeah, just here. You can close this in. Thank you for my shortness. It will be good. Should be. Okay. Does everybody want to take a seat and we will get started here? Okay. So, for those of you who want to join us, we're going to get started here with our lunch panel. Certainly, if people want to mingle, feel free to go out in the hallway. We are beyond excited to have such an incredibly rich panel of speakers for our lunch session today. These are our patient advocates. I talk to so many patients who say, how do I get involved? How do I make my voice matter? And these are individuals who have done exactly that. So the format, we don't have a lot of time. So the format for the lunch session will basically be each individual will talk about who they are, their organization, their mission for about 3 minutes. So kind of like speed dating, except we're going to do it in a different setting. And then really we want to have a good 15, 20 minutes where we can hear from all of you in terms of questions, patient advocacy. It is just so incredibly important. Every voice matters. And the more voices, the more we get done. So on that note, why don't we start with you, Marianne? It should be. That on?
Okay, now. Okay. Hi, everyone. I'm Marianne Pearson. I'm the Senior Director of Patient Navigation and Patient and Family Support at the Colorectal Cancer Alliance. It's a national nonprofit that supports patients and families going through colorectal cancer, but we also do screening for colorectal cancer patient navigation. And so I had to write down all the services that we have because there's quite a bit. But I've been in supportive oncology for about 20 years now. I'm an oncology social worker by background. And so I've supported quite a few families and patients along the way. We also do patient advocacy. We have a group of allies, hundreds and hundreds of families and patients that have gone through colorectal cancer that donate their time and donate their voice to make sure that we are meeting the needs of everyone that we can. And so the services that we have are patient navigation and screening navigation, but we also do we have a financial assistance program for patients and families to offset the cost of care. We also have a clinical trial and biomarker program through Clinical Trial Finders and a company that we work with to help people get tested for their biomarkers. We also have a peer-to-peer support program for mentors and mentees. So if you're seeking out to talk to another patient or caregiver that has gone through the disease, we have trained volunteers for that as well. And let's see what else we have. And then we also have this really exciting platform that we launched in January. It's called Blue HQ. It's a patient-facing and caregiver-facing digital platform that you can become a user in and get all the education, all the resources specifically for colorectal cancer, treatment, diagnosis, genetics, psychosocial support, all of that within a platform that you can navigate. We also encourage people to talk to their doctors. So we give them ideas of questions to ask their doctors when they're confused about their diagnosis, et cetera. But we also, the last thing just to remember about us is we have a helpline that you can call anytime and talk to professional navigators that can walk you through whatever is coming up for you or your family. So that's us. Thank you.
I'm Brian Schertz. I'm with Connect My Variant. I'm a molecular pathologist at the University of Washington by day. And the rest of my time, I'm trying to help families with hereditary cancer reach out to their relatives. So we're all about family outreach and not about your treatment, although we can point you the right direction to some of these other groups to help with your treatment. But we're about helping your relatives who don't know about their Lynch syndrome risk find out about it. So helping you talk to your aunts, uncles, cousins, brothers and sisters who don't want to get tested, children who aren't sure if they want to get tested, all of that, we want to help you do that. So we have family outreach navigators. We provide free genealogy assistance. We provide, and then the unique thing we do is we have a database that when we sign up, we ask about your specific variant, not just MLH1 or MSH2, but like the specific C.dot number. That coordinate, that address is actually could be a key to help finding more of your relatives. Because if two people have the same variant, then the analysis that we've done shows that 90% of the time they have a common ancestor. And so we use that data to connect people up. They can share their family history. Sometimes they find out they're third or fourth cousins. Sometimes it's harder to find out if they're related, but we can help them do like ancestry DNA or things like that. But we do everything we can to help you find out which side of your family your variant came from, so you can talk to your the right aunts, uncles, and cousins, the right second cousins even. And we've seen that people have been able to find 4 or 5 or sometimes even a dozen additional relatives who benefit from genetic testing. And we have the technology to prevent hereditary cancer. There's no reason why your relatives have to get cancer. If they can get genetic testing and get appropriate screening beforehand, then they might not ever get cancer. And that's really what our goal is. So that's what we do. I'm happy to talk more. We also have some equity and inclusion mini grants to give people who want to reach out to who are in groups that are underrepresented in genetic testing. And so they can have additional resources to help reach out to their families and to help find their families. So if you're interested in any of that, then do the QR code and sign up. Thanks.
I'm watching the clock over here. She tells me 1 minute, wrap it up. So I will make this as quick as possible. Name is Roger Miller. I'm with Catch It in Time, and we're a group of video professionals, either from broadcasting or corporate communications. And we want to tell the story of the cancer survivors. And our belief is it's not about the quantity of life you have after your diagnosis, but the quality of life. And so we want you to know that you're not alone, and we want you to share your story with other people so they know that they're not alone as well. We have about 9 million views on our stories, both with our website and with other associated websites from the people that we have their stories on, like a gentleman who's a pilot from Red Bull. So we have a lot of views off of theirs as well. We want to help you as an individual or your corporation, your nonprofit organization, help tell their story as well. And I'm kind of like the poster boy for Couch It in Time, because working with Keith, who founded this organization, I ended up noticing some stuff and ended up getting almost 4 years ago at Halloween diagnosed with esophageal cancer. And so that combined with the skin cancer stuff that I have, I'm not the poster boy anymore. I'm the poster senior for this organization. But we want to be able to help people tell the story about catching your cancer in time and awareness of it, and making sure that you know your body better than the doctors do. Let them know that you don't have maybe something in your family, but you may be the first one. It has to start someplace. I have 1 minute left. Oh no, I thought it would be the wrap it up stuff. So anyway, with my particular part of it, I've had so much of the skin cancer on the head and the neck and the forehead, a lot of Mohs surgery. And you know about that. If everyone who knows Mohs surgery, you've had that. I can't have any more of it. I now am going into the curly surgery and Larry surgery. No more Mohs. So that's Catch It in Time. We want to tell your story on video, and we also do live streaming of events as well. So we want to, for a nonprofit organization, if you have a big symposium coming up, we can tell your story via the live stream. Thank you.
Hi, everyone. My name is Joan Rush, and I'm the president of the Jacqueline Rush Foundation. My husband, Alan, in the purple shirt over there. We started the foundation after our daughter, Jacqueline, was diagnosed with rectal cancer at the age of 20. She had classic colorectal cancer symptoms when she was 16, but her pediatrician believed that you couldn't get colon cancer at that age. So it took 4 years for her to be properly diagnosed with rectal cancer. After she was diagnosed with cancer, she was tested for Lynch syndrome, and she tested positive. And so one of the reasons that we started the foundation was because none of our doctors had ever heard of Lynch syndrome, including my OBGYN, who should have known about Lynch syndrome. So our focus really is on education and awareness, both in the general population, but also in the medical community, especially the primary care doctors, because I feel that that's your first line of defense, really. So, you know, we're trying to put together some education programs in different hospital systems for primary care physicians. So the other thing we do is we provide education and support for Lynch syndrome carriers and their families. And we're building a community so that Lynch syndrome carriers don't feel alone. We have a lot of information on our website, and we really try to connect people with each other who have had similar situations so that they can really relate to someone else. How much time do we have? Am I good? 1 minute? Oh, 1 minute. Okay, let's see. One of the things too I wanted to say is I think in the education area, a lot of families, especially ours, didn't have a lot of cancer in the family. So they wouldn't have been a typical Lynch syndrome family that you would say, oh, there's Lynch syndrome in this family. So that's another thing we want to educate doctors and the general public about. Just because you don't have a lot of cancer in your family doesn't mean you can't have Lynch syndrome. And I feel that I know it's a scary diagnosis to have Lynch syndrome, and I don't know what that feels like because I don't have Lynch syndrome. But had we known Lynch syndrome is in the family, we truly believe Jacqueline would still be here today. So thank you.
Hi, my name is Robin Dubin, and I am the executive director and co-founder of Alive and Kickin'. Founded it 12 years ago with my husband, David, who is a 3-time cancer survivor. And when he first found out he had Lynch syndrome, we started looking for resources and found very little patient education resources out there. And so we've spent the past 12 years building out Alive and Kickin' to provide resources for the patient community. We have quite a lot of different patient education pieces. We've got our podcast, which has been running for the past 3 years, and there's over 100 episodes where Dave interviews patients to tell their stories, interviews professionals. There's actually a number of people in this room that have been interviewed on the podcast, including several on this stage. And some of the leading researchers around the world. That's been very helpful for both patient and professional education. We also have our Living with Lynch patient workshop, which we have an application process. Patients from all over the country apply every year, and we select a small group of about a dozen patients to participate in person. And we do that in partnership with an organization called the Colon Cancer Coalition, who runs the Get Your Ear and Gear races around the country. And we do it each year on the weekend of the Get Your Ear and Gear race in a different city, and partner with different academic institutions to bring their professionals out to speak to our patient group. And we also interview everyone, patients and professionals, on camera to develop video content for the website. So either aliveandkickin.org or livingwithlynch.org, we've got all of the videos that we've produced on a variety of different topics, from understanding what types of annual screenings to get, to getting your children tested. And all of those videos are content from the patients that attended our workshop. So it's their stories to hear in person. And I'll be here later if you have any questions. Thank you.
Okay, there's our slide. Hi, everybody. I'm an advisor to fight colorectal cancer. My name is Andy Dwyer, and I'm with the University of Colorado Cancer Center and School of Public Health. But I'm actually representing Fight CRC, and I want to share a little bit about why I have joined in with Fight CRC to help really frame and look at some of their research work, as well as that pairing with advocacy research and really policy initiatives. So about 6-7 years ago, I was really frustrated. There wasn't as much money coming to colorectal cancer, hereditary cancer, Lynch syndrome, as there were to many of the other cancer types, as dollars were devoted to from NCI, DOD, CDC. And I decided that I wanted to share my perspective about things that were happening in Colorado, things that were moving through, the country. And I had an opportunity to go to Call on Congress with Fight Colorectal Cancer as I host an annual kind of on the Capitol talking about colorectal cancer related issues, Lynch hereditary issues. And what really was interesting to me is in the time that I was there, I had a chance with a number of advocates and others to talk with people who were actually supporting legislation to start doing more work for coverage for colon and rectal cancer, Lynch syndrome, as well as people who were opponents, or not opponents, but were understanding really what were the reasons and rationale more dollars should be supported. And I think that really got me hooked on this idea of advocacy, on really showing the outcomes, telling the story, because we had real FaceTime with people who were senators, congressmen, legislators, lobbyists who were making those decisions. I had some chats with Angie Davis and really started to help develop what is called the Research Advocacy Training and Support Program that allows people who are patients, patient advocates, to really go through a formal process to understand how to advocate the science, how to be effective in communities, local, regional, and national, and really to help advocate for the issues that are related to rectal cancer, colorectal cancer, as well as some of the Lynch-affiliated cancers that we've heard so much about today. So I really want to focus that Fight CRC has done a lot with policy and advocacy. I've seen a number of advocates go through these training opportunities, be matched on panels. Lenora is one of the women that is a Fight CRC advocate who actually sits with the American College of Pathologists to talk a little bit about the uptake of screening guidelines for Lynch, sharing a patient perspective. Many of the other advocates that I know and work with are now very much related and really connected into some work that we're doing, where we're starting to look at ICD-10 coding, where hopefully insurance groups and others will still start to begin to really capture how big of an issue Lynch syndrome is, code these sort of information so that we can make system change and policy change. But before we can make these kind of initiatives move and really make it happen, we have to have people who understand advocacy, who understand policy, and really think about how their voices can be most effective in change. So even for this ICD-10 code situation, where it is related to insurance, systems change, in order to put Lynch syndrome as something that insurance companies, others really take serious, really think about coverage, obtaining data, we need people around that table to share their personal stories and impact, because that's what makes a difference. So I'm delighted to work with Fight CRC, who offers patient education, resources, a number of initiatives, a number of partnerships that people that sit here on this panel today. But I really do think that I have become someone who's very much involved in service implementation, research at the university. I've understood that really the opportunity to disseminate and implement and make sure things stick is through policy, but it really takes the voice of many of the advocates who have an opportunity to share that. And what I love about Fight CRC is they provide an opportunity, a platform to learn about that, opportunities for really getting that stage with people who are making a change, and really how to be effective at the state, national, and even local level. Thank you.
Thank you. Thank you so much to everyone for telling us who you are, what you do, your mission. I am truly in awe of what you all have done. So thank you for your efforts. Why don't we open it up to questions? We'd love this to be interactive. We want to hear from all of you in terms of questions that you might have for the different speakers.
I'm also a moderator.
I'm just thinking about the difference between going for your regular screening, a preventative screening with insurance companies, and then the minute that they find something, you are no longer preventative, it goes straight to diagnostic. And I don't know if your organization is working with that, because with most insurance companies, your regular screening doubles or triples in price in order to get that screening done, because they find one polyp and they have to test it. And it just seems like it might not come back positive or negative, but you're paying, so much, and it might interfere with people going and getting their regular screenings.
I think that's a good point, and there's others that can speak to this as well. So the follow-up colonoscopy bill that was actually passed last legislative cycle is supposed to specifically speak to that if you have follow-up in need for something where you're positive for a stool-based test, or there's something that's found, there should be that follow-up colonoscopy, that it's actually covered as a preventive cycle, not as a prevention, then turn diagnostic. There's also some Medicare loophole initiatives that we're supposed to be shored up as well. What I will say is, in legislation, those things are supposed to have happened. They're really in the implementation component, but there's still a lot of education that has to happen to ensure that that does happen. And I think that's where also policy and advocacy makes a big difference, is we have to make sure that those rules, laws are implemented and enforced. But I don't know, Swati, others, Lisa, or if anyone else has anything else to share about it. What I will say is, watching these processes happen at the federal level, where a lot of this was supposed to have actually taken shape and really been alleviated, there sometimes actually has to be a reinforcement at state houses that this is also something that should be enforced at the insurance company, because a lot of insurance plans are actually more geared towards state level and what's happening for that insurance policy. So I will say that I think that many of the organizations here spend time reinforcing, talking to legislators, talking to advocates. Providers are oftentimes people who are educated and also enforcing, because just because a law is passed doesn't also mean that it's implemented the way that it's intended. But yes, I think it's still kind of a bit of an issue, but some of the legislation that's come through is supposed to have actually helped alleviate that. But in full implementation, we're not there yet. It's a really great point. I don't know if anyone else has something else to add to that.
I just wanted to talk about like support for the young adults. And this kind of goes hand in hand with the insurance piece. So my son was 30 when he was diagnosed, off mom and dad's insurance. Now he's on his own. I have a survivor and a pre-vivor, and their insurance is like $350, $400 a month. Their deductibles are $6,500. They get screened every year. And all of that adds up. And it's almost like so mentally and emotionally heavy for them to even have to think about doing that. And then the cost of it all. And then you've got your deductible and your 20%. Is there anybody out there that can help with that type of situation? I know these 30-year-olds don't have, I mean, if your deductible's $12,000 and you're already paying $350, $400 a month, and that's employer shared, how do these kids do this? And then the other second part is just, where do the young adults get the emotional and mental support of it? My boys really struggle.
It's okay if I take that one? Okay. So there's a lot of national organizations that can help people with co-pays, co-pay assistance, deductibles. It tends to patients and their family members, depending on the cancer center they go to, should probably talk with an oncology social worker or a patient navigator that is at their cancer centers, or call someone like us so we could walk through those topics for you. It's hard, it's intimidating, it's overwhelming, and people get so discouraged because they're, like you said, emotionally drained. So that's why we're here. That's why supportive care at the cancer centers are there, is really to take advantage of that. The AYA population, or the young adult population, has a totally different level of distress after a diagnosis. So that's also something that most cancer centers hopefully have. If not, have them call us and we'll walk them through. Yeah.
Because I think Jack looked at Joan and others. One of the things though I think you bring up is sometimes the issues that are related to patients, unless it's brought to the forefront as an issue, sometimes I don't think people don't know what they don't know about insurance carriers and providers. And I think that's one of the things that I like about what Marianne said and others have said. But I think there's going to be opportunities, right? That if this is happening to your family, it's happening to other families. So I would also say that everyone here has an opportunity that if you share this information and it starts coming forward, it takes all of us to really help advocate for that. So if these concerns come forward, you have the codes, you have people's, because these are the things that need to be fought for. But if it doesn't sometimes reach that level, then people don't know. And if you think you're the exclusion, you're typically not. So I would just encourage everyone that you have, Michelle, you have the entire team, you have a group of advocacy folks here today. When you leave, really be thinking about what you want to do to make change, an idea you have, something that's an obstacle, because this is a group of people who could really help be reactive to that.
So I'm gonna go ahead.
So I also have two young adult pre-vivor children that are kind of in a similar situation. And as far as the psychosocial side of it, that is definitely something that is very hard to understand in that context. You're a young adult, and you haven't actually had cancer, so you're not an AYA cancer survivor, yet you're dealing with this cancer predisposition in a very adult way. And that can be very overwhelming. you know, my recommendations are to see if your support system, your providers, your cancer center has some psychosocial support options for individuals that, young individuals that have hereditary cancer predispositions. Sometimes that can help, but that's not always the way that they prefer to interact and receive that help too. So a lot of times it's really difficult to find that support. One of my sons became a mentor through an organization we partner with called Immerman Angels, and they actually connect both cancer survivors and previvors with mentors that are in similar situations. So he has been connected to others his age and with similar diagnoses that were looking for support. So it's one-on-one peer-to-peer support. Sometimes that's an avenue where they're more receptive to finding help and support by talking to someone else that's kind of in a similar situation to them.
Okay, there are a few comments about getting the word out, letting more people know. Just want to put another plug for family outreach. Your family members are the people who are going to be the strongest advocates. Right now, the statistics are that maybe somewhere between 10 and 20% of the people with Lynch syndrome in the United States know about it. So that means we're talking 80 to 90% of the people with Lynch syndrome don't know about it. And if everyone who knew about it could reach out to their aunts, uncles, cousins, second cousins, we can help you find out which side of the family it's on, then that gets you to about 80% of the people in the population. So almost everyone in the United States who has Lynch syndrome and doesn't know about it could find out about it if they knew about all of their relatives with Lynch syndrome. And if everyone who knows about Lynch syndrome, if everyone who's diagnosed with Lynch syndrome knows about it, then you also have to count their brothers and sisters who don't have it, and their parents and children who don't have it, but who are immediately related to them. That becomes a big chunk of the population, and that level of advocacy will change policy. And so yes, definitely, letting people know about it, but definitely go to the people who are in your families who haven't had genetic testing. Help them get genetic testing, and if you need help with that, then that's what my organization is for, to help with that.
This is absolutely wonderful, and this is exactly what we had hoped for. More questions?
All right. I'm wondering about international efforts for networking and advocating for Lynch syndrome, because, for example, I am an immigrant. I immigrated to Canada, and I've only lived in the United States for 23 years and have no other family in the United States. Are there efforts internationally, or how would you connect with family in other countries?
I certainly, for us, we were forced to be international very quickly because, hereditary disease does not respect international borders. So we have families that are, across different countries. We have one woman with Lynch syndrome who's an immigrant from Trinidad and Tobago, and now she has a cousin in Trinidad and Tobago who's, she found that she didn't know, but found on Ancestry, and that person has Lynch syndrome as well. And now the two of them are working together to figure out, to navigate a totally different healthcare system, totally different testing. So at least for us, then by nature, we're international because we have to be. It's very different depending on where you're going. In Mexico, they're just starting to think about hereditary cancer. And when people get diagnosed, they're oftentimes the first person who's if you think you're educating your doctors, then, but genetic testing is becoming much less expensive. We work with a laboratory in Algeria that's becoming the first testing company in North Africa to do genetic testing at all. Because of the cost of genetic testing going down, then this is becoming something that across the world, people are realizing that this is the easiest way to prevent cancer is focusing on hereditary cancer. And there are international groups, and at least for us, we're international, and we're right now our website's only in Spanish and Chinese, but we're looking at other languages as well. So if you have family, at least in other countries, then family outreach is very easy across countries, and with the internet, it works really well. Others might have other comments.
Just Andy, real quick, we have time for maybe one more question, and we want to give everybody just a couple minutes before the afternoon starts.
Talking here about some connectivity to the ability to pay world and the political world, if I may put it that way. Can somebody address the connectivity to the insurance industry? Is there outreach occurring to the insurance industry? And I'll only use the hundreds of thousands of dollars that was spent on my wife's case of care over the years, when if there had been somebody willing to pay more attention to emerging science, they might have saved a couple $1 million in the last 10% of her life.
I think what you bring up is an excellent point, because I do think right now they're the people who hold really the reimbursement and how people will receive care and how denials are happening. I will tell you that I do know that Fight Colorectal Cancer, especially with their policy group, are taking more and more discussions around roundtable discussions with insurance around coverage, around issues. There's more and more denials, right? I mean, even there's certain groups right now who are coming out who are actually denying moving that guideline from 50 to 45. And we talk about the science and what this really looks like for intake. So once again, yes, I think insurance industry and some of the other entities, it is a big part of, I know, what Fight CRC, Colorectal Cancer Alliance, and others. But what I would say is that for those of you who have a story, who have a voice, bring that, because that's what's going to make that change. I will impress upon people that really a lot of the questions today were really about insurance coverage and what does that mean. And I think that's something that we have to continue, and it is on the radar, but we need more of it. Yeah, so coding is tricky. Swati, I'll let you take that. I do think there is something around coding and knowing those codes and what that means, but it shouldn't be a matter of bait and switch, right? It shouldn't be like you use a code, you do this. There really has to be a comprehensive policy so that it's done and it's done well, and so that we don't have people who slip through the cracks because someone coded it incorrectly. So I do think there is something to the coding. I can't speak to it as a clinician, but I do think many of the initiatives right now that are policy advocacy related are also having discussions about insurance. What does that mean? Because ultimately, as the gentleman who just asked, and then your questions, this makes big difference in people's lives.
The only thing before we wrap that I'll add to that question is, from the clinician side of things, and I work with many of you on this, sometimes it's a game of whack-a-mole, that we find a code that works. We use it every year. Our nurse navigator knows it. And then all of a sudden, 2 years later, we get some, like Andy said, bait and switch. So yes, we will continue fighting the fight, writing the letters, whacking them as they come. But the bigger picture is working with organizations like Colorectal Cancer Alliance, Fight Colorectal Cancer, Alive and Kicking, all these organizations that are advocating for really quality metrics and policy level change, so that we don't have to keep doing this, because otherwise the goalposts change, the rules change on us.
Well, and as I have listened to all of you, and thank you so much for your time and for being here today. What keeps coming in my head is it takes a village. It really takes a village. I think so many individuals and their families, they feel like they're alone. It is a lot to process. It's a lot to deal with. And you are not alone. You've got a ton of organizations and resources and providers out there who are here to help you, and every voice matters. And what? Yeah.
Sometimes you advocate for yourself doesn't come naturally, or asking proactive questions that come because you're in a fear state or you're so overwhelmed. So please, if I could tell you anything, is to reach out to your physician, out to your cancer centers, your patient advocacy services. You have to ask the question too. We're here. We're here, but I was shocked. For 20 years, I built programs and people did not know they were there, like walking in the hall. And I like tried my best for 20 years and people would say, I didn't even know you guys were here. And I'm like, oh my gosh. And also when it comes to billing, there's care coordinators, there's billing coordinators. You kind of have to go find it. And I hate that for you because I want it to be very evident. So they also have insurance navigators. We do that as well. We might not have all the answers, but we can think of questions for you. So that's another thing just to remember when you're at your cancer centers, when your family gets diagnosed, when your friends get diagnosed, see what resources, search them out. I know it's hard, but they're there.
They are there, and it takes a village, and that is why we are all here today. This is an incredible village, and we are so thankful for all of you today. So let's give our panel discussion another hand. It is 12:13, and why don't we give everybody maybe like 5 minutes? Use the restroom, grab something to eat or drink if you haven't, and we will see everybody back here in a few minutes for the afternoon session.
Load them up for you. Oh, so I don't have to do anything? Don't touch anything? Yeah, don't touch anything. He's got it. He's got to load it up. And so Cassie just said she wants to walk around, so I'm going to give her like 2 minutes. I'm okay walking around. Either way. As long as I'll see it up there, I'm happy to walk. Oh, yeah, I'd rather not just stand here.
Because she doesn't. I can have a next time.
Is it, will this time?
But you'll get a little sick. Just have to pass. Yeah.
Flash my little sign right there and I'll make sure I make eye contact. Is this yours?
Yes. Okay.
I think we're going to go ahead and get started with the afternoon session. So if everybody can start to find their seats, please. My name is Lisa Koo. I'm one of the genetic counselors at the Hereditary Cancer Clinic here at the university. And I'm really excited to be moderating this second session. I think that there's already been a lot of interest in this particular topic, so it's going to be great. We have a really packed agenda with 4 different speakers. And we're going to be focusing, really talking about engaging your family and talking about the Lynch syndrome community as well. So without further ado, I'm going to introduce the first speaker. This is Cami Wolf-Schneider. She's a genetic counselor with the University of Colorado, she's working primarily in pediatric cancer genetic counseling, but she has also worked for several years with the adult population as well. And today she's going to be discussing Lynch syndrome in our young population.
Does it take a minute? It's working now. All right, great. Thank you, Lisa. And thank you to the organizers for inviting me. I'm so excited to see all of you today and be able to talk with you about children. How many of you have a child or a grandchild or another child in your family that might be at risk for Lynch syndrome, or maybe a future child that isn't here yet? Okay, so that's a lot of people. Okay, so we talk a lot about adults with Lynch syndrome. So I want to spend today, my portion, just talking about what things do we need to think about for these children you all raised your hands for. So just give a little background on genetics, and we'll talk about a few different things as we go. These are my topics we'll go over. So I know we mentioned earlier that Lynch syndrome is autosomal dominant. You are probably mostly all familiar with that. I'm not sure how many of you are really familiar with kind of the tumor genetics and kind of where this all factors in. So I just want to take a minute so that we're all talking the same language. So if you think about the fact that our bodies are made up of trillions of cells, in every cell of our body, anyone know how many genes we have? About 20,000 pairs. So it's a lot of information, little squiggles, in every single cell of the body. And every time our cells divide and copy into new cells, which they're constantly doing, they have to copy over all that information. So you can imagine with 40,000 instructions for our body, we expect mistakes to happen. And the more and more cells divide, the more those mistakes add up. And eventually that's what leads anyone to getting a polyp or a cancer or a tumor. Cells divide abnormally. And if the cells have the ability to spread to other parts of the body, that's what we call cancer. There are several hundred genes that we know about that their job, like the Lynch-related genes, are involved in stopping this process. So with these genes, the ones we've been talking about all day, everyone typically has 2 copies of them. With Lynch syndrome, usually 1 copy has an abnormality that's keeping it from working. You still have another copy that's protecting you from cancers and tumors, but you just have less protection than other people have that have 2 working copies of the gene. So what happens if when you've got 2 genes, both of them have abnormalities in them? So say you've got 2 parents and both of them have Lynch syndrome. Let's say you come to a Lynch syndrome symposium and you fall in love. It can happen. So if neither copy of the gene is working, then you don't have any protection from that gene. And that's true in all of the cells of the body. And you have this condition called constitutional mismatch repair deficiency, which was mentioned earlier. How many of you heard about this before today, walking in the doors today? Okay, only a couple people. So this is a recessive condition. When you inherit Lynch syndrome from both sides of the family, you have a different condition. You have higher risk for the cancers because you've got less protection. And we also see some physical findings. So have any of you heard of the condition called neurofibromatosis before? A couple of people have. So that's a condition where you can have things like brown spots on the skin, we call cafe au lait macules, freckling in spots that don't see the sun, like armpits and groin. Little Lynch nodules are things on the back of the eye. Neurofibromas are lumps and bumps under the skin. And tibial bone is in the leg. You can have abnormalities with when you're born with having an abnormality of your leg bones. So some of these features we can see in some of the people with CMMRD. So there's a lot of overlap. So sometimes the way people have heard about this condition is they think that they have NF1, but it's really this, but this has a higher chance of developing cancer. And then when you have Lynch syndrome in a family, you kind of look at the other way. You know, if I've got a partner that could be at risk for Lynch syndrome, is there a chance of having it? So the primary cancers that we see are hematological, which we haven't talked about at all today because we don't usually see an increased risk in heterozygous or 1 gene being abnormal for Lynch syndrome, but we see this in the CMMRD. We see brain tumors more often, and we see early onset colon cancer, so a lot earlier than we see with Lynch syndrome. So there are some published guidelines since 2017 that came together with 2 different publications, 2 different groups that have consensus guidelines on what we should do for children at risk for this. There are some discrepancies, and I will say the second one, I'm involved with an update that should be out next summer. So if you're worried about this or there's someone in your family at risk, there will be new guidelines coming out that shouldn't be too different. But some things to highlight, there's some differences as far as when you should start endoscopies, but it's early childhood, not the age 20 or older that we've talked about. We start MRIs of the brain at least by age 2. Some people say just at diagnosis, and then every 6 months. Some people say in the first year to start with head ultrasounds. When your brain's not fully put together with the skull, you can do ultrasounds instead of MRIs in the first year of life. And then there's a discrepancy as far as do you do urinalysis for screening or abdominal ultrasounds. But that's really what we do about it to prevent the cancers, or if they do develop, to catch them early so the outcome is better. Now, have any of you ever known a child with Lynch syndrome who's gotten cancer under age 18? Okay, so there's a couple. It does happen, and it's not always CMMRD. You can have Lynch syndrome present in childhood, but it's rare. I only saw 2 hands up because it's not very common, and therefore we don't recommend screening for cancer in childhood, but that doesn't mean it can't happen. So it's important to just be aware that even though we don't do anything about it for children, that there are some cancer risks to be aware of, so that if there is bleeding or some issue or symptom, that you go to the doctor and you check it out and say, this child has a family history of Lynch syndrome. We actually published a case series of different cancers that we've seen at Children's Hospital with pediatric onset cancers, and with only 1 mutation and not 2. So another thing that has come to light is, how do we decide you've got children with Lynch syndrome that have cancer, and then you've got CMMRD, but sometimes genetic testing isn't perfect and can miss things. So how do you decide if someone just has Lynch syndrome with a pediatric cancer, or do they have CMMRD? So luckily I had the opportunity to be involved in this project that was published a couple of years ago, where we kind of outlined how you decide if someone has a CMMRD diagnosis or not. And I think the most obvious is what I was explaining, where if you've got 2 abnormalities, 1 from each parent, that is what causes the CMMRD. But there's a lot of different ways people present where it's just not clear. And so there is a consensus out there as far as what we can do to try to decide what to do and what screening to follow based on that. So that being said, should we test children if they're at risk for things? It depends. So there's a lot of guidelines out there about the ethical and professional recommendations as far as should you test children for conditions where management's not going to change till adulthood. Things say, it's only acceptable to do genetic testing in children if there's preventive actions before adulthood. So really, based on screening recommendations, it's ethically appropriate to test for CMMRD, but not Lynch. But it's the same test, so that's a little complicated. There's also deferring pre-symptomatic and predictive testing in children is recommended. It's recommended to wait till they're older. It should be deferred is another recommendation. But there's an exception that might be made for families for whom there's diagnostic uncertainty, or there might be psychosocial burden. I don't know how many people in the room are uncomfortable with uncertainty, but that's a common thing that people feel, and our children feel that too. So there can be psychosocial benefit as well as psychosocial harm to testing children. And then there's also points made about facilitating predictive or predisposition testing of children for adult onset conditions can be justified in certain circumstances. So basically, children should have a right to an open future. And that, therefore, if you can delay testing, if it's appropriate, if they can wait, ideally we want to wait till children are older and can make their own decision about genetic testing. But there's a lot of circumstances and arguments for considering it. And really, that's where I advocate for genetic counseling, where we can really sit down and talk about in each child's circumstance whether it makes sense. So it also depends on the age of the child. There's different things throughout development that make each child's situation different. So if you test an infant for either Lynch or CMMRD, they have no awareness that they've even been tested at all. There's no way they can provide any assent or consent for the test being done. And they will have no recollection that it's been done. And the whole goal of why we're talking about everything today is we want to keep people healthy. So if you don't have the knowledge that you need to do things to keep yourself healthy, it's not very helpful. So you need to have future disclosure to them of letting them know that they're at risk. There's also, as children get older, they might have some understanding that they had some sort of test. Like, I remember spitting in a tube, or I remember getting my blood drawn, but they might have no idea why. And they'll need additional counseling as well. And there's, from a developmental standpoint, there's this, I mentioned uncertainty. I think that's one of the challenges as far as why people sometimes don't want to wait, because living with uncertainty through your whole childhood can be tough. And you can normalize things and say, you know, if you know your whole life what your risk is or is not, it's much more straightforward of how you can normalize that. However, then you've got this diagnosis that you're living with for a lot of years that you can't do anything about. Kind of take away the hope when you test too early. But you can also get a relief if you find out a child tests negative. As children are getting older, they may be able to concretely understand what they're being tested for and why, but child's brains aren't fully formed. So really comprehending and making an independent adult decision about it is not the same as testing a child whose brain is still developing. And then they're also, at least at some point, becoming reproductively capable. And so when you think about, 18 is really just a social thing that we put in the sand. Really, you're able to have children as soon as you hit puberty. And people that have hit puberty can have children. So when it comes to passing on a genetic risk, sometimes it's perfectly relevant to know whether you're at risk or not, if you might be having children of your own. For teenagers, the biggest job of teenagers is to form their identity. So when you test a child and they get labeled with something like Lynch syndrome, it's really important to think about how that may help or harm shaping their identity. There's 20,000 other genes in our environment and all the choices we make that make us who we are. And we don't want teens to make choices about who they are based on a genetic test result. And then there's also school. They've got a lot of other important things to be focusing on rather than genetics and medical things. So all of those things have to be factored into these discussions. Also, they're old enough to oftentimes want to be involved in the decision-making, having an opinion about the test, and having the results disclosed to them. And so it's an important consideration if a teenager is getting tested as far as how they want to get the results. Do they want the parent to get the results and tell them, or do they want the genetic counselor to tell them, or do they want it to be a group discussion? Those are all really important discussions. And then social support is really important too, in that we usually start screening for Lynch syndrome at about 20. So if you think about the trajectory of a lot of people's lives, 16, 17, you're technically a minor, but oftentimes you're still at home with social support. You're in your parents' environment where you have, like where you're going to eat and how you're going to get through the day and where you have to go for school and all that. When someone's 18 or 19, they're often trying for the very first time in their life to be an adult. And it actually may be not the best time compared to just a year prior when they're in a more structured environment. So I think there's some discussion to be had as far as if you're going to test sometime between 16 and 20, does it make sense to wait to 20, or maybe a few years earlier might be better, might not be? And you can also always just start colonoscopies at 20 if you're at 50% risk and not know your genetic status until you're ready. And then the last one is transition considerations, which I was just alluding to. But if you wait till 18, 19, it's a lot more straightforward from the standpoint of it's your own test, you own it. You can make your own decision about it without your parents, although I do see a lot of 18, 19-year-olds that their parents are still helping them make decisions, but legally it's their own right and it helps their privacy. So we talked a little bit about reproduction already. And we've seen the slide already talking about pre-implantation genetic testing, but I just wanted to go through a lot of people are diagnosed with Lynch syndrome. A lot of the time they're done with childbearing. And so we don't talk that much about all these options if someone's done with childbearing. So for people who are diagnosed younger, whether that's 20s, 30s, early 40s, or in childhood, we do have to think about what does it mean for the future as far as their options. So people that are concerned about their future reproduction have lots of choices. They can, like I mentioned, not test their children and just make sure that they get managed as though they are at risk so that we're being on the safe side and just get the management without genetic testing. They can stop the management if they do testing and test negative. If they want to test, there's lots of timing for that. They can wait till adulthood or when they know that they're at risk. They can test in childhood, like we talked about. They can be tested on cord blood right at birth. During pregnancy, they can be tested with procedures like, if anyone's heard of like a CVS or an amniocentesis, that can be used to test. Some people like to have that information for making decisions about the pregnancy. Some people like to just prepare as soon as possible. And then there's preconception testing, which is where the PGT comes in, where you use your own egg and sperm that you want to use in the lab and you test and you choose an embryo that maybe doesn't have Lynch syndrome. You can also use it as an egg or sperm donor or adopt or have no children. But there's lots of reasons people decide any one of these choices if they're planning a pregnancy. And then before I conclude, I just want to highlight a few other things. When you say, what about the children? I think there's a few other points to be made. So it's important to think about not just what does it mean for them to have Lynch syndrome or CMMRD, or to think about their future and their cancer risk, but it's also important to think about what does it mean for them when they've got a parent with Lynch syndrome or someone else in their family with Lynch syndrome. And so survivor guilt's really common. So whether or not they have Lynch syndrome, just knowing that they've got a parent going through anything that a parent is going through can be tough. There's the trauma of when they're seeing their parent go through some sort of surgery or procedure or struggle. There's also the issue of siblings, and that if some siblings are at risk and some are not, and how does it factor for each sibling differently? There's also the aspect when we talk about the genetic testing that decision-making is not just the person being tested, but it's based on the guardian or guardians, and guardians don't always agree. So it's important to think about that it's not an individual decision if there's multiple opinions. That genetic risk may be the same as the parent if it's been inherited, but that doesn't mean the story is going to be the same. I think this is really important, that a lot of people that may be the first one in the family diagnosed with Lynch syndrome may have had some sort of really bad experience. But when you get diagnosed younger, preventatively, hopefully the story is going to be much better with preventive options and proactive care. And then there's also 20,000 other genes. So we're not just one gene. So I know you all know that. But I think it's really important to recognize that there's a lot of guilt a lot of the time of parents passing a risk on, but you pass on 20,000 other genes that are probably amazing. And so a few other things to just be aware of is that there's a lot more people getting diagnosed with Lynch syndrome. We've talked about this a little bit today, but we now are testing so many people with cancer of their tumor and their inherited risks. And there's also people getting whole exome testing of all 20,000 genes for other reasons that may incidentally find Lynch. And then you may also present with NF1 type features and end up having CMMRD. And you may also have symptoms at an early age, and it may actually be related to Lynch. So in summary, genetic counseling, I'd recommend at any age. If there's questions, concerns, you want to talk about it with a professional, I'd recommend genetic counseling for someone. Everyone always asks me, since I work at Children's Hospital, when should I send my child? Are you worried about it? Let's talk about it, whatever age they are. If no one's worried about it, you can wait. But genetic testing is an option, just it's only under certain circumstances. Lynch syndrome can present in childhood, but it also is very rare. And because it's so rare, that's why we don't have standard surveillance. But it's important for you all to be aware for the children in your family that if there are symptoms, to get them checked out and to advocate, which we've talked about. And then there is a recessive condition possible with the mismatch repair genes. It is also very rare, but there is increased surveillance to keep children with CMMRD healthy. It requires both parents to have Lynch syndrome, or every once in a while there can be a de novo event, which is where there's a new abnormality in the egg or the sperm. but it's super duper rare. And then I think my last bullet was that there's physical features also that present with CMMRD. So I want to thank you all for your attention and for being here today. And I look forward to the panel.
Thank you, Cami. All right, our next speaker is Dr. Cassandra Roca. She's a board-certified reproductive endocrinology and infertility specialist at Shady Grove Fertility and an assistant professor at the University of Colorado School of Medicine. Today, she's going to be talking to us about family planning and Lynch syndrome.
All right, good afternoon. My name is Cassie Roca. Thank you for that wonderful introduction, for having me today. Aside from being a physician at Shady Grove and at university, I'm also the current chair of the Colorado Fertility Advocates. So as a dovetail to the prior session, advocacy is very important to me as well. Potentially you've heard of the Colorado Building Families Act, which the Colorado Fertility Advocates, we helped write and pass. That requires Colorado employers as of this last January to cover fertility preservation and infertility IVF treatment for people who have or at risk for medical conditions that will impair their fertility. So, you know, it's exciting things that are coming for Colorado, and there's more work to be done as it doesn't cover everybody, but definitely something to keep in mind as I'm talking to things that are, you know, quite expensive today, that there is hope for those who need them to have actual access to this. So today we'll be talking about Lynch syndrome and fertility, and then fertility options for both men and women, and then talking about fertility preservation as well as some financial considerations. So as you're aware and has been discussed, Lynch syndrome is an autosomal dominant, it's an inherited cancer condition. And so there are multiple genes involved, and these are several of the most common. And we know that some of the hallmark diseases of Lynch syndrome affect possible fertility and can cause cancers that will occur at younger ages and in those of reproductive years. So we know that up to 7% of colorectal cancer is going to be diagnosed in women before menopause, and colon cancer and endometrial risk, you know, lifetime is up to 61%. And then over 20% of the endometrial cancers will be diagnosed in reproductive years as well. There's a very elevated ovarian cancer risk, and the average diagnosis is in the early 40s. So we know that chemopreventative strategies can be used to try to help, you know, keep ovaries quiet. And things like prophylactic hysterectomy and bilateral salpingo-oophorectomy is recommended for those who have completed their childbearing. But, you know, it's just important to keep in mind that somebody's desire for future fertility really should have a big part in helping influence risk management decision-making for patients. And so there's multiple threats to fertility in patients with Lynch syndrome. So obviously having cancer during your reproductive years and having exposure to chemotherapy, radiation, or surgery are things that can impact people's fertility. Having risk-reducing surgery, you know, taking out uterus, taking out fallopian tubes, taking out ovaries. In general, we're seeing more people across the board delaying childbearing. And we know that the average rate of first child is going up now I believe it's 29. And so the risk of infertility is going to span all cancer types for all genders and ethnicities. And as my plug as an infertility specialist, it's just to say that we can't avoid the fact that age is tightly tied to our reproductive potential. And so considering these earlier on, really for anybody, but in particular those who are at risk for impact of, you know, infertility is important. And so maximum fertility potential is in your 20s in women. And we see that once you hit 30, it's just kind of a steady decline in fertility potential. And where we start to really see that impact fertility is in the mid 30s, where you start to see very increasing rates of miscarriage and infertility and increased risk for chromosomal abnormalities as well.
So it's important that options should be presented to patients and should be presented earlier on. And it's important to know that there are options for preserving or family building that can exist before or even during a cancer diagnosis and after, okay? And these are available for both men and women. And then we have multiple strategies that are available to help people meet their reproductive goals. And this can sometimes include third-party parenting options, such as using donor gametes or using a gestational carrier. And as has been discussed, there's options for genetic testing of embryos prior to transfer and implantation to prevent transmission of a known pathologic variant if people are interested in that. So different options can include, of course, natural conception, and then IVF with PGTM using either a donor egg from a known or an anonymous donor, using donor sperm from an unknown or an anonymous donor, donor embryos using gestational carrier adoption, and then fertility preservation with egg or embryo or sperm freezing. So, you know, natural conception, the classic birds and the bees talk. You know, you're just going to try and have intercourse around your ovulation window. About a week later, should have implantation. A week after that, a positive pregnancy test, and then, you know, hopefully healthy pregnancy from there. So whenever we're doing treatments for infertility, depending on which part of this process might be at risk or blocked, is where we can try to help aid our patients. So IVF is commonly known as in vitro fertilization, means under glass. So in vivo is the conception, the fertilization of sperm into an egg happening in life, whereas in vitro is happening under glass and technically in our petri dish in our laboratory. So it's going to involve extraction of eggs outside of the body, and then have sperm outside of the body, and then that fertilization event is occurring in the IVF lab. And then we would have an embryo develop that can then be transferred into the uterus of a patient or a gestational carrier. And any remaining embryos can stay frozen. At Shady Grove, we'll transfer an embryo prior to somebody's 51st birthday. And so a little more about pre-implantation genetic testing, which I know has been spoken about, but this is really a general term as recommended by the American Society for Reproductive Medicine. And so what it is doing is describing removal of cells from an embryo that are then utilized for subsequent testing. Right now, what we do is an embryo that's basically capable of implantation, which is a day 5 embryo called a blastocyst. We usually take about 5 cells from the trophectoderm layer that will become the placenta, okay? We don't touch the inner cell mass part that becomes the baby because we don't want to risk injuring the fetus. And so it's important to know this testing is about 98% accurate. And the hope is that over time we can do a less invasive test, you know, that's not causing possible potential damage to the embryo by doing that. But babies who have been born from PGT testing seem to be as healthy as those who are born spontaneously or without that. So it seems to be an all or none response. If it really does affect the embryo, it's likely just that embryo won't survive. But if it survives, it has just as good a health reproductive potential as its non-biopsy counterparts. So there's different types of PGT that you might hear about. PGTA is testing for aneuploidy. This is something we're recommending for patients who are maybe like, say, 35, 38 years or older, conceiving with IVF, and it's going to test do you have the correct number of chromosomes. And so are you 46XX, 46XY, or is there an extra chromosome 21, for example, something like Down syndrome to delineate any possible chromosomal abnormalities. PGTM is looking for a monosomic genetic disorder. And so that would be something like targeting, you know, a Lynch syndrome variant, for example, cystic fibrosis gene. So that's something where you're looking for that single gene disorder. And in order to do that, we have to know that that genetic disorder exists. So it will involve extensive genetic counseling and testing prior to getting to the point where we're able to actually test those embryos. And then structural rearrangements are for people who have balanced translocations within their DNA. And so because of, say, an autosomal dominant disorder, could affect 50% of the embryos that a couple creates. And so doing this testing can help to better identify, okay, which embryos are at risk, and help people make decisions if that's something that they would want to preferentially avoid transfer, for example. So it allows for family building options and people to make that decision, but obviously a lot of thought and, processing to go into making that. And then the process. So typically patients will come, have an initial consult and say, we know that we're carriers of this disorder and are hoping, not to transmit it to our offspring. And so then in collaboration with genetic companies, they'll have a probe created that's specific to your mutation, because there can be various sequence changes within a given mutation. And so they're going to look at your and usually first degree relatives to help map and make sure that they're looking for the correct inherited gene. Then once that probe is created, they'll go through IVF, which is about a 2-week process of injections for 8 to 12 days to try and get the ovaries to grow as many follicles as we can. Then with a 20-minute procedure under anesthesia, I'll use a transvaginal ultrasound wand with a needle attached, poke that through the back of the vagina into the ovaries, suck out as many eggs of those that I can that have developed. And then we'll do ICSI, which is intracytoplasmic sperm injection with sperm. Pick one good looking sperm and inject it directly into the egg, so we don't have other sperm in the dish that could maybe confound our results. And then we'll grow embryos over the course of 5 to 7 days. And any embryos that make it to that blastocyst stage, we'll do that trophectoderm biopsy. And then we're going to freeze those embryos. And then it usually takes 4 to 6 weeks for us to get the results back. And then once we know if we have good quality embryo, we can move towards transfer, which takes about 3 weeks, 2 weeks of uterine preparation to make a nice thick lining that the embryo can implant, and then 6 days of progesterone exposure. And then 9 days later, we do the pregnancy test. So that embryo cryopreservation is nice too, because then embryos can be available for maybe I don't want to get pregnant right now, but I want to in 5 years, or maybe we want to have several kids and have multiple embryos available for that. So using donor eggs or embryos, so this allows people to choose a donor, and it can be sometimes a family member or a friend, known donor, or an anonymous donor. If there are concerns about, again, passing off an inherited genetic disorder. Anyone, even if you've gone through menopause, even if you ended up having, ovaries out for whatever reason, can go through this again prior to the age of 51, because we can give you the hormones to support that pregnancy. And then donor eggs can be fertilized with gametes from a partner, gametes from a donor, to create embryos. So, you could use a donor sperm with your egg, or you could use a donor egg with your partner's sperm, if desired for family building. And generally, donor eggs are preferred to be from young people because they're going to have a lower chance for chromosomal abnormalities. And we usually see very high success rates with this. And then gestational carrier is using, somebody else to essentially carry the pregnancy. And usually we're doing single embryo transfer into gestational carriers to help limit any morbidity to the carrier, because we know that twin pregnancies are going to confer a higher risk to the carrier as well as the babies. These have very good pregnancy rates as well. And gestational carrier laws do vary state by state. So we work closely with reproductive lawyers as well to make sure that intended parents and gestational carriers are supported. But Colorado is very gestational carrier friendly and supportive for both protecting, again, intended parents and the surrogates. So there's, fertility preservation and the idea that, we need to be counseling patients about their fertility options before or at the time of cancer diagnosis is becoming much more common. And it's still underutilized, but there's been more awareness that, just because you're being told you need chemo in 6 weeks doesn't mean you don't have time to potentially do something to protect your fertility in those 6 weeks before you get that radiation and before you get that chemotherapy that might confer you infertile. And so it's important to educate patients, and we do a lot of work here with our fertility preservation team that's led by Dr. Leslie Apia through Children's and University, and then myself at Shady Grove, to get patients who have a new cancer diagnosis seen within 48 hours to make sure that they have time to get through potentially whatever it is, you know, we need to do to best help. And this goes for men and women and boys and girls. So we see, you know, kids and adults. So options again, embryo freezing. So, you know, people who have a committed partner or who have already biologic children who are desiring more can freeze embryos. Something that I always say is, you know, you just want to be sure that that's the person you definitely want to, you know, have kids within the future, because once those embryos are created and it's fertilized, that's a joint custody embryo. And that's something everyone thinks about. So it's always something, you know, if there's any question about retaining your reproductive autonomy, you know, then I would counsel freeze the sperm or freeze the eggs by themselves. And then you be certain, you know, with whom you'd like to fertilize those in the future. But embryo freezing is truly the highest, gives you the best chance of a live birth in the future. And we know a lot more about the reproductive potential of an embryo than we do just sperm or eggs alone. And so this is, you know, I would say in general, 45% you know, pregnancy rate per transfer, but really like if somebody's under 35, I would expect 65% to 70% pregnancy rate per transfer. So again, it's dependent on age. And this is a very proven technology. Egg freezing used to be experimental until 2013. And so now you're probably hearing more about egg freezing, you know, both elective and then for fertility preservation as well. And so generally to offer this, a girl will have to have at least signs of puberty or have gone through puberty. And I think the youngest patient that we've taken through this is 12 years old. But, you know, patients generally, if they know that they're higher risk, you know, might want to start having the conversation, you know, around the age of 18 even, and just depending on family history and different considerations, you know, maybe something where they're watched a little closely or sometime during the 20s, this is something that you would consider. And like I said, with the Colorado Building Families Act, if somebody is known to have Lynch syndrome, that should be covered for them to go ahead and freeze their eggs. Just depending, again, it's through your employer, and they have to be a Colorado employer who has 100 or more employees, and they need to be offering that for patients who are at risk, you know, for a disease that will impact their fertility. And so again, this takes about, you know, 2 weeks to accomplish. And usually if, so that, you know, I say, okay, maybe start talking about this when somebody's 18 in their 20s. And if you freeze eggs in your 20s, they're going to have a very good reproductive potential if you were to need them in the future. One of the risks of doing egg freezing, if you don't have an active cancer diagnosis, is you may never need these eggs in the future, right? So you might have paid and gone through this process for nothing. But it's like any insurance policy where, yeah, you're hoping you don't need it, but then it's there, you know, if you do. But freezing eggs earlier is going to give you a better chance of a live birth, as opposed to freezing later. We see a lower reproductive potential of those eggs and a lower chance of a live birth if you were to try and need them. No fertility preservation, no infertility treatment that I can offer gives 100% chance of a live birth. And then sperm banking, you know, typically this is reserved until there is a man or boy who has a cancer diagnosis. Unfortunately, prepubertal boys with a cancer diagnosis, the only thing we can offer right now is testicular sperm or testicular tissue freezing, which is experimental because they haven't yet produced sperm that they're able to ejaculate. But we do offer that at Children's. But freezing sperm is a lot simpler than freezing eggs, but sometimes kids, young men who have a cancer diagnosis are quite sick, and producing an ejaculate is not easy. And we have other techniques and even do sperm harvest with Tessie, where they can, under local or general anesthesia, go in and have sperm extracted that then can be cryopreserved for future. And so this is just, again, we can do egg freezing within about 2 weeks for those with cancer. And then this is just saying that it's safe for those who have undergone chemotherapy, have had cancer, to then get pregnant, okay? And they can have healthy pregnancies. Usually we want to wait, generally about 2 years from finishing your therapy before that. But there is a lot of hope for people who have had a young cancer diagnosis that, yes, they can complete family, building afterwards as well. So that provides a lot of hope for patients. Here are some of the costs that are associated. As you can see, surrogacy gets, now probably closer to 200,000. So there are a lot of cost considerations. So that's why we're doing what we can to try and help alleviate this for patients. And we work with a lot of financing as well as agencies that will help provide free medications for patients who need to go through this, who are thinking of a million things all at once and already have a lot of stress. So doing what we can to try and help ease that in a short amount of time. So wrapping it up, fertility-oriented informed consent should help guide decision-making in Lynch syndrome patients and discussions. And yes, so we're, again, SGF and University of Colorado working together to help serve this population. So wrap it up. Thanks.
All right. Thank you, Dr. Oka. All right. Our next speaker is Michelle Springer. You've already seen her a few times, but she's a certified genetic counselor here at the University of Colorado and one of my colleagues. And she's going to be speaking today about genetic testing approaches in family.
Is it on? Is it on? Okay. My session, just to give you all a little heads up, is going to be a little bit different. I am going to talk for about 10 minutes. I get long-winded at times, so a little bit longer. Talk about genetic testing in families, the idea of cascade testing. What do we know about it? What are barriers? And then the second half of my session, I want to hear from you guys. We can read all of these things, but the best way for us to learn is to hear from you directly in terms of what your experiences have been. So on that note, I have no disclosures. The nice thing about having Dr. Lynch and Cami and everybody go before me is that this is review. Benefits of genetic testing. It can help us explain the underlying cause of cancer in a family. It can help us understand other cancer risks and what we should be doing for screening and prevention. Treatment implications. This is huge right now. We do genetic testing in many newly diagnosed individuals because we know it can impact their treatment options. And lastly, what I'm going to focus on, genetic testing is a hugely important tool to identify family members who might be at an increased risk. I think you guys have seen this like 10 times today. Dominantly inherited, both males and females can carry it. There's a 50-50 chance to pass it on. And if an individual does not pass it on, their offspring then cannot pass it on. So it does not skip generations. Just out of curiosity, how many people have heard of cascade testing? Have heard that term? Okay, just a few. It is just our fancy way of saying testing in families where a mutation has been identified. It's a term that our field came up with a number of years ago, but really it is just the process of referring to a genetic counselor and doing testing in blood relatives of an individual who has tested positive. So we have a known mutation in the family, and now we think about testing all of those relatives. Generally, it is recommended that we do this in a sequential manner. And really what that means is we start with those closest individuals and then we work our way out. And really the premise behind this is that if, say, a sibling tests negative, their children are not at risk. It doesn't always happen. It's not always feasible, but that's kind of the preferred manner. And really the power of cascade testing, and you've heard this already, it helps us distinguish the carriers from the non-carriers. We identify the individuals who carry a mutation. We know that they're at an increased risk versus those individuals who test negative and we don't need to screen them. And Dr. Lynch talked about this morning in terms of, you know, before we had this, we were just screening all of those individuals. And then obviously for those individuals who do test positive, increased surveillance allows for early detection and even prevention. This information saves lives. What does cascade testing look like? This is how we think in the genetics world. This is a family tree. This individual with uterine cancer undergoes testing. She tests positive. We know that her siblings and her children are at a 50-50 chance. Her first daughter tests, she's negative. We don't need to test the children. Her other daughter tests, she's positive. Her son now, who is 17, is at a 50-50 chance. This would be the person I would then send to Cami, and she can have the discussion regarding, is testing right? Is it the right time? And then a sibling who tests positive, we know that their children are at a 50-50 chance. They undergo testing, so you guys kind of get the idea in terms of what that process looks like. The types of test results, and I included this because you're hearing a lot about how we are doing a lot of genetic testing using broader cancer panels. And that's partly why I include this. But one possible test result, they're positive. We know that they're at an increased risk. Increased screening is recommended, and their offspring are at a 50-50 chance. A negative test result, increased screening is not recommended based on the gene mutation. There's a big disclaimer with this that I will talk about in just a minute. But more importantly, for an individual who tests negative, their children are not at risk. This does not skip generations. A variant of uncertain significance, or a VUS, is something that we can possibly see if we are doing genetic testing beyond just that known familial mutation. So like Brian said, that C dot number, that specific variant that's in the family. And these are pretty common. Simply means there's a genetic change. We don't have enough data right now to know what it means. Our technology is ahead of us. These are common. It doesn't impact screening. We don't go out and test the whole family. The majority of them are ultimately found to be normal variation. Considerations, and we've already talked about some of these. Cami alluded to this, and I think it is so hugely important to remember. Family members who may delay testing or choose not to, it might not be the right time for them to test. They are still at risk and they still qualify for increased screening. This is something that a lot of families aren't familiar with. So if you have relatives who haven't tested, maybe they just don't want to know right now, they can still undergo increased screening. This is where that negative test result gets muddied a little bit. The presence of other non-Lynch related cancers in the family may warrant additional screening in those individuals who test positive or negative. And probably the best example of this is Lynch, or is breast cancer. We don't have any guidelines right now for breast cancer as part of Lynch syndrome. It's still very controversial. And what we know is that when we see that in a family, it will likely increase the risk to close relatives, and they may qualify for increased breast screening, whether or not they test positive or negative. So really important to kind of think about the cancers in the family, what's related to Lynch syndrome, and what's an outlier. And this ties in with another consideration, testing for a single gene versus a cancer panel. Like Dr. Lynch talked about this morning, what we know about technology is whether you test for one gene or a whole cancer panel, it's one and the same in terms of cost. So we need to think about, are there other cancers in the family that aren't related to Lynch, that are maybe, could there be another mutation in the family? What about the other side of the family history? An individual inherits 50% of their genetic material from mom and 50% from dad. So there's that other half that we need to think about. And this is really where genetic counseling and, you know, being able to really do a risk assessment is so important. This came up earlier, a hugely important consideration as well. How our genetic information is protected. It's protected by employers and our health insurers. They can't use it against us. There are loopholes. This is important for those individuals in the family who are thinking about doing testing. Get policies in place before you test. What do we know about cascade testing? Unfortunately, we're not doing as good as we could, is the bottom line. There have been many studies done looking at the uptake of testing in families. And what they uniformly show is that the rate of testing in at-risk relatives is less than about 30%. And this seems to hold true whether or not that information has been shared. So even in families where people are sharing this information, they're saying, hey, this is in the family, you guys are at risk. That rate of testing in at-risk relatives still seems to be low. And what we are finding is that there are barriers at multiple levels. And I've heard some of these concerns already in some of the discussions that we have, and we see them firsthand. There are patient and family level barriers in terms of financial, medical distrust, discomfort sharing information, the lack of awareness of risks and benefits, limited genetics knowledge. At the provider level, again, limited genetics knowledge. Time constraints. It seems like we all go into a doctor's office and they're looking at their watch and they're like, I have 10 minutes. What are your top 3 concerns? We need to do better. Lack of availability of genetic counseling support. We need more of us. Policies preventing direct contact of relatives. The same policies that help protect all of our genetic information, unfortunately, prevent us from reaching out to those relatives. And then barriers at the healthcare system level. When you see your doctor, they're focusing on your health, not your family's. Lack of availability of genetic counseling support. Costs related to screening. We've heard these concerns. They are very real. So what have we been doing as a genetics community to try and overcome these barriers? We are trying our hardest to come up with better resources. We hear you. We know that these barriers are out there. We're coming up with videos, patient family letters, chatbots, web-based tools, toolkits. A huge shout out to Connect My Variant for being here today. Brand new nonprofit organization. We need more resources like this. We need resources like Connect My Variant to help us have these conversations and increase the rate of cascade testing. So if any of you have not already been to the booth, please stop by Connect My Variant. Wonderful, wonderful resource. On that note, how are we doing for time? Oh, hey, I didn't ramble too long. My husband would have been proud of me. I would love to hear from you in terms of what have your experiences been? What has worked in your families to share this information? What are barriers? How can we do better? The best way for us to learn
is to hear from all of you directly. Yes.
Thank you. First, I just wanted to say thank you for the infertility talk. I'm a former gestational carrier, carried a little guy about 8 years ago, and I've worked as a journey manager for an agency for about 8 years. So if anybody would like more information about that, I'd be happy to chat about that later. I think for my family, I have a 19-year-old, a 17-year-old, and a 13-year-old. My mom was diagnosed with cancer and then had the Lynch diagnosis. Then I was tested, was positive, and then did some proactive things like getting a hysterectomy. And as I start to think about my daughter, who's the oldest, and talking about testing, I think the biggest concern and barrier for us is, what does that look like for life insurance and things that they may need down the road that I'm afraid they can't get? And so I don't want to jump into testing without knowing what they aren't going to have access to. And to talk to your concern with the, 10 years later, it isn't cheap for these kids to continue to manage their lives. And they're certainly not going to pay for some insurance plan that's expensive when they can't manage life financially anyway. And so I think that's a piece when we talk about the health insurance side, affording that's one side. But the other side is who's advocating for the life insurance and all of that side. That's something I just don't even understand, but I'd like to hear more conversations about that argument, and how we're protecting. Yes, let's get everybody tested, but hold on a second. What are we risking by saying, yep, my name is, and now I have a red mark next to my name? So.
Is this on? So this is a very, very common question from a lot of people. In 2008, the GINA Act was passed. So it's the Genetic Information Non-Discrimination Act, and it's a national law that prevents discrimination against individuals with a genetic condition for health insurance, but it does not cover life or disability or long-term care insurance. There have been a few states here and there who have gone further and passed laws in their state where it does protect individuals for life insurance. But in most of the country right now, life insurance can use this medical information to determine how much a policy may cost for you. And so we always tell everyone to get a life insurance policy, no matter the age, before you get your genetic testing, especially if it's someone who is unaffected and has not had a cancer diagnosis. And I can give you our own personal example, because we did not do this when our oldest son got his genetic testing and he tested positive. So when our middle son was old enough to have his genetic testing, we went to our insurance agent and said, we need to get a policy for him before he gets his genetic testing, but we also want to try and get one for our older son so our oldest was 22 and Lynch positive, and our middle son was 18 and hadn't had genetic testing yet. And we went out and had to fight the insurance company. We got the exact same $1 million whole life policy for both of them, and it cost twice as much for our older son, who was and still is a pre-vivor and has never had cancer. And they didn't actually specifically ask. Now this was 5 years ago, so things may have changed a bit, but they didn't specifically ask for any genetic testing results or any genetic diagnoses. But they do ask things like, has he had any diagnostic procedures? So you have to disclose that he's having annual colonoscopies or any other procedures that they may have. And then they dig in and they find that information out. So that's just kind of my real world example of
if you can do it, if your child is 18, gets a life insurance policy and then tests negative, you can make the decision to cancel that policy. But once they already have the testing, it's going to be a lot more expensive, even if they never have or get cancer. So that's
a great question, Dad. We definitely do hear that. Yes, Brian.
Well, I have two comments. One is that what we found is that the studies that say only 30% of people get family testing are really short-term studies. There hasn't ever been a study that's examined people for more than 2 years. And what we found in the families that we've interviewed is that this family communication is a process. It's not something that happens at one time. You get somebody who talks to their relatives, and then they talk to their other relatives, and somebody else tests positive, and they talk to each other. And so we're trying to get published a paper by a genetic counseling student who worked with us and interviewed a bunch of families and found that it was like a 4 to 6 year process, and maybe even longer for many families to do that family communication. And so in a year, maybe only 30% get tested, but that really should be really encouraging for everyone here. I've spoken with a few people who's already talking to their, who their brother won't get tested, to keep on bringing it up, talk about the Lynch Syndrome Symposium and what a wonderful time Dr. Patel has treated us to here. And, just whatever opportunities you have, bring it up casually when you see them. And over time, people get testing, people see new things, people learn more about genetics, and it becomes easier. So that's the one point. The other point I want to comment on is that if the insurance companies knew what they were losing, they shouldn't discriminate. Because if someone's getting the prevention that we've all heard about today, their risk of cancer is as low or lower than the general population's risk of cancer. And so if they're charging more, this community needs to find the insurance company that won't charge more, and then that company is going to make a killing because they're going to be charging the same rates for people who have low risk of cancer. So that's something I feel like who are the advocacy groups that are doing legislation? So somebody needs to talk to the insurance companies and figure out which one everyone can go to that isn't charging more.
Thank you. Very good points, Brian.
Okay, I think we're gonna we'll take one more comment and then we're gonna move on.
More of a quick encouragement to all of you. My son had cancer in 2020, is in remission now. Because of the geneticist at Children's Hospital, we found out that we have MSH6 in our family. And because of her work, we're saving lives in our whole family. We had no idea that MSH6 even existed. So our family's just really grateful for geneticists and oncologists and immunologists who saved his life and are now saving other lives in our family because of this information. And he's going to be that kid who the life insurance is going to suck, and all of this is going to be pretty rough. But without any of this, he wouldn't have had a chance. And then without this, my sister and I maybe had things growing that were not healthy. And so now we can get those taken out and all of those different things. So we're just really, really grateful for the advocacy of the people that work in this, and the prevention of the genetic counseling has saved multiple lives in just our family. And we're so grateful for that.
I so appreciate that. I often will tell my patients when they talk about genetic testing, when someone is doing genetic testing, they are truly giving their family the gift of knowledge. They really are. This is information that is important for the entire family. And while we can't change the genes that we've inherited, we can potentially change the outcome of what those genes do. And that is why all of you are here today. Yes, we know that our family has Lynch syndrome, but by God, we are going to do everything that we can to prevent it. So thank you for sharing your story.
Right, and we are going to have some time after our last speaker to talk a little bit more. So I don't mean to sound insensitive in any way, because I really do think this conference is all about all of you. And so I didn't mean to cut you off, but I do want to give some time to our last speaker for this session. who is Wes Hensel. So Wes is an individual with Lynch syndrome, and he's also a rectal cancer survivor. And so he is going to speak a little bit more about patient advocacy and talk today about his experience. Thank you.
Okay. Hello. I am a little bit out of place here, I feel like, but happy to be here and speak to you all. As she mentioned, I'm an MLH1 Lynch survivor. Also, thanks. Stage 3D colorectal cancer survivor as well. So this talk is going to be a little bit maybe pointed more in the colorectal cancer direction. But here we go. So I'll go through this quickly. I was born and raised in Las Vegas. I'm 40 years old now. I'm an engineer, so I've kind of turned into a program manager recently at work. So very busy job, and live in Broomfield with my wife, 2 daughters, 2 dogs, and 2 bunnies, a menagerie, and I'm very much outnumbered. So, and also a realtor in Colorado. So pretty small print here. I should have split this into a couple slides, but so this is essentially my story. So I was at the age of 30, started having rectal bleeding. I have no family history of any cancers. So I went to doctors repeatedly. It took 4 years to get a colonoscopy. It was always bright red blood. There was never any other symptom. You know, there wasn't really any reason necessarily to assume that that was what was going on. But eventually, after asking for a hemorrhoid banding procedure, found out through a colonoscopy at that point that I had a very large rectal tumor, 5 centimeters up. So, which explained why the blood was red and all of those things. So, you know, 34 years old, I wake up on the table. This was not on my radar even one little bit that this could be cancer. So, and then throughout the process, after that point, things started rapidly moving forward on, you know, starting radiation. But in parallel, I had the genetic testing, found out that I had MLH1. So I went through radiation and then some chemo. I did surgery and then a little bit more chemo after surgery. I went down to MD Anderson in Houston. Dr. Nancy Yu did my surgery. It was a very complex surgery. I had a deep pelvic lymph node involved that was difficult. I lived in Tucson at the time. And I was told by 3 different doctors in Tucson, and Mayo Clinic, all over the place in Arizona, that the pelvic lymph node was not operable. And I just trusted my gut that that was not true. And so went down to Houston. Dr. Yu said that it was, and we got it out. It was a very long surgery and did everything in one shot. I have a permanent ostomy now. But it turns out of all of the lymph nodes that were removed, that one was positive, and it was the only one that was positive. So it's been an interesting journey, let's say. So one of the things I was going to say about the ostomy is that in advocacy, that's one of the things that it seems like there's a little bit of a gap there in education on ostomy. Before my surgery, I knew very little about it. It was devastating to me to find out that I had to go with a permanent colostomy, and it couldn't be further from the truth. Honestly, I think that I've found that it is a very easy thing to live with. The quality of life is very high with it, and so I really try to focus on that when I do tell my story, do advocacy. So I'm 5 years NED now. So I just had my 5-year scan in July. So thank you. And it's interesting, right? You would think I would be fully celebrating that. Part of me is, and part of me is like, oh no, I'm not going to get scans anymore. So no, but I think it's very positive, and I'm very appreciative of all of the care that I've gotten. And so So advocacy. I started into advocacy kind of accidentally. It turns out I found out after I was diagnosed with the cancer that a neighbor that I didn't know that lived 3 or 4 houses down from me, that she was going through stage 4 colon cancer treatment, just coincidentally, also really young, like 32. And so she told me a lot about organizations like Colorectal Cancer Alliance, Colon Town, Fight CRC. I learned about them really early, like in month 1 or 2 after being diagnosed, which was really good. I connected with the groups that they have on Facebook and other means, and started meeting other patients and survivors. And that was invaluable to me through my process of getting treatment and just being able to talk with other people that were going through the same thing. But through that, kind of started getting more involved in, you know, events and volunteering, and just kind of, you know, snowballed a little bit over time, and just eventually just dived fully into it and started really just doing more in that whole regime. So, and then the last bullet point here is just a plug. So there's an organization called the Colon Club that does, every year they create an On the Rise magazine, and there are 12 of us that get to go out and have a wonderful retreat out in Tennessee, and we're models and they take pictures of us and we tell our stories, and they make a magazine. So there's a bunch of them sitting out on the table out there. If you didn't grab one, go grab one. My stories in so I think a lot of things were already covered during the lunch session, which is awesome. So some of what I'm saying here is probably duplicating that, but there are some things here that I think are important. Like I was saying, I think I had to start by just doing it. It feels to me almost like similar to what they say about having kids. You're never ready for it. You need to just jump in and do. So, and I think I was pretty uncomfortable with doing it, especially with sharing my story. But I think the more I did it, the more I realized how impactful it was. So I think I've had several times that I've had acquaintances that I hadn't spoken to in a very, very long time, barely even knew them really, you know, kind of high school people you had in a class one time, you know, and you're Facebook friends with them, reach out to me out of the blue and say, you know, I had symptoms, I read your story, I went and got tested and I found a polyp and they took it out, you know, and I wouldn't have done it otherwise. So thank you, you know. So just hearing those kinds of things, it just, you know, like gives you like the chill, seriously. So, you know, I think even though I'm 5 years out and I kind of choose to stay in this world, which, you know, it's a double-edged sword there. It's difficult to stay in this world too, because you form close bonds with people and there's a lot of loss. So, you know, I think the good outweighs the bad though. And I think it's really important to share stories, and it helps change policy and it helps change people's minds on things. So let's see. I think I covered most of the things. I think down here I have many ways to advocate. I think all of the organizations that were here talking today, you know, there are probably so many other things, but these are the ones that are top of mind, and some of the things that I've done. Having pairings with buddies or people that are in similar situations to you has been really a good thing. Political advocacy, I'll talk about that a little bit, because I went to Call on Congress with Fight CRC this year. That was the first time that I had done that before. I was very nervous to do that one in particular, because it is just, it's different, somewhat different from many of the other things that I had done before, but it was very surreal to be able to go to Capitol Hill and, you know, be able to go sit and talk with your representatives, and they want to hear you and they're interested in your story. And it really feels like it made a difference and changed some minds and helped, you know, policies move along that are going to help others. So really highly recommended to go do something like that if you ever get a chance to get involved in political advocacy. That was one of the ones that I think, more so than others, I had to really just jump in and do it because it made me nervous. So I think the thing I've done a couple times, for Colorectal Cancer Awareness Month is submitted a request to the state governor to get the state to proclaim the month of March Colorectal Cancer Awareness Month. And I didn't even know you can do that, but there's a process with every state that you can request proclamations. So this is an important thing. And so I've done that alongside with sharing my story through local news and kind of tying the two together. Actually, last year, Dr. Liu and I did a story together on Fox News. So it's out there. I should have put the link in here. I can probably get it in there. But some really good opportunities in March, particularly for colorectal cancer. Volunteering at events, 5K runs like the Get Your Rear in Gear. There's the Walk to End Colon Cancer that Colorectal Cancer Alliance does. Cologuard Classic is a big one. There are other golf tournaments that have been happening recently as well that are very, focused on fundraising and raising awareness for colorectal cancer. So research advocacy, another big one. I haven't done this one as much. This is the one that I'm really wanting to focus on getting more into. So that's why I was very interested when I was asked by Dr. Patel to do this. So, yeah, and so many other things as well. So I think, if anyone's interested and kind of hasn't taken the leap, please feel free to reach out to me. I can tell you my experiences. I can connect you to people in any of these organizations for the most part. And so, yeah. Any questions for me? I think that was all I had on here. Oh yeah, so I have some links in here, but these probably exist in a lot of other places as well. So this was just kind of the list of the ones that I had all the icons for on the other slide, but I've worked with all of these. They're all great. They all do different things. There's some overlap, but I think in general, they all kind of have their area that they focus on and shine. So thank you.
Thank you, Wes. Okay, I'm going to ask all the speakers from this panel to please come up and sit up here so we can have a little bit more discussion. If anybody has any specific questions that they want to start off with, or if we want to continue on with the discussion we started with Michelle's group, either way.
I just had a quick insurance question, I think, for Michelle. I learned something new today. Two of my siblings don't want to get tested, but I appreciated the information that even if they don't want to get tested, they still qualify for increased screenings. Does that apply to their children? Or is that only at this 1 degree level, or?
That is the son, yeah. That is a good question. Most often when we do that, it's to the individuals that we know are at a 50% chance. Now, certainly in some families, you may have, say, someone who's deceased and we're now at 25% chance. I think it would be worth a conversation. It is truthfully something that a lot of families don't know, that you don't have to do testing to start that screening. We have people who say, I want to get a life insurance policy in place. Maybe they're 21, 22, they're in college. It might not be the right time. People can start screening. I will tell you where it gets a little bit tricky though, is, say you have a female who is 35 to 40, and now we're talking about like the ovaries and the uterus. If we're getting to the point where like we're actually talking prophylactic preventative surgery, then we really want to have a test result. It is helpful because it's one thing to do screening in someone where, we don't know their genetic status, to do surgery and to have that risk. But certainly we see many families who do it. And it is definitely something that we talk about. We have a lot of families kind of hit the pause button and say, I need some time. I need to get life insurance in place. This may not be the right time. And we say, we can refer you and get screening started regardless. So thank you for sharing that.
I'd add that we see it a lot where the recommendation is screening and that the family's on board and the providers are on board. And when an insurance pays for it, it's a great plan. So what I actually experience more clinically is that our families are having trouble with reverse discrimination, and that it's that you can't get the screening paid for by insurance without doing genetic testing, as opposed to the other way we usually talk about discrimination. But that usually it's the recommendation to do the screening, even at the 25% risk, if you might be at risk. But it's hard, the further away you get, the harder it is to get insurance to pay for it.
Thank you. I think my question might be for Dr. Roca. It's two-tiered. My first question being, when thinking about IVF for patients of Lynch who have Lynch, has genetic testing of the egg and sperm donors become a standard? Because in the context of this conversation, we're trying to prevent then, having that that genetic mutation in our children. And the second part of my question is, since there is an increased risk for gynecological cancers in Lynch syndrome, are there any studies assessing the risk of increasing Lynch syndrome related cancers as a result of all the hormones and things that go into IVF?
Yeah, those are great questions. So when thinking about choosing a donor, typically like sperm banks, egg banks are going to exclude donors who might have a family history that's suggestive of a familial cancer syndrome. And anybody who's using donor gametes, we require to meet with a genetic counselor. So the intended recipients of those gametes also have to review the results of the genetic testing with a genetic counselor, so everyone's fully informed. And they'll suggest, this person seems to have a family history, suggested that they might require further hereditary cancer screening. And in those situations, often it will be up to that person to decide if they would like to have that risk or not. But a lot of the banks up front will say no, and that's an exclusion criteria.
Well, and with PMS too, that's sometimes a sporadic mutation, so family history may not be helpful.
And that's something where it's a risk, and no matter what, again, 20,000 gene pairs. So we know about one. That doesn't mean they're not going to be susceptible to something else. Anytime you're having a kid, there's risk, even if you're doing the gene testing or anything. So I think that it's always, but we do the best that we can with the information that we're given to make sure that patients are fully counseled. Like I said, that includes for everybody meeting with a genetic counselor. And then to your next point, so looking at, does IVF and infertility treatment, increase risk for ovarian cancer? Does it increase risk for breast cancer? Generally, things like the pregnancy state are thought to help prevent risks of those cancers. And we know that often data from infertility is tied to increasing age, which people who are older are already at increased risk of these cancers. So infertility treatment itself has not been linked to an increased risk.
This is a question for Michelle. So in the tradition I was raised in, you were encouraged to go to confession, and then you would tell, you would say so many Hail Marys, and then the priest would say, "Go now and sin no more." Well, I think genetic counseling and cascade testing is kind of like that. We find a mutation in a patient variant, and we basically say, "Go tell your family members," and then we just kind of hope they do the right thing. Okay, I think that's a terrible model, personally. There's so many bases for family dysfunction where we don't communicate for so many reasons. I mean, let's face it, everybody's got that crazy aunt locked in the attic, right? Or some equivalent of that. Somebody in the family that's just kind of cut off, that either we can't talk to, or they won't listen, or whatever. But there are studies, and I think I know where you're going to go with this, but there are good studies, mainly from Europe, that show that families tend to trust information from their providers more, and they would actually welcome the opportunity for the provider to be doing that outreach and communication, because I'm not sure what to tell my relative. I'm not sure they'll hear what I have to say. But if it comes from a reputable provider, nothing will get lost in translation. They're more likely to believe what they hear and so forth. And lastly, as I'm sure you know, in New Zealand and parts of Australia, that model's been adopted, and the providers, the genetic counseling providers themselves, are the ones that provide the outreach to the family members. And they have data showing that the uptake of counseling and of testing are much higher. In one slide, you showed that one of the provider barriers is that there are policies against it. The policies against providers communicating directly to relatives are baloney. I mean, there's no real foundation beyond we don't want to bother and we don't really have the resources to do it. So I think some of the things like connect the variant may be steps in that direction, but we need to really be, I think, as providers, we need to really be prepared to be much more proactive and participating when the family wants. Only with the permission of the index patient, obviously, HIPAA and all that. Only with the explicit permission of the index patient and the family are we allowed or able to communicate with other family members. But that's really all it takes is consent on the part of the index patient. And notions that there are policies against doing that, we're just making stuff up. And we need to do that. That's kind of my commentary on that. And if Brian wants to comment about how Connect My Variant may be kind of a step in this direction, that would be great. But I think there's a lot more we need to do. And advocates can help with that. So thanks.
No, thank you very much for that. You are 100% correct. We need to do better. We need to do better. And you're right. Some of the families say, hey, can you help me? Can you, we give, certainly written information, summarizing everything because it's a lot to digest. It's a lot of information. And, I think having that written information that they can share with their family members, but really helping these relatives then find those resources. Unfortunately, state licensure laws, they prevent, someone in one state from providing genetic counseling in another state. And that's a whole other topic because licensure is good, but it also creates another barrier. I can't provide genetic counseling to someone who lives in Ohio. But even though those barriers might exist, we know how to overcome them. And we need to do better. Get them connected with people who are there. I totally agree with you. We need to do better. Brian.
Wait, hold on.
Sorry.
Go ahead.
Dr. Lynch kind of stole my thunder. So that was one of the points that I was going to make. Just the, when we found out about Lynch and our family, it was because a lot of my paternal uncles, including my mom, were diagnosed with colon cancer at a very young age. So then that's when I felt like it was my responsibility as I'm one of the oldest of 50 plus first cousins. So I felt like it was my obligation to educate the rest of my family because there was lack of information, lack of resources, and also culturally. We found out it comes from maternal, so grandma. She was very offended that she had passed this on to her children. And so just the lack of information. And so I feel like, yes, more resources, more information, but also culturally sensitive. That's a huge lack or part that we're missing because out of all those 50 plus cousins, only like a handful of us have been tested. And even with our uncles, or like in my case, mom, who had cancer, it's just hard. When they sent me home with that booklet, I called everybody and not everybody followed through.
Thank you for sharing that. And I can totally appreciate where you're coming from. I will say though, and we talk about this in terms of the uptake of genetic testing being, 30%. I do like to think of it the opposite way though, and that is for those cousins, for those relatives that have taken your information and they have done genetic testing, every person that uses that information to test, you have potentially saved a life. And that is huge. It is, we're never going to get to 100%. It'd be wonderful. But no matter what our numbers are, yes, we need to do better. Yes, we need to provide our families with more resources, but every single relative that you can touch, you can truly save a life. So, Brian.
That's it. Thank you. No, but if there are barriers, like Dr. Lynch, you asked kind of, yes, it's a crime that genetic counselors aren't reimbursed for following up with family members because they're trained to do it, and that's what they do it. And so I mean, we started Connected America because we found no resources out there specifically directed at family outreach, and they need to be out there. And like all the other advocacy groups and all the physicians and genetic counselors here do their jobs really, really well. But this was a place we didn't find anything. And so every single barrier on that barrier list, you know, we're trying to, and actually for so many of them, we just very successfully say kind of this barrier, we're just going to eliminate it by providing the right resources for that specific situation. But what we found is that we can't do it on our own. And you know, we could have a family outreach navigator, but it really is we really need to partner with everyone in this room. And we need those partners, and we need and with the right resources, you can reach out to your family members. With your right resources, you can get your crazy uncle to get genetic testing. It might take 5 years, but you can. And with the right resources, you know, there's an amazing amount of things that we can do together. And then the other thing about the culturally sensitive communication, I wanted to follow up on that. There is no more culturally sensitive way for your family to receive information than receiving it from you. You know, no genetic counselor is going to understand your family better than you understand your family. And no doctor is going to understand your family better than you understand your family. And so when you think about that, then that, and if the optimal thing is for you to partner with your aunt or your cousin or your brother who also is interested in it. And that's really where we also see that, you know, don't think you're on your own. You know, find the other people that are in your family that have been tested, whether they've been tested positive or negative, and bring them in. You know, bring your spouse in. Some of the most powerful advocates we've seen are people who are the spouse and the parent of somebody who has Lynch syndrome. We see someone say, I'm going through cancer now. I can't talk to my family. And we say, well, talk to your brothers and sisters. And the brothers and sisters say, absolutely, I wish I could do something for my sibling who's going through cancer. And you've given me something I can do. Thank you so much for giving me something I can do to help, because I can't like go through chemo for you. So it's you know, that type of community building within a family is really, really powerful. And so there really are not barriers that can't be overcome. And most of those barriers don't take a lot of money. They just take a lot of care and time and conversations. Thank you.
I'd like to ask the audience if anybody has anything to share that they've done within their own family that they felt that was worked.
That's a great question, Lisa.
Yeah, this is my first time sharing this story, so it's going to be hard. But
we're with you.
My mom was diagnosed with breast cancer October of 2021, exactly 2 years after my dad was diagnosed with lung cancer. After that, I opted not to do genetic counseling despite the fact that my mom does have a positive BRCA mutation. I said, I'll just do the screening. Yeah, I immediately did a mammogram. 6 months later, I did an MRI, and that MRI saved my life. I was diagnosed with breast cancer May of last year. I did chemo. Please don't share this video. I'm sharing it with this group because I feel really connected with all of you. So after I was diagnosed with breast cancer, I went ahead and did my genetic
genetic counseling, they found a BRCA2 and a PMS2 mutation. Sharing the BRCA2 mutation with my family has been challenging. At one point, one of my cousins said to her mom, who also has it, "Oh, well, that's a great inheritance." It's a very challenging thing to share. And even if we do know our family, to his point, it doesn't make it an easy message to share. So we haven't done genetic testing on my dad yet. I don't know if my PMS2 is spontaneous or not, but I really rejected doing the genetic testing until it was obvious to me that it would be helpful. So if you're questioning it, please do it. It might save your life.
Thank you so much for sharing your story, and we all really appreciate that. Oh, hold on. We got one more person, and then we'll ask that question. How's that?
You asked if anyone had another story to share as far as what made a difference. It could have made a bigger difference had I seen more response, but I attended a family reunion after I found out about Lynch syndrome and having it, and having the additional information that my sister, who's 9 years older than I am and who had pancreatic cancer diagnosed before I got my uterine cancer diagnosis, then later found out she was positive for Lynch also. But we attended a family reunion that was my mother's side of the family. And if I had, because of the number of cancer cases in that side of the family, that's where I would think my inheritance has come from. But anyways, my mother's side of the family had 13 children and on down the line. So there were a lot of people. There weren't that many attending the reunion, but I still thought word of mouth would spread. And if I got through to even half of the 13 as family representatives down the line, out of that presentation that I made and saying, this is what I have learned and what I want to share, and if you have any questions, get in touch with me. I got 2 responses from cousins who were willing to go out and have their own testing. 2 of so many, but neither one came back positive. But still the word was out there. And so I'm just saying that's another avenue for people to get the word out if you go to a reunion to speak up.
So like, I'm taking this letter to the family reunion and we're going to talk about, I know it's not something that, like, talking about a colonoscopy, it's not something we're going to do at the dinner table, but that's, do it. You have to do it. And, oh, thank you. And the other thing that I will say, and Brian
had alluded to this, you know, I think in many families, it can be a domino effect where, okay, no, maybe you don't have everybody go out and do testing all at once, but you have one person who tests and then they talk to another relative and they're like, yeah, I should probably get tested too. That person gets tested. And maybe that person is, you know, they have a better relationship with Weird and, you know, Linda. And then she gets tested. Every single person that we talk to, it is truly a domino effect in terms of we're increasing that message in the family. And again, every person who does decide to test, that is potentially a life that we have saved. And so I have talked to so many of you today, and everything that you guys are doing, you guys are here for a reason. and you are doing all the right things. You let us know if there are other things that we can do to help your efforts, because it takes a village, and that is why we are here today. So
I just want to add to that you're all amazing advocates, I'm going to assume, and going through so much on your own that you can lead a horse to water, but you can't make it drink. So you can educate, you can let people know, but if they make their own choice not to listen, you can't hold yourself responsible for that. That's their choice. And I also want to add a resource for people that need access to a genetic counselor. Find a genetic counselor.org is a place people can go if they live out of state or somewhere else and are looking for a genetic counselor.
All right. Thank you, everybody. This was an excellent session, and I really appreciate this panel. So let's thank them again. We're going to take about a 15-minute break before the third session. During that time, I really encourage you all to please go and visit all the booths. Those resources that have been mentioned several times in the past hour and a half would be really encouraging to, just find out what else they have to offer. And then we'll maybe try the poop joke when we come back.
Your situation it was so hard. Yes, you know, otherwise, you're a lot of question. That's what we're trying to now I'm kind of hindsight and thinking I shouldn't have been. Well, we open it now because he was not at that time to be starting to yeah, the major will be that you say that we have problem. You would have gotten chemotherapy months. Maybe no surgery at all. Exactly. That's what I thought too, but after I'm not going to complain being 5 years, but it's like, and this has not been but it's not yeah. There's a lot of talk there. There are a lot of people. If I could, I would go. That's what you said, the breath. And if we just Anyway, you did a great job. Yeah, for sure. For sure. So anyway, yeah, thank you.
you know,
All right, I think we're going to go ahead and get started on our last session. If those of you who are still here want to start taking your seats. And if there's anybody out in the hall who can hear me, who's interested in coming back in, now would be a good time. I am acting on behalf of Jessica Berman, as she is out ill, as Dr. Patel mentioned earlier. So I am the moderator for this session as well. This session is going to be focused on treatment for colorectal cancer in Lynch, and we have two very wonderful speakers coming up here. So our first speaker is Dr. John Vogel. He's a colorectal surgeon and professor of surgery at CU Anschutz. And he's been performing surgery on patients with hereditary colon syndromes for the past 18 years. And today he's going to talk about surgical approaches to colorectal cancer in individuals with Lynch syndrome.
Well, good afternoon, and thank you for having me here. So this is me. And today I wanted to talk with you about what colorectal surgeons think about when they meet a patient with Lynch syndrome, to talk about surgical options. And, you know, we see patients in sort of two scenarios. One is they have a cancer and the other is they don't, and they're trying to prevent it. So these 4 points sort of outline the thought process. One is appropriate treatment of the primary tumor if they have a cancer. If they don't have a cancer, then it's appropriate ways of reducing the risk of developing a cancer. When we think about what operation to do, we think about the risk of them developing a second cancer if we remove a small part or a large part of their colon. And then we think about the morbidity of surgery. Different operations have higher levels of risk for complications. I'll talk about that more as we go on. And then for female patients, we think about what else we might do while the patient is prepared for surgery under anesthesia and having a surgery. So one of the things that I think about is the genotype of the patient, because I think by now everyone here is well aware that different genotypes are associated with different risk profiles for colorectal cancer. And so I do think about this. I think about this mostly when I see patients who don't have cancer and they're thinking about doing surgery for risk reduction. And I will also think about this with surgical decision-making, and I'll sort of expand on that as we go. So now for the patients that don't have Lynch syndrome, the patients who have sporadic colon cancer, which is, you know, obviously the majority of patients that most colorectal surgeons take care of, we know that just by removing the segment of the colon that's affected with the cancer and the associated lymph nodes is adequate treatment to treat the cancer that's present and leave the patient with an acceptable and manageable risk for a metachronous cancer. So this is an example of a sigmoid colectomy. Patients sometimes want to know when they ask me, how much am I going to be taking out? And I put my hands up and I say about this much. And they say, wow, that seems like a lot. The cancer is only this big. Why are you taking out this much? And the reason why is that we have to take out the blood vessels that supply the tumor so that we can get the lymph nodes. We need to get the field of lymph nodes that are associated with the segment of colon, which go along the blood, the blood vessels that supply the tumor. And I say, don't worry that we're taking out a piece this long, because your colon's really about this long, and you're really not going to miss a small segment. It really doesn't have any long-term negative impact on quality of GI health. Now, would be an example on the left side of the screen of a right colectomy for colon cancer. And again, it's that larger segment of the colon that's necessary to be removed so that the draining lymph nodes can go with the the specimen. We call that an oncological resection. So on the left side of the screen, it's a right colectomy. On the right side of the screen, it's a sigmoid colectomy. If we do that in patients with Lynch syndrome, we know that their chances of developing a second colon cancer, colorectal cancer, over the next 10 years is around 10 to 25%. And that's even with good surveillance. You know, in the studies that are listed up there, these are patients who have been, with known Lynch syndrome, that have undergone colonoscopic surveillance every 1 to 2 years. And so they're not patients that are really falling through the cracks. It's just, it can be hard to find these polyps before they turn into cancer. I think that's probably going to get better as the years go by, as endoscopies get better and high definition imaging is present and other ways to detect cancers. But this is where we are as recently as a couple of years ago. And so what other option can we do? The patient has a right-sided colon cancer, they have Lynch syndrome, and we talk about doing either just a segmental removal of the right side of the colon or doing something more. Well, it turns out that if a patient comes in with a right-sided colon cancer, a sigmoid colon cancer, a splenic flexure cancer, if you look at the United States Multi-Society Task Force guidelines and the American Society of Colorectal Surgeons guidelines, both of those societies recommend doing a total abdominal colectomy. I mean, moving essentially about 80% of the large intestine and then joining the small intestine to the rectum. Okay, it's not such a hard operation to do. It's really just sterile plumbing work. But the problem is that it is associated with a higher risk of complications of surgery. And it's also a quality of life changer. Because I think many of you probably know the colon doesn't do much aside from absorb water. It turns liquid waste into formed waste by absorbing water. That's pretty much it. And so what happens in this situation is you get liquid waste delivered into the rectum, and that is associated with more frequent bowel movements. 3-4 bowel movements per day is good. We don't see that until about a year after this operation. It takes a long time for the ileum and the rectum to adapt and to be more absorptive. We know in doing this operation, it really reduces your risk of developing another cancer. However, it doesn't make it zero. And you can see studies have shown that up to 8% of patients who have this operation will subsequently be diagnosed with a rectal cancer. I told you what the United States Multi-Society Task Force and the ASCRS would do. The UK guidelines, which were more recently published, took a slightly more nuanced approach. And they said, you know, if the patient has an MLH1 or an MSH2 defect, then yeah, we feel like we can make a real good case for doing a total abdominal colectomy with ileorectal. But in this setting of MSH6 or PMS2, they say, you know what, we can't make as strong a recommendation. And that's something that maybe we can talk about later. For patients with rectal cancer, now you're faced essentially with two options here. Do you just remove the segment, the rectum that's affected by the cancer, as you would do in a patient with sporadic rectal cancer, and leave all of this healthy colon, or do you do something more? So in sporadic rectal cancer, we just remove the rectum, the surrounding lymph nodes, we join the colon to the rectum. It's not such a life changer because you're leaving the rectum, and leaving the rectum is essentially the critical part of good bowel function. So, but how about in Lynch syndrome? Because that's really what we're talking about today. What's the risk of developing a second cancer? And should we do a segmental resection as we would do in a sporadic patient? Or should we remove the entire colon and rectum and give the person an ileostomy or do something called a J pouch? And this is a big decision, because quality of life, if you take out somebody's entire colon and rectum and give them an ileostomy, they're going to have a very normal quality of life, but it's going to be harder. It's going to be harder to go skiing and to go running and to go camping with an ileostomy. It's also going to be harder to do those things with a J pouch. J pouch allows you to avoid having an external bag, but people who have J pouches on the inside are going to the bathroom 6, 7, 8 times per day, one time at night. So I guess what I'm getting at is by removing the entire colon and rectum in Lynch syndrome patients with rectal cancer, it really is a dramatic change in quality of life. So if we just take out the rectum in Lynch syndrome and leave the colon, then what happens in terms of risk? Well, these two authors looked at their experience. Kalady and colleagues looked at the experience from the Cleveland Clinic, and Wynn and colleagues looked at their experience and found that patients who had just a rectal resection kept the colon at about a 15 to 30% risk of developing a metachronous cancer, increasing with time. So again, obviously, these patients need to be watched very closely. In terms of guidelines, the American Society of Colorectal Surgeons recommends just treating rectal cancers as you would in a patient without Lynch, because of such a dramatic quality of life change. And I guess what's thought of as an acceptable risk of metachronous colon cancer. But again, that's another thing that might be a good point of discussion. I wanted to just get in briefly. This is an area, I'm not an oncologist, but this I find this topic pretty exciting. These are a new pharmacological approach to treating colorectal cancer with drugs that are called checkpoint inhibitors. They're advertised a lot. Keytruda is the trade name for the drug pembrolizumab, which essentially allows the immune system to do its greatest battle against cancer cells. Cancer cells are trying to block the immune system from coming and gobbling up the cancer cells. These PD-L1 drugs are on the side of the immune system. They're helping them out. They're allowing them to go in there and devour cancer cells. This is really an exciting topic. This was a study that came from Memorial Sloan Kettering that looked at PD-1 blockade in mismatch repair deficient rectal cancers. There was no patients in this study with Lynch syndrome, but just to make a long story short, they treated these patients with these nasty rectal cancers just with this checkpoint inhibitor drugs, and they found that all of the patients, their cancers completely disappeared with checkpoint inhibitor therapy. Not one patient to date has had radiation or surgery. And so this is another really exciting sort of area of patient treatment and research in colorectal cancer, and it's going to play a role in patients with Lynch syndrome. When I take a patient with Lynch syndrome to the operating room to do a segmental or total colectomy, I'm also talking with my female patients about uterine and ovarian cancer risk reduction. I know that topic was covered earlier, so I'm not going to go over it again. I will tell you that the society that I sort of follow most for guidelines, again, which is the American Society of Colorectal Surgeons, their recommendation is that hysterectomy and bilateral salpingo-oophorectomy should be offered to women with Lynch syndrome undergoing colectomy, particularly if they have finished childbearing. And so to wrap it up and summarize, colorectal surgery considerations in Lynch syndrome, we're thinking about treatment of the primary tumor and how do we enable the best chance for risk reduction for a second cancer, and how do we try to have as little impact on the person's quality of life. I didn't really talk about prevention. I just recently operated on a patient who has Lynch syndrome, does not have cancer, has had a real difficult time with preps, colonoscopies, complete colonoscopies, the inconvenience, expense, and whatnot, and decided at the age of 42 to have a colectomy with ileorectal anastomosis. And obviously there's select patients who that is the most appropriate way to go. We talked about considerations of second colorectal cancer risk reduction, the morbidity and quality of life associated with different things we do, and then lastly about uterine and ovarian cancer. So that's all, and thank you. I'll turn things over to Chris.
All right, thank you, Dr. Vogel. Our next speaker is Dr. Chris Liu. He's a medical oncologist and associate professor in the Division of Medical Oncology at CU Anschutz. And today he's going to be talking about treatment options with Lynch syndrome for patients with colorectal cancer.
Well, hello, everybody. Thanks for taking time out of your Saturday to come talk about all these incredible topics and to hear these great speakers. And sorry, you got to end up with me, but we're going to talk about treatment options for patients with Lynch syndrome and colorectal cancer. And really over the next 15 minutes, this is what we want to talk about. Just want to give you a quick background. I'm talking to the experts, I know, but some background on colorectal cancer. We're going to talk about what makes patients with Lynch syndrome and colorectal cancer different than other patients with colorectal cancer. And we're going to talk about how immunotherapy has changed the landscape for of these treatments that we offer for patients with what we call MSI high colorectal cancer. And this encompasses those patients with Lynch syndrome as well. You've already heard a little bit about it from Dr. Vogel. But, you know, as we always do, right, we'll start out with a case presentation. And this is a real life patient, a 31-year-old female with no past medical history, presented with a 6-month history of bleeding that she saw in the toilet. And there was a palpable mass on the digital rectal exam. And so what does the colonoscopy look like? Dr. Vogel's already shown you some pretty tough pictures, right, from colonoscopies, but this is a rectal mass. And then, you know, biopsy confirms that this is a poorly differentiated adenocarcinoma. So this is a rectal cancer. This is what we typically do. We stage our patients with a CT of the chest and abdomen, and we get an MRI pelvis. And I'm showing you images from the MRI pelvis here on the left, showing this this mass here in the rectum. And, you know, that's one of the major advances, I think, over the past couple of years, is just our ability to get really, really great images preoperatively for our patients with rectal cancer. And this really can help us inform our patients, well, this is how we'd like to, you know, treat your tumor. And of course, you know, one of the things that our patient, and we'll come back to this at the end, is really sensitive about is that, well, she's 31. Not only was she told that she was too young to have colorectal cancer, but now that she's got a diagnosis, how are these treatments, if we are able to cure her, impact her life going forward? In particular, you know, what about her ability to have children in the future if we offer treatments like chemoradiation, which has a high risk of pushing somebody into early menopause? So keep that patient in mind. We're going to come back to that. So how big of a problem is colorectal cancer? Again, I know I'm talking to a very, very well-informed group, but this year alone, there'll be over 150,000 new diagnoses of colorectal cancer in the United States alone. So your risk in the general population is 1 in 3. And we also know that there are 1.54 million survivors of colorectal cancer in the United States right now. And that is an absolutely amazing number. What are some of the risk factors? There are some of these risk factors that are actually risk factors for all cancers. One that's somewhat specific to colorectal cancer is this diet high in red meats and processed meats and cooking meats at very high temperatures, which is, of course, something that I love. I love barbecue. But of course, why we're all here is this risk of family history, which includes familial adenomatous polyposis, and then, of course, Lynch syndrome, which makes up a fraction of our patients with colorectal cancer, but obviously a significant number when you're talking about over 150,000 new diagnoses every single year. These are the charts that as oncologists or as any healthcare provider, we want to be able to show you. And that is that the incidence and mortality from colorectal cancer is decreasing. And so this is what the curves look like in terms of incidence and mortality for colorectal cancer in our older population. And you want to see these curves come down over time. This is from 1970 to 2020, which is really great. Many of you in the room know that these curves are absolutely reversed in our younger population. And so you see this incredible increase over the last couple of decades in both the incidence and mortality from colorectal cancer in our younger adults, and CRC will be the #1 cause of cancer-related death in our young patient population by 2030. We are not the only country documenting this type of increase. We kind of want to think that, well, this has got to be a United States specific thing, but it really isn't. And so these countries that you see kind of called out here in Europe, even in Asia, Australia, and certainly in North America are all reporting higher rates of early onset colorectal cancer. And this is obviously something that not only has national importance, but has international importance. And again, something that this group is really well suited to improve the awareness of this major issue. So you'll see a couple of these take-home points over the course of my talk. The incidence of colorectal cancer in a young population is increasing. And, you know, these numbers are a little bit debated, but 20 to 30% of our young patients seem to have some amount of genetic syndrome associated with their colorectal cancer. But many of these cases in our early onset patients still are without a specific hereditary cause. Okay, so you had already heard me use the acronym MSI, or microsatellite instability high colorectal cancer. We're going to talk about why that's important, because all patients with Lynch syndrome have high microsatellite instability. I want to show you where colorectal cancer typically fits in terms of the number of mutations that they see. So when you look at colorectal cancer in the series of cancers that you see here, colorectal cancer is kind of on the right side of this curve, suggesting that colorectal cancer may have a higher prevalence of mutations compared to other cancers. Why is this important? Because the more mutations your tumor has, the more your immune system is attracted to it. And so, what is the importance of mismatch repair? And again, I know I'm talking to a group of people who probably understand this even better than I do, but the way I describe this to our medical students is as simple as this. If I asked you to transcribe War and Peace on Microsoft Word with an intact spell checker, how many typos would you have? You probably have a handful, but not a ton. If I asked you to transcribe that entire book without the use of spell checker, how many typos would you have? You would have a ton, or at least I would, right? And so what happens when your body replicates DNA is that sometimes there are typos. And so your body has to be able to recognize the typo, unwind the DNA, clip it out, replace it, and wind it back up. And we call that mismatch repair. And when that's intact, you get less mistakes in your DNA replication. But when that mechanism or that spell checker is broken, you get a ton of mutations. And we kind of denote that as high microsatellite instability. So what does that mean practically for our patients with Lynch syndrome that have MSI high tumors? Well, a typical colorectal cancer will have somewhere between 30 and 70 mutations in any particular tumor. But in our patients with deficient mismatch repair, or MSI high, and this includes all of our patients with Lynch, the number of mutations can be about 1,700. That is a huge fold increase in the number of mutations from microsatellite stable colorectal cancer to MSI high colorectal cancer. So what does that mean? Erica has heard me use this analogy before. It means that you have T cells that are in the tumor that have been turned off. And the way I like to describe MSI high tumors is that you have the dance floor, which is the tumor. You have people on the dance floor. That's your immune cells. Those are all the brown cells that you see here. They're just off. Nobody's dancing. There's no music. And so really the big advance in immunotherapy for cancer has really just been to turn the music on. And I'm going to show you the class of medications that Dr. Vogel's already talked about in terms of immune checkpoint blockade. So we know that there are a lot of genomic markers now that we look at in colorectal cancer. This is where you want to see oncology go, where we're starting to divide up this pie for colorectal cancer and be able to offer personalized therapy. And our patients with Lynch syndrome that are MSI high represent a sliver of this pie. But the question is, well, if you have the dance floor, you have people on the dance floor, can we start the music? Dr. Vogel's already shown you a slide suggesting that we can turn on an immune cell by blocking this interaction between programmed death ligand receptor 1, or PD-1, and PD-L1. And so what happens is when that connection is made, I love this cartoon, it turns off the T cell. So this is the tumor, the pink guy here, the blue guy is your immune cell. And what happens is when that connection between PD-1 and PD-L1 is made, T cells asleep. This is overly simplified, I know, but this is how I see this interaction in my brain. This is the PD-1 checkpoint blockade. It basically gives your T cell a hat so that the tumor tries to knock the T cell out, but fails, or you can wrap up the stick in bubble wrap and essentially prevent the T cell from being turned off. And that's all these drugs are. They're just antibodies to block this interaction. So what has that meant in real life? So this was the study, the seminal study from Johns Hopkins, which was not funded by Merck, by the way, was actually funded by a patient advocacy organization who believed that maybe there is promise of immunotherapy in MSI high colorectal cancer. And what you see here is essentially tumor shrinkage over time. When you hit 100%, it means that you can no longer see the tumor radiographically. The green are our MSI high patients. These are patients that are inclusive of our Lynch syndrome patients. And then the red are the patients that are not MSI high. So the red bars do not include any patients that, do not include any patients that have Lynch syndrome. This is not only effective in colorectal cancer, but it's effective across numerous cancers. And so you're seeing here responses and pretty incredible responses in prostate, pancreas, endometrial, you name it. If you're MSI high, you can have a pretty impressive response to immunotherapy. So what does that look like in real life? We show patients their CT scans in our clinic all the time, and it kind of looks like a jumbled mess, right? But you can kind of make out the liver here. You can make out the spine and the spinal cord here. The patient's belly is here. The patient's back is here, and they're laying on the table. Here's the patient's spleen, and you can see this gigantic mass here. And patients actually can feel this, right? She told me that she could kind of feel that tumor pushing up against the abdominal wall. After 8 weeks of immunotherapy, Dr. Vogel had talked about pembrolizumab, which is immune checkpoint blockade. That's what that tumor looked like after 8 weeks. We actually ended up removing this, and it had no active cancer in it. It was just all fibrotic tissue scar. So the immunotherapy had managed to wipe out all of the cancer. So the questions that you want to ask, and I'll go through this fairly quickly, is immunotherapy better than chemotherapy for MSI high colorectal cancer, again, inclusive of our patients with Lynch syndrome? This was a trial that was designed to answer that question. If you have a new patient with metastatic colorectal cancer stage 4, is it better to start with chemotherapy or immunotherapy? And the curves, this is how much time it takes for a tumor to grow. And the green line is immunotherapy and the red line is chemotherapy. And there are 2 main take-home points from this. I'll give you 3. Number 1, immunotherapy is better than chemotherapy for our patients with MSI high colorectal cancer, and it's not even close. Number 2, there's a tail to this curve. And what does that mean? It means patients here are living 5 years plus without having their cancer grow. And that's exciting because that's what we call durable response, a response where you don't lose the effectiveness of the drug. And that's really where you want to get to, because you don't want to get a response for a couple of months and then lose that response. That doesn't help our patients as much. And then the third thing is that not everybody's responding. And so this is an area of need. There are about half the patients that do not respond to immunotherapy. So we need to do better. Combination immunotherapy, nivolumab and ipilimumab, has also shown an incredible response rate compared to even single agent immunotherapy. And I think that this is where the field is going to go in terms of adding additional immunotherapies to overcome any resistance that might exist in our patients. So your take-home points number 2 and 3, immunotherapy is approved for use in metastatic colorectal cancer that is MSI high, again, inclusive of our patients with Lynch syndrome, and immunotherapy should now be considered the gold standard, the initial treatment of choice for our patients with newly diagnosed metastatic colorectal cancer. All right, so what's new? Dr. Vogel had kind of touched on this. Well, if we know it works really well in stage 4 disease, what about earlier stage disease? And he has shown you this another immune checkpoint inhibitor for patients with rectal cancer. And this was the point that he was making, was that every single one of these patients had a complete clinical response, which means that they were diagnosed with stage 2, stage 3 rectal cancer, were given immunotherapy, and then the cancer just disappeared. And that's a pretty phenomenal advance in patients where, well, maybe we don't have to offer them surgery. Maybe we don't have to offer them radiation. Maybe we don't even have to offer them chemotherapy. We just treat them with immunotherapy and their tumor melts away. That's a very, very cool outcome. This also led to a New York Times article that led to about 1,000 different calls to our clinic about dostarlimab. But it's this group that's actually going to receive this type of benefit, right? So. What about in stage 3 colon cancer? The other slide that I showed you was in rectal cancer. This is a study trying to determine if patients with MSI high colon cancer should have immunotherapy added to chemotherapy. The question that we all want to ask is, could immunotherapy just be better than chemotherapy so that you wouldn't have to give these patients chemotherapy? This study will not answer that question. There's also another study now looking at whether or not the addition of chemotherapy in the frontline setting for stage 4 metastatic colorectal cancer can improve on immunotherapy alone. But this is still the standard of care, is to use immunotherapy. Okay, so I'm going to wrap up with this. We're going to go back to our 31-year-old female with stage 3 rectal cancer. She wants to avoid radiation as she really, really wants to have kids, understandably. And so we started with systemic therapy. So this was before the data came out with dostarlimab, which is the data that Dr. Vogel and I both showed you. So what was our best bet? Chemotherapy, right? That was the only thing that we really had at the time. So we started with chemotherapy. And unfortunately, at 2 months after receiving chemotherapy, she's got a new liver lesion. So she doesn't have stage 3 rectal cancer. She has stage 4 rectal cancer. So this is not only a failure, right, of chemotherapy. Well, now the disease is actually getting worse. We switched her to another immune checkpoint inhibitor, pembrolizumab. And there were no side effects, thankfully. We can talk about side effects to immunotherapy, later, but the MRI pelvis reveals a complete response to therapy. What does that look like in reality? And Dr. Vogel's already shown you some pretty cool pictures, but this is what the tumor looked like before. And then after that immunotherapy, this is essentially what the tumor looks like now. There's just this scar and there's just nothing there. So this patient is under surveillance, did not get radiation, did not get surgery. And so she's just on this plan where we look with a scope and look with radiologic imaging, and she's doing great. And that's all I got for you. Thank you, guys.
Thank you, Dr. Liu. All right, so we're going to have both Dr. Vogel and Dr. Liu sit up here and field any questions that you may have. And if nobody has any questions, then I might pose some myself. Go ahead. Oh, hold on. There's a mic coming. Oh, well, never mind. Go ahead.
Hi, Dr. Lee. So you started to discuss how going earlier and earlier, either in treatment or in disease course, has been pretty revolutionary when you use immunotherapies. So is that as far as we're going? One, can we go earlier? Two, considering Lynch syndrome patients have a very clear genetic predisposition, can we go into the interventional space? And can you lean on the sort of the side effects?
Yeah, thanks for those questions. Interestingly, you're very, very right. As we go earlier and earlier in stages, it does seem like immunotherapy works better than, so interestingly with targeted therapy, when we give targeted therapy, that seems to work better in stage 4 than it does in stage 1, 2, and 3. With immunotherapy, the reverse actually is true. And the reason why people are thinking that is because as a tumor gets bigger and grows and spreads, it actually develops some immunoresistance, even further immunoresistance. So it's kind of, it seems like the smaller a tumor is and earlier in its development, it seems to be much more susceptible to these types of therapies. So then it begs the question, can these therapies be preventative? There are two main issues with immunotherapy. Number one, whenever you're activating the immune system, you have the ability to create a whole host of problems that you don't want, right? And the entire field of rheumatology is based off of an overactive immune system. So what can you get? You can get arthritis. You can get a pneumonitis where your lungs become inflamed. You can get a colitis where your belly becomes inflamed. And it's not because you're dealing with an infection. It's because the body's immune system is essentially attacking itself. That's the fear when it comes to things like prevention. The other thing is that these drugs are exorbitantly expensive, right? And there's, so you kind of worry about in the preventative space, what's the most effective therapy, something that's cheap and non-toxic, and then this kind of has two problems, right, in that way. But having said that, we are looking for more and more excuses to give this in earlier lines, but the data quite hasn't caught up to our enthusiasm in regards to being able to do these therapies in earlier lines of treatment.
To the prevention question is part of Dr. Lynch's presentation about leveraging our own host immune system. So not so much a pharmacologic agent, but boosting our own immune response. And that's really the work that's being done for this really innovative and I think game-changing vaccine. And so that could be something that's, as we've all learned, something that can be distributed in a public health kind of approach. And so far in early studies is showing that it's safe, it's tolerable. And so now the studies that we're part of that are led by Dr. Lynch's colleagues are to look at actually if it works. If we give these people a series of a vaccine and compare it to folks who get a placebo in 2 years, do they have fewer polyps? Do they have fewer cancers? Our targets for prevention, not so much, early stage cancers where the patient already has a cancer.
Can I do a follow-up with you, Dr. Patel? You did a great talk on the polyp distinction. Do you think there's a way to identify the specific polyps that may lend a patient to be more relevant for an immunotherapy with new high contrast, all that kind of technology advancements.
That's a great question. So to repeat the question, sort of when we do colonoscopy, is there a way to just see which polyps, might be more amenable to certain types of interventions, or see which ones are more immunogenic versus not? Is that a good summary of your question? With the colonoscopy technology, probably not, but with the tissue that we acquire, I think there's more and more work being done to do various kind of tissue-based kind of assessments to see whether polyp tissue is different than the surrounding tissue. The different kind of advanced stages of polyps have different kind of profiles than earlier stage polyps. And what we observe is that, even when you take biopsies from patients with Lynch syndrome that have normal colon tissue, not polyps, there's sort of mismatch repair deficiency that's observed just in normal appearing tissue. And so these are some of the really early changes that Dr. Lynch referred to that happen very early on in Lynch that could be a target for this type of vaccine.
Hi, I have a question. What's the percentage of microsatellite instability high colorectal cancers in Lynch? That's the first part. And then are there any any of the Lynch gene mutations are any of those less sensitive to immunotherapy? If you know.
So, yeah, thank you for those questions. So, it's interesting when you look at microsatellite instability, it actually decreases as you go from stage. And, one of these things about these hypermutated tumors is that they have sometimes a hard time metastasizing because they can't, they're just almost too deranged, right? So they have a tendency, and John can tell you this, they grow locally and kind of become very inflamed, even just in the colon. But so when you look at like stage 1, 2, and 3, it kind of goes from 10 to 15% down to 5 to 10%. And then when you get to the metastatic setting, it's only 4% for a patient population. And I wanted to show you that pie graph because, again, starting to chip away at colorectal cancer 2 to 3%, at a time. But the 4% that are MSI high, we do offer immunotherapy, but you're starting to kind of chip away finally at that block for colorectal cancer. John had a great slide on the different mutations and some of the outcomes depending on the mutations that exist that lead to Lynch syndrome. But there isn't really a correlation there between the specific gene mutation and the effectiveness of immunotherapy, and most likely because once you're hypermutated, and again, the presumption is that it's going to work. But there are some other genes that might play a role in the effectiveness of immunotherapy that we're looking into, but these are beyond the kind of traditional mismatch repair. Yeah.
I was just going to add, we think probably about 10% of colon cancers that happen in the setting of someone who has a Lynch syndrome diagnosis don't have this microsatellite instability. Those are probably random colon cancers that maybe aren't driven by that same Lynch syndrome process. So most, 90%, if not more, of Lynch syndrome individuals will have mismatch repair instability.
We have somebody come up.
I'm curious, with all the research that's ongoing and the different studies, are there sufficient subjects, participants? This seems like a grounds for recruiting people to participate if in fact there is a need for that.
Maureen, thank you. Your check is in the mail. Absolutely. I mean, this is why we do what we do to forward the care for our patients. And there are a lot of ongoing research studies. Hopefully, many of you have stopped by and met with Liz and Sammy and Sandra, who were able to tell you about some of our Lynch syndrome specific studies. But it's a collaborative effort, right? Because here we are, several hundred of us passionate and interested about this. But it requires all of us to reach out into our own communities, get our families engaged, get our, connections and, social media, engaged and partnership with lots of other centers to truly get enough patients to answer these questions. So for instance, the vaccine trial is the first trial to look at whether it actually works. It's 14 centers across the United States to get enough patients to really answer this question. So there's a lot of enthusiasm to participate, but it still requires commitment from our patient communities, which we know is donated time. Everyone's here on a Saturday, and Wes was telling me earlier about how busy, his job is. And, I know that, this is really a generosity that our patients provide to participate in clinical trials. And I'd love to hear, Chris, your input as well, because I know you engage in research a lot in the oncology space.
Yeah, Dr. Vogel and I were able to show you that incredible data was dostarlimab and the 14 people who had 100% complete clinical response rate. GlaxoSmithKline is the maker of dostarlimab and has a trial now exactly in that space, but it's an international one encompassing essentially 300 different sites. And so it's hard. It's hard to capture a small, part of the population and then have those patients be enrolled in the clinical trials or interested in clinical trials. And again, just to echo Dr. Patel's point, this is the group that really can make a humongous difference. You guys are raising awareness. You're passionate about this. Again, you're here on a Saturday. And this is what we need really to move the field forward. And it's what makes it so difficult, but also at this point with a symposium like this, very feasible.
Do we have time?
Yeah.
So I have a question. And I was diagnosed with colon cancer 10 years ago. And at the time I was offered a trial for statin use to prevent recurrence. But then by the time I was eligible to sign up for it, there was inadequate enrollment and we were no longer offering it. Do you know if statin use, like where a statin is used as prevention? Do you know what? I didn't really follow what ended up happening with that study because I didn't enroll.
So thank you for that question. It brings up 2 points, right? One about statins, which I'll answer, but then 2, the difficulty sometimes of prevention trials. And this is where, again, preaching to the choir, we just need more participation, right? And these studies are done in a setting where there's very, very, I think, low risk for harm. And we can answer some really, really critical questions. I know Dr. Wood would agree with this statement, who's sitting in the back. Statins are really interesting. They're thought to be somewhat anti-inflammatory. And so there's been a lot of interest in regards to statins and prevention for cancer. A lot of the data, at least in the GI space, has been more with liver cancer than necessarily colorectal cancer. I think, the answer is there's no clear answer. And so therefore, right now, we don't offer statins for primary cancer prevention or even secondary cancer prevention. But the simple fact is that we would need a really well-done trial to answer that question. But there is a lot of interest because there seem to be those properties that would impact not only colorectal cancer, but other cancers as well.
I actually have a question for Dr. Vogel. You mentioned something about some people choosing to do prophylactic surgery, and I was wondering how often you actually have that kind of uptake and whether or not this particular population would benefit from considering that.
Well, it's not a common situation. It's unusual, and it just takes, the right scenario. This patient that I was talking about is somebody who had a lot of anxiety about doing colonoscopies. It was very difficult technically to do a complete colonoscopy. I learned during her operation that she had a very elongated and twisted colon. And so, it's always just risk versus benefits. And, for certain individuals, and I think some of it is based on their age, their genotype, how difficult surveillance is, their compliance with surveillance. But for some people, it makes sense, but not for all. And so we just, it's one of those situations where we just work very closely with the patient to find out what they want to do. In this particular case, the patient was very keen on doing it to avoid having the bowel prep and colonoscopies. So that's it.
As the doc who does colonoscopies, I will say that I sent Dr. Vogel that patient because, again, as we talked about this morning, what are we trying to achieve when we do colonoscopy? If it's not going to be a complete procedure, a procedure where we actually find polyps and take them out, we're not really achieving our objective. Or if the patient's not coming but every 3 or 5 years because they dread the process. And so I think in that scenario, we can either continue the dogma of throwing the guidelines at them, and saying, come every 1 to 2 years, come every 1 to 2 years, or we can think a little bit outside the box. And it is admittedly outside the box to do prophylactic colectomy for those who don't have cancer, but one that with kind of multidisciplinary collaboration for certain scenarios, as Dr. Vogel said, might be the best solution for a specific patient if we're not actually achieving what we want to with colonoscopy.
Swati, can I ask you, is there any role now for non-invasive testing or screening for colorectal polyps or cancer and Lynch syndrome?
It is a really, really great question. I want to hear Dr. Lynch's input as well. There's a lot of interest in this. So what Dr. Vogel's referring to is we know that, as Dr. Lynch also mentioned, that colonoscopy is not necessarily perfect. And so looking at other biomarkers, stool-based markers, blood-based markers, there's ongoing clinical trials looking at this as adjuncts to kind of, in addition to colonoscopy, see if these things can pick up additional cancers. They haven't quite made it to prime time yet, but what I will say is just because of circumstances and lack of kind of colonoscopy capacity during the COVID pandemic, the group in the UK through the National Health Services actually implemented a stool-based program for Lynch syndrome patients because they couldn't get them in for colonoscopy. They gave everyone FIT tests, fecal immunochemical tests, and if they had a certain amount of blood in their stool, microscopic, those patients were ushered urgently to colonoscopy. And so it wasn't sort of replacing colonoscopy in any way, but it was a tool to help provide risk stratification to really call out the patients that need it right now. And so there's now multiple studies that are looking at some of these types of adjuncts. But Pat, what's your perspective on the role of non-invasive surveillance?
Well, I think it lends itself ideally to the design of a trial. And I think we've talked a little bit about this. Many of us feel that we're doing too many colonoscopies too often with too little yield in terms of completely preventing colon cancer. So I think a trial, for example, randomizing people to a baseline and then a longer interval with non-invasive testing in between versus a shorter interval, and then just do a non-inferiority thing and just see, are the people that are having some other form of non-invasive screening, exact type tests or something like that in between. And if it's positive, well, then we go ahead and do it at 1 year, even though we weren't planning to for 3 or so. I think lends itself ideally to a trial. Now, at one point, not that long ago, people would have said, oh, that's unethical because we know that it just stands to reason doing it every year makes sense and is going to work better than 3. But the data from Europe turn all that upside down and really call into question, the efficacy of it. And so I think we're back to kind of a point of equipoise in terms of the benefit of frequent surveillance. So I think that the ground should be wide open for a trial, which would be very easy to design around that. Having said that, yeah. So, but I do have one question, and my apologies because I'm rather deaf and may have missed a question that kind of already asked what I was going to ask, and you may have already kind of answered it. But you showed some data on these patients with rectal cancer that had complete response to immune checkpoint inhibitors, and I didn't catch all the details of those, but I'm guessing that many of those were patients that had potentially resectable disease, following chemoradiation and so forth. But because of concerns about maybe they're going to wind up with a colostomy or maybe they're going to have problems with the XRT effect, the thought was, well, let's go ahead and try a checkpoint inhibitor, and it worked great. So these were people where there was some reservation possibly about doing an operation. And as you guys both know, there are many situations where we've kind of taken a chance on a very promising chemotherapy in a group of patients that we kind of really weren't that excited about operating on. And then ultimately we wind up calling that definitive treatment. So my question is mission creep. So let's say we have somebody that's got low stage, right colon cancer, chip shot surgically. Okay, right hemicolectomy extended or not, I don't care, but chip shot surgery. Maybe they've got a lymph node or two, maybe not, but it's going to be an early stage standard case for surgery. But gosh, this pembrolizumab and related agents work so well. Patient's not real keen to have surgery, or maybe has got some comorbidities that give you second thoughts. I'm going to guess we're kind of maybe already doing that occasionally on an opportunistic basis, but is there enthusiasm on your collective parts about that, or is that a third rail we shouldn't be talking about yet, or what?
I think we should be talking about it. There's no real very low risk surgeries. As a patient once told me, the only low risk surgery is a surgery that's not being done on them. It's coming. I have to think it has to be coming. Why wouldn't you treat a colon cancer that's MSI high or has mismatch repair deficit with pembrolizumab? It makes sense. And so I do see it coming. And with rectal cancer in that trial, the aim was not to do non-operative management. The aim was to treat them and then restage and then use chemoradiotherapy and then see if there was complete response and then maybe do non-operative management. But the immunotherapy was so effective, they never even got to the radiation. So it makes perfect sense that a sigmoid colon cancer in the future that's MSI high is going to be treated with pembrolizumab or a similar drug, because it just makes sense. And so then it'll have to be like a lot of things to think about with it, but it's got to be coming, right, Chris?
Yeah, I completely agree with Dr. Vogel's comments. It is, those trials are being designed and one is currently open and enrolling. I think it's a little bit of a trade-off between obviously a highly effective agent, but then the surveillance, right? And I did put up that slide in terms of what our patients go through when they do non-operative management. It can be sometimes intense. And so if you are having to get a colonoscopy every 3 to 6 months, that's a big ask, right? Those things, they come pretty quickly. So somebody may just throw up their hands and say, I just think I'm just going to get the surgery, right? And some people will be like, well, if I can avoid a surgery, then I would be willing to get that type of, pretty intense surveillance. And that's where, what used to be maybe a 5-minute discussion now is going to turn a lot longer, but it should, because there are options and that's fantastic, but they really need to be discussed in the context of, well, what are our patients' goals? And then how can we best meet them with those available options?
Well, and a kind of a related question, one of my concerns in like developing a trial of, looking at different intervals of colonoscopy, and I wonder if one of the things is, might we ultimately get more cavalier about our surveillance if we say, well, okay, even if you develop a colon cancer, we've got this great rescue therapy and you're going to do fine even if you have, I worry that we're going to get cavalier about that because we've got such great agents. Even if we don't want you to develop cancer, we're going to do the best we can. But even if you do, don't worry about it. We've got something great.
I think it's such a great point. And I think we're already, I think John and I are both worried that we're already being a bit cavalier, we're really pushing the envelope with non-operative management, immunotherapy before surgery, maybe omitting surgery. And this is a pretty Wild West type feeling. We're trying to make decisions based off of just 14 patients. That gives us some pause. And so we really want to do things the right way to make sure that we're not making conclusions too soon, right? And so, just bear with us as we kind of sort through this, but we're going to obviously do this all together.
I think we have to,
I was just going to say it's exciting, but I agree measured, but it's really nice to finally start to see a lot of different options, not just on the treatment side, but also on the prevention side. Colonoscopy is not the only game in town for reducing cancer risk in Lynch syndrome anymore. And we're going to see a lot more data on those things. And that's as a colonoscopist speaking.
All right. I think we had time for one more question, but if you don't want to ask it anymore, then we can wrap up. So let's thank our panels again. So this closes our session. We're going to have a few closing remarks. And before I leave the podium, I just want to do my one joke that I promised. Why don't people tell more poop jokes? They stink.
So this has been a year in the making, putting today together, and we had, we were really excited about this and had high expectations, but I think we are all just awed by what today has been and everything that you guys have shared with us and everyone that's been here today. Today would not have been possible without the generous support of the Karen Wachtel Fund. And this is in memory of Karen Wangarud, and I hope you've met her family who's here today, Ken and Kira. Through your generous support, this has really been truly outstanding day for all of us, both as providers and I think hopefully for you as attendees being able to be here. And then a special thank you to our keynote speaker, Dr. Lynch. Truly an honor to have you be here with us today, and all the other talks that you've given, truly an honor. And we'd also like to thank all our speakers. Took time out of their day on a weekend to come and share their expertise and experience. Couldn't have been possible without you, so thank you. As well as our sponsors, and so the advocacy partners and nonprofit partners, all of you today, and the lunch session was truly wonderful to hear all the work that you're doing, all the advocacy. So Connect My Variant, Colorectal Cancer Alliance, Fight CRC or Fight Colorectal Cancer, Catch It in Time, and the Jacqueline Rush Lynch Syndrome Cancer Foundation. So truly, thank you. And then our sponsors. So our wonderful breakfast was from Grail, and they're a platinum sponsor. And then Bearing Pharmaceuticals, after we conclude, which will just be in a couple of minutes. I know it's been a long day, but there's going to be a reception upstairs on the rooftop. So we hope that a lot of you can join us and I have some beverages and some appetizers and mingle. And then our bronze sponsors, which are Janssen Oncology, Medtronic, and Myriad Genetics. And then the pearl sponsors, Cook Medical and Invitae. And then thank you to all my co-directors that have been here. We're really sorry and sad that Jess wasn't able to be here. She was supposed to be doing these closing remarks, so it seems a little stuttery. You might know why. And then truly the Cancer Center team and all their coordination and help, this wouldn't have been possible without their behind the scenes work. So if you could all stand. For Ryan and Ashley. I see Sandra. Is that Andrea in the back? No? And then Maddie up front. So thank you, thank you. And this was a first-time event for us. So we'd really love to hear your feedback. Are there other things you'd love to see at a future conference or symposium like this? Things that, time of day, day of the week, all those types of things are helpful for us to really hear from you. What are things that you'd like to hear from the medical community and give us that feedback and input?